Thank you very much, Director. Bon dia. Bonjour. Mlibwanchi. Good morning. Salam no? Yeah, thank you very much. First and foremost, just to commend the team and you yourself for a job well done yesterday. So I have some few announcements to make. Tomorrow, EXA, in collaboration with IGAD and ECONET, and the support of the World Bank, will be co-hosting the Global Health Diplomacy Workshop that will bring together the PSCs from different countries, alongside with the project implementing unit personnel and directors from the ministries of health. The goal of the objective of this workshop is to equip our PSCs with the health diplomacy's skills and knowledge that need to navigate through the complex environment that we are having right now. So the main focus will be in the area of sustainable healthcare financing through the Lusaka agenda and the Abuja Declaration lens, health security, by focusing mainly on the pandemic agreement and amended international health regulation implementation. And the other one is going to be on the right to health and how do we strengthen the South-South cooperation. So the theme for tomorrow's workshop is leveraging the pandemic agreement, international health regulation, and the right to health in advancing Africa's health agenda. So my humble request is for each and every person whom I've mentioned to attend, because this is an important workshop. It will help us to discuss various issues that will help us as Africans to navigate through the complex environment that we are here in, from communication to lobbying to negotiations to etiquette and protocols. So I hope that those whom I've mentioned, they will attend. And this event will take place at the Legas Hotel. And our advice to the teams is to leave the hotel where you are staying right now, at least at 8 or 8:30, so that we should be able to start the workshop on time. Otherwise, thank you very much, and I look forward to meeting all of you tomorrow. Asante.
Thank you, DG. So the agenda for this morning is as follows. So the first presentation will be a panel discussion on progress on accelerating health manufacturing in Africa. The second item on the program will be digital buys to enhance preparedness and response in health emergencies. Then we'll break off for tea. After tea, we'll continue with a session that we were not able to have yesterday, which is the cross-border coordination and collaboration in health preparedness. So this is how the program will run. So allow me to invite quickly to take up the first session of panel discussion. I will invite Dr. Karim Wanga from IGAD to take up the floor. Thank you.
Good morning, colleagues. Good morning. As the chair has mentioned, my name is Karim Wanga. I am a pharmaceutical expert working with the IGAD Secretariat. So I will request the panelists who are in the house to come on the stage. I'll start with Dr. Tadesse Mekonnen, who is the president of the Ethiopian Pharmaceutical and Medical Supplies Manufacturing Industry Sectoral Association. He is also the co-founder of AfriCure Pharmaceuticals Manufacturing Ethiopia. Please take a seat. Next, I will invite Dr. Rabera Kenyanya. She's the head of technical operations at Kenya Biovax Institute. Next, I will invite Dr. Nancy Ngum. Dr. Nancy Ngum is a public health expert working with AUD and EPAD, that's the Africa Union Development Agency, and supporting the Africa Medicines Regulatory Harmonization Program. The fourth panelist is Yewe Dalem Tesfaye. The name is a bit difficult. She's a senior advisor to the Minister of Health on local manufacturing, supply chain, and commodity financing. Minister of Health of Ethiopia. She's a senior advisor to the Minister of Health for Ethiopia. So we also have some panelists who are joining virtually. I'll just mention their names as well. We have Dr. Abebe Genetu, who is the coordinator for local manufacturing platform for harmonized African health product manufacturing in Africa CDC. I hope they have joined online. You can see Dr. Abebe is online. We also have Dr. Janet Biaruhanga. She's a health policy expert working with AUD and EPAD, as well as the Africa Union Commission, and specifically also working on this agenda of local health manufacturing. We also have Zito Alfayo, who is a career development banker with Afrexim Bank. I don't know whether he has joined. We're expecting him. And then we have Professor Dhiren Thakur, who is the president and CEO of Med Aditas Pharmaceutical Limited. He's joining us from the US. It must be very late night there. Thank you so much. So those are the panelists, and I will start by giving a very brief background on this panel. So as you're all aware, Africa's population is estimated to be around 1.5 billion, which is estimated to be 17% of the global population, with a median age of 19 years. We bear about 25% of the world disease burden, with a triple burden disease of communicable and uncommunicable disease, injuries, and trauma. Our government health spending is less than 5% of GDP, while Africa health market is expected to grow to about 259 billion US dollar by the year 2030. And of course, health funding is affected with a lot of political fragility and election cycles. COVID-19 exposed dependence on external supply chains, highlighting fragility of our supply chains and the need to establish local production capacities. This renewed the push for local and regional health manufacturing, and there's a strong political will and momentum across the continent. Africa pharmaceutical manufacturing sector accounts for 1.5 to 2% of the global market share, and it is estimated to be about 25 to 30 billion US dollars. 70 to 90% of medicines are imported in most of our countries, and 10 to 30% locally manufactured, mostly generic medicines. We are manufacturing mostly generic medicines. Our continent holds about 25% of the global vaccine demand, while we only produce about 0.1%. Can I use this one? While we produce 0.1% of the global vaccine supply. And in terms of trade, it's 3% of intra-Africa trade in pharmaceuticals. When it comes to regulation, we have highly fragmented medicine regulatory systems with long turnaround of approvals, and sometimes also maturity of our NRAs, low maturity of national regulatory authorities, with varying legal and regulatory frameworks. And the last one is we have limited capacity to conduct bioequivalence studies on our continent. So those are the issues that form the background and why we are all aspiring to enhance or accelerate local manufacturing of health products on our continent. So I'll start by Yewede. And my question is, policy is very critical enabler to support local manufacturing. And I know Ethiopia has done a lot. They established a Shieldvax company for vaccine manufacturing. We have capacity building at Hari Institute on bioequivalent testing, research and development. And then, of course, recently we have maturity level 3 by Ethiopia FDA. And you're setting the groundwork for vaccine manufacturing in Ethiopia. What are some of the policies, just maybe two key policies or policy action that the government of Ethiopia has implemented to promote local manufacturing, whether it's incentives or access to finance or even streamlined regulatory pathways, just in 2-3 minutes.
Great. I might be brief as much as I can. As you know, Ethiopia is a country with more than 120 million population, and each year we add to 3.2 million kids in our systems as well. So it's a huge market. We have a health facility, more than 5,000 health facility and 17,000 health posts providing community services. Looking at the market size, it's really critical for a country like Ethiopia with a huge market size to produce some of selected high prioritized life-saving commodities. As a country, we acknowledge we can't and we shouldn't produce everything in country, but we need to prioritize those with a high economic and health impacts. With that, the government has a huge commitment on ensuring that in-country production of life-saving commodities. For that to happen, we have manufacturers already in the market, and also we're working to attract direct foreign investment, leveraging a different global as well as regional platforms. For this to happen and then to realize that the government designed different physical and non-physical incentives. Physical incentives focusing on exemption of different tax, corporate tax, income tax, expatriate tax, and the like, and which helped the foreign newcomers to leverage this opportunity to design and install local manufacturing based on the government prioritized interests as well as high impact product, as I mentioned. So the government last year made a huge macroeconomic reform, which used to be a big challenge in our country. If you ask few years ago, if you ask most of the local manufacturers as well as the possible investors, hard currency shortage is the biggest challenge. But starting from last year, this is elevated and it's improving the hard currency access for our local manufacturers as well as for the newcomers as well. Liberalizing the macroeconomic is one big step, and as some of you might visit last year during the RAC meeting, we have a dedicated industrial park. So for those working within the industrial park, we have a list of additional prioritized incentive package that's implemented and leveraged by those who are operationalizing within the industrial parks. Not only that, we have a different procurement-related incentives. For example, when the local manufacturers are competing on international competitive bidding, they get a 25% price protection. And also, we have a list of items produced locally that we dedicate a national competitive bidding solely among the local manufacturers. That will help them to access the public market in a significant manner. And you might already know Ethiopia is public dominated, and we have a national procurement agency serving up to 80% of the public sector needs. So the 25 price protection when competing with international bidding, and also 30% advance while receiving the purchase order, and also the dedicated list of products solely sourced from the local manufacturers are some of the incentives that we are implementing. And of course, I'm not saying there's now a problem in the local industry, given there's a challenge on consistently implementing those incentives and leverage of those incentives by our local manufacturers. With that, I would just want to close the answers that are specifically on targeting vulnerable population. The government is fully responsible. Government, Ministry of Health, Ministry of Finance, with a close collaboration with partners, including the World Bank, fully responsible on availing life-saving commodities, specifically for RMNCH, for free at all levels, free of access of the medicines, but the government take full responsibility on the resource mobilization in the location.
Thank you very much. Please have a clap. And thank you for highlighting the issue of access, especially to for reproductive, maternal, newborn, and child health products. And I think that's a very good initiative by the government, as well as the various incentives that are offered to promote local manufacturing. So I'll come to our panelist who is joining virtually, Professor Thiren Thaka. Maybe you can switch on your microphone. And my question is, Professor Thaka is setting up a new manufacturing industry or plant in Kenya. And we would like to hear a little more about the model of this manufacturing, the product portfolios you're going into, and what is the role of technology, deploying technology in manufacturing to enhance efficiencies, as well as the use of technology for track and trace of products. Of course, once you start manufacturing, you have intention to use some technologies to ensure that there's end-to-end visibility of the products. Over to you, Professor.
Thank you, Dr. Wanga. And thank you for inviting me to this very important discussion. So we are a family of companies entitled MedEditus. Editus is Latin for access. And our overarching mission is to improve access to medicines of high quality and affordable price in sub-Saharan Africa. And we believe that, as it was already mentioned in the introduction, that the best way to really pursue this mission is to promote growth of local pharmaceutical manufacturing. As you pointed out, depending on the country, 70 to 90% of the drugs that are needed are imported from outside. And I think this has to be changed. This has to change. And our goal is to really use technology to promote growth of local pharmaceutical manufacturing. And we want to start with establishing a pharmaceutical manufacturing in Kenya. And we want to use, as you pointed out, use technology to drive this change. We are going to deploy continuous modular manufacturing, which is a technology that has evolved over the last maybe 10 to 15 years. A lot of multinationals have already started to deploy this technology to promote for them to achieve local manufacturing in different parts of the world. We believe that we can actually use this technology to achieve the same goal, and that is to promote local manufacturing in different parts of sub-Saharan Africa. This is a highly automated, compact manufacturing technology. It works continuously, and it, with a very compact structure, it actually produces very high capacity. It's flexible, and most importantly, it's scalable. So we want to. This will be the first deployment of continuous manufacturing in Africa when we when we actually go forward and build it. We also want to incorporate blockchain in manufacturing operations as well as in supply chain logistics. And I think we want to achieve this because all of our operations, both manufacturing and supply chain, we like to really have this digital. And as you know, when you have digital operations, data security and quality is very important. So to really achieve high quality both of data and products, we plan to really incorporate blockchain from end to end, as you pointed out. In manufacturing, it'll give us ability to achieve high quality sort of GMP compliance, and not only that, but transparency of the data so that we can share this with our stakeholders in real time. And in a supply chain area, as you also pointed out, we can actually achieve a chain of custody, and we can ensure that our products, from the time they leave our premise to the time they reach the patient, that we have complete sort of a control of the custody of the product and such, and so we can really avoid substitution with substandard and falsified medicines. We are to achieve this. Of course, we are pursuing a public-private partnership model. We have built a partnership with the government of Kisumu County. And with their active involvement, we have secured long-term lease on a 10-acre land. But the county government is also helping us with a number of different other aspects of our startup, including helping us secure incentives from Kenyan government, financial incentives. We also forged relationship and partnership with RAC Bank and Mr. Zito Alfayo, who is on the panel. And we have worked closely over the last year. And we are availing their very interesting sort of a facility, and that is project preparation facility. As you know, for startups, I think the initial capital is very difficult to achieve. So I applaud RAC Bank for really putting together this facility that helps startups like ours to get enough capital, of course, match with some private equity investment. But this capital helps us really conduct the bankability work that is critical before the bank would approve the full project financing. So we are already in the actually moving forward with bankability studies with a very close collaboration with RAC Bank and Mr. Zito Alfayo's team. We expect to finish this in the next 9 months, and we hope to really seek financing for the full project. In the meantime, we are poised to raise somewhere in the range of $10 to $12 million as equity capital. So that's our story, and please stay tuned. I think we are here to stay, and we really want to achieve both health and economic impact in East Africa and beyond.
Thank you, Professor. We are always happy when we hear about a new investment coming in. And I think also you are going to go into an expanded scope of products, especially oncology, medicines, where traditionally our local manufacturers have not been manufacturing. So I'll roll over to Zito from Afrexim Bank. We know that one of the major challenges of our manufacturers is access to finance. And the role of development finance institutions is very key in terms of access by manufacturers to finance. So what are the initiatives by Afrexim in designing of innovative credit facilities that are tailored to the needs of our local manufacturers, especially the small and medium size enterprises? Over to you, Zito.
No, thank you. Thank you very much for having me on this particular panel. I'd like to thank the EXA team and IGAD for inviting Afrexim Bank to participate. So first and foremost, let me start off with the big picture. As we all know, SMEs are the engine of Africa's manufacturing future. They're responsible for about 80 to 90% of jobs, local value addition, innovation, and resilience. So for us at Afrexim Bank, supporting them is not optional. It's an industrial imperative. And in formulating some of the solutions that we've come up with, what I'd like to do is just go sequentially, looking at some of the challenges that SMEs face and the responses that we've made across the continent that are moving the needle in support of the SME market. So first and foremost, when we engage SMEs, the first thing that we notice is that typically they're only able to access short-term facilities which come at a very high cost, which typically don't match the manufacturing cycles. So what we've done at Afrexim Bank is we've come up with an SME development program. Essentially what that entails is we provide medium to long-term lines of credit to local commercial banks so that they can own lend to these SMEs. And the idea is that by providing these lines of credit, they'll be able to support the manufacturing cycles, they'll be able to give sufficient liquidity so that these SMEs can put together projects that are able to be more resilient and enhance competitiveness. And most importantly, we try to ensure that the facilities available to SMEs are in local currency. Again, this significantly mitigates the foreign exchange risk. The other key challenge that we face, that SMEs face, is the high perceived risk. The high perceived risk. And again, this is due to the fact that most SMEs tend to be small in nature. They tend to have weak corporate governance structures. So what we've embedded in our SME intervention is a capacity building program. And what this means is that we typically put together workshops and conferences and seminars where we pull together SMEs, bring together experts that can educate them, capacitate them, and outline the merits of them putting in place adequate corporate governance structures. We also try to facilitate market linkages with potential either inputs. They can also get access to markets so that they can be able to de-risk their projects. And given the significant demand for this particular intervention, we're working closely with some of the regional development banks and local commercial banks in country to meet that particular risk. The other key challenge that we face, that SMEs typically face, is with regards to bankability. And as Professor Diren mentioned, we have a lot of SME developers or sponsors with very good ideas, very creative ideas. Unfortunately, some are not in a position to package them in a shape and form that can meet the stringent requirements of DFI such as Afrexim Bank. So we have this project preparation facility. And what it does is that we provide facilities whereby we assist them in engaging consultants, the best consultants globally, to put together bankable studies on the market aspects, on the corporate governance aspects, on the technology aspects, financial models, environmental and social impact assessment reports. What this does is that it de-risks the project, clearly outlines the risk and mitigants that are in place, so that when these projects are then presented to financial institutions for consideration, or equity investors, as the case might be, they're easily assimilated into the credit cycle. They can be easily approved in a timely manner, and on the back of that, we can bring more projects into the market. The other key thing that we've also done is we're trying to leverage off technology, And in that regard, we've come up with what we call the Africa Trade Gateway. And what the Africa Trade Gateway does is that it's a mix of solutions. First and foremost, we've got the Mansa platform. The Mansa platform is a proprietary due diligence platform that was conceived and developed by Afreximbank. What it does is that it is a central repository where all SMEs, consultants, or key players in the healthcare value chain can have access to information about other counterparties. It's a platform whereby stringent due diligence standards are upheld, and it builds trust. Because, for example, if you're in Zambia and you want to do business with Professor Diren's company in Kenya and you don't know the counterparties, if you go through the Mansa platform, given the fact that it's been independent, given the fact that all parties on that platform have been independently assessed and cleared and deemed compliant, it's easy for you to then reach out to them because their contacts are there to facilitate transactions, and that will also facilitate intra-African trade. And then the other key thing that we've done, and this may not speak too directly with SMEs, is our collaboration with the Africa CDC, and I see my colleague Abebe is here. What we've done is in line with the fact that we're trying to boost local manufacturing to about 60% of the continent. Afreximbank has partnered with Africa CDC, and we've put together an envelope of $2 billion. This $2 billion is to be deployed across the full end-to-end aspects of the healthcare value chain, right from coming up with projects at the project preparation stage, the implementation through project finance solutions, trade finance solutions, equity investments, risk-bearing instruments. And this facility will support the development of medical equipment, vaccine plants, vaccine manufacturing plants, pharmaceutical manufacturing plants, or any other elements in the healthcare value chain. So what I'd like to highlight to the audience is that we have an envelope of $2 billion that you can access and that you can use in order to put together local manufacturing, to boost local manufacturing capacities. We also have a collaboration with RAC, and RAC is arguably the continent's leading industrial park developer. We're developing about 12 industrial parks across the continent. What we would like to do and would like to welcome is SMEs that intend to manufacture. Instead of putting up your own plants, we've got industrial parks that are coming into the market. We can put you in touch with this industrial park so that you can actually set up shop in this industrial parks, be a tenant to that industrial park, leverage of existing infrastructure, be it water, be it electricity, ICT platforms. So it's plug and play. You can set up shop and go into straight manufacturing without having the headache of having to put together all these support utilities, which are typically a challenge on the continent. The other thing I just wanted to highlight, and as I conclude, is that Afreximbank cannot do this funding alone. The infrastructure, the healthcare gaps on the continent are significant and they're huge. And typically, we do this in partnership and collaboration with all stakeholders, be it on the financial side and the non-financial side. So Afreximbank is not just about providing loans. What we are trying to do is trying to provide ecosystems that will avail finance, guarantees, ensure that we have standards, quality infrastructure, technology, logistical platforms that are all designed to support SMEs to make them competitive and also ensure that they have a high likelihood of success. Thank you.
Thank you. Thank you so much, Zito, for the key information that you have shared with us. I hope the manufacturers have heard. We have the 2 billion facility that is out there and is all aimed at accelerating manufacturing, the partnership between Afrexim and Africa CDC. And also I think my take also was on the governance, supporting SMEs to work on their governance structures, especially to build their capacity to be able to absorb these credit facilities or finances. So let me come to you, Dr. Tadesse. I know you are one of the largest manufacturers in Ethiopia and very key in terms of access to medicines by the population. However, manufacturers still face many challenges, and I think you know them better. You can mention some of the key challenges you are facing, but what is the real ask? Because the government is here. what is the real ask to the government? Because you're also speaking on behalf of the rest of manufacturers in the Eastern and Southern Africa. What is the key ask to the government? But also you can speak about the intra-Africa, intra-regional trade. How can we unlock the trade to ensure products are moving from one country to the next, from one border to the next? Over to you.
Thank you, Dr. Karim, the RAC and the IGAD Secretariat for inviting us to this important panel. Dr. Karim, you started by saying only the key challenges and the key asks. You know that I would be talking the whole day if I start narrating the plethora of challenges that the local industries are facing in Africa. But we have no option. We have to localize our health security. We cannot import health security. We can only locally manufacture it. Really, some of the key asks that the local industries would have from the governments include creating truly enabling environments for business. That is crucial. Policy setting is one thing, but cascading it down to implementation is another. We're very good at setting policies. Our governments are good at writing policies, beautiful ones. It looks like you are promised the world. When it comes to implementation, there are so many missing links. It comes from licensing, business operation, customs, regulatory bottlenecks. In all those aspects, I think government offices should, maybe for the first time before kingdom comes, start operating like business houses with so much efficiency and with so much transparency and with true commitment to transform this local industry. So policy to practice, I think that's the first thing. The second thing is when you happen to be an industrialist in a continent which is grappling with so many economic challenges, financing is the first major challenge that you have. I think governments should be resolute and focused in helping to mobilize resources, both locally, regionally, and internationally. Every country has, I believe, development financing institutions. For example, my own country has, we call, Development Bank of Ethiopia. They really need to focus on local production, especially local production of healthcare products. They should put in instruments or facilities that are affordable, flexible, with reasonable tenure, and then coming together with access to Forex. If you look at it, the development financing institutions often owned by government, established by policies, they don't look this sector critically, and investment in this sector is often not great. So I think financing is very important. The third element is, governments should support and stand in solidarity with the local manufacturers with a notion of sustainable pricing. Every time you manufacture a product and supply to the public sector, the first question they will ask is, no, your price is expensive. It is known, it is inherent in a young industry not to be exponentially cost competitive like industries from the East, like India or China. Governments, public procurers should really understand the dynamics of pricing cost when you are a young industry. You are still not paying your capex, you don't have return on your investment. Forget that aside, but you are battling with new technology. Efficiency is a challenge. You are building up the human resource, a skill base. Your processes are not optimized. You don't have automated systems. And you have to pay school fees for some of your processes. And more importantly, you don't have economies of scale. So when these things come together over time, being competitive price-wise will only be a matter of time. When there are more industries in the space, when there are economies of scale, when the processes are optimized, when quality control and assurance systems are automated, you will be very competitive. So for governments, for public procurements, the real ask is that please don't compare apples with oranges. India has paid a lot of fees to get to where they are. China has done the same. That strategic Solidarity is very crucial. We ask the governments and also continental organizations like Africa CDC to work with us, with local manufacturers, to instill the concept of sustainable pricing. If the industry doesn't survive today, it cannot thrive tomorrow, it cannot be sustainable. Health security will be just a fleeting illusion that will never realize. So I think it is critical that government should understand sustainable pricing for young, frail industry that is coming up. You know, maybe the last 2 points that we wish to raise is governments also need to work with different international and continental organizations, including the Afrexim Bank. Afrexim Bank, we had engagement with Zito and his team recently as local manufacturers in Ethiopia. All the facilities that are built there are beautifully crafted, and most of them could really speak to the issues that we have. I think government should have a mechanism to work with Afrexim Bank to ensure that $2 billion, which is sitting there, should be disbursed quickly. I think the success of Afrexim will be measured by how quickly you liquidate that money, disperse it on the ground, and that it has a return. I think that is a destination. Otherwise, you know, if we have that 2 billion sitting there for maybe 2 decades, it wouldn't help us. I'm not being provocative, but I think it is important that we have that strong message. But how does the government really work with Afrexim Bank to facilitate that money coming down to the manufacturers? The last part is Forex. Forex is still a problem in many parts of Africa. My colleague from Ministry of Health mentioned that there is significant improvement in Ethiopia. That is true. But remember, we started from a base which was non-existent. Forex was a problem. The first thing that any investor who wants to invest in Ethiopia used to fear was, where can I get the Forex? How can I repatriate my dividend? That is changing, but still we have a long way to go. I think government should put forward preferential access to Forex because still much of our materials, raw materials are imported. Finishing off in terms of inter-country and intra-country in the regional trade, as manufacturers, we feel that Africa should integrate more than ever before economically. I don't think we can unite Africa with patriotism sentiment. I think the key to unite Africa or integrate Africa is economical benefit. That should be a win-win for every citizen of the continent. Otherwise, our differences are extensive, including the legacy of colonialism. But Ethiopia manufactures certain molecules. My friends in Kenya would manufacture certain molecules. Why should we duplicate the effect all the time? If I'm good at certain molecules, it looks like somebody wants me to stop, but I'm finishing. If I manufacture certain molecules and if I'm good at certain technologies, you know, we can cascade it down to our friends in Rwanda or Kenya. I could manufacture, let's say, a molecule called telmisartan and export the bulk. And my brother in Kenya can do primary and secondary packaging, and with certain value addition can control the market. I don't have to compete with him in the same market with the same product. So that friend of mine or partner of mine in Kenya, instead of investing on the same technologies that I have invested on, can invest on another product, maybe linagliptin or whatever. And then I can take that product into Ethiopia, do primary packaging, I get it in bulk, do primary packaging, and so I think that sense of networking, collaboration, you know, eliminating this thought of working in silos and repeating everything everywhere, if it comes to an end, with the provisions and the means of the Africa Free Trade Area Agreement, the biggest Africa Free Trade area in the world, would give great opportunities. But I think we need to work together. We need to understand the strengths of each entity in every country. For that, data is critical. Market shaping, in a way, what I'm trying to say is market shaping is critical. Why do we need 25 vaccine plants in Africa where we don't have more than 50 million kids born every year? We may not even need 1 billion doses of vaccine a year, but we have 25 manufacturing plants pledged. Basically, you know, what it means is every 2 million kids will have one plant. How could we even sustain it? So I think, you know, we should not be driven by patriotism, sentiment, and emotion, but should make business sense. We need to trust each other. We need to work each other. We should be complementary than duplicating. and with the facilitatory role that the Africa Free Trade Area Agreement that bringing and opening up all the boundaries and borders, I think there's great opportunity. If we do that, we can fast track development, we can fast track technology transfer, we can fast track innovation and health security. Without that, we will be dealing with, a dream that might not come true. So I say, let's work together. We are one nation as a continent. Thank you.
Thank you. A lot of echoes on solidarity, unified approach, regional approach, economic integration, networking, collaboration, and also the key ask from the government on sustainable pricing. When they supply to the government, please look at the pricing so that they don't close shop, but they're able to grow as industry. So I'll roll over to vaccine manufacturer. Kenya Biovax, you are setting up, you are establishing your horizontal infrastructure, you are working on starting the negotiation on tech transfer as you prepare for vaccine manufacturing. I know you definitely have some challenges, and vaccine manufacturing is fairly new on the continent. It's not very new, but of course we have had veterinary vaccine manufacturing. We have a lot of history in that area. But human vaccine manufacturing is fairly new. So I would like to talk to the issue of skills gap. Because we really require skilled workforce if we have to have successful vaccine manufacturing. And what's the role of academia, government and industry to address this issue of the skilled workforce, the gap in the skilled workforce? Over to you.
Thank you, Dr. Karim. And I really do agree with the sentiments of the previous speaker, because that is what we have been trying to preach as manufacturers within this space. Allow me to speak again and just to emphasize what has been said. The integration of our markets, as it were, will be the only way we will survive. And the realization that the 10 cents that will be saved by getting a product that's come from outside of the continent versus the investment of $1 that gives the people $13 in return that the governments will have to buy for, let's say, about 10 years before they can actually now see the positive impact, is a decision that now as governments has to be made from today. Because as has been said, if I was to start vaccine manufacturing today, my vaccine will possibly be 3 times to 7 times the cost of what our governments are getting from outside of the continent. However, within 10 years' time, you'll be able to see that you're getting the returns on the investments that have been made. Now, to the question about workforce, I will still reiterate the matter about integration. So we appreciate that there are some specific skills required within vaccine manufacturing because it's a highly regulated, highly specialized space. But as you have indicated, there are certain parts of the continent that have had some very advanced manufacturing initiatives. Egypt is one of the ones that has had industries that have been doing vaccine manufacturing for approximately 100 years. We have South Africa that ventured into this in the 90s, and then they closed down and then started over again in the early 2000s. We've had Senegal that's been doing it for over 40 years. And as you've mentioned, Kenya has been doing it for over 40 years, but now in the veterinary vaccine space. So when you have a conversation around skills gap, I am of the school of thought that, number one, within our tertiary institutions, we have sufficient didactic knowledge that is imparted to our people. The only component that normally misses is the experiential learning, the hands-on experience. I strongly am of the opinion that we just need little moments, about 6 months to about a year, to upskill the people who have gone through trainings within our institutions of higher learning. Because these are the same people who, when they have an opportunity, leave the continent and go and work in NASA or AstraZeneca or Pfizer, just to name a few, and they're able to transfer the skills that they had when they were trained within the continent to do this. So when we're talking about skills, again, it is a matter of just simple upskilling, and I'm grateful that IGAD and EXA, through the support of the World Bank, has been able to provide opportunities for such upskilling. We've had some major players within the continent supporting capacity building efforts. To name a few, there's been Africa CDC itself by setting up the regional centers of excellence for workforce development that is actually coming up. We have the International Vaccine Institute that have offered scholarships for people to actually do these trainings. So those particular gaps that have been highlighted, especially, let me talk about BioVax. As I've said, we've been able to appreciate that people have the relevant papers to make sure that they can fit the general regulatory requirements for vaccine manufacturing. And we have also appreciated that with just a little bit of upskilling, they've been able to prove that what they were taught in school is actually transferable. And within that same space, I would say that I'm speaking from a point of privilege because I come from a country that has about 40 manufacturers. So we also take advantage of the existing manufacturers to have our staff go and do some learning sessions. So they based in some manufacturer space and work for a few days just to understand what the general production processes are. And even beyond that, we end up getting persons from the private sector coming into the public sector to be able to support our efforts towards vaccine manufacturing. We even have scheduled in the coming some of our staff just going to with the manufacturers of veterinary vaccines a few weeks to just start the entire production process. And I'm speaking possibly as somebody who works in government, that this is something that can be replicated for any country. For Senegal, who has had this experience, for South Africa, for Egypt, I know that there are efforts even with the manufacturers directly to see how we can be able to place persons who do not have experiential learning in those particular industries so that they can learn the entire processes, so that by the time the infrastructure is ready, they're not coming into this space without knowledge of how the processes work. In addition to that, about the role of academia, government, and industry, academia, generally, I've spoken to it. There is some very solid theoretical knowledge. However, we've also appreciated that the same notes that were being taught about 20 years ago are still the same notes that are being used now. So there is an opportunity for academia to just add 2 more modules. We're not asking for you to scrap the entire curriculum because we are products of that curriculum, but just to add a few more modules and consider having industry players coming to the universities to actually speak to the students regarding these matters. Secondly, within academia itself, there's transferability in the way some of the skills around research, development, and innovation can be utilized. We have a lot of untapped innovation within our universities and colleges that can be able to be translated if it offers commercial viability. And now this is a challenge to the industry to actually now go to academia and find out what they have. Because by doing that, you are even in a position to better your processes in the long run. Now for governments at the end of the day, I come from a country where we had the opportunity to get instant work placement as soon as you finished university. But over time, that has been something that has dwindled. And right now, getting opportunities in the workspace is difficult or next to none. And there's an opportunity for now governments to look at it as a capital investment. Because as you've indicated, our progression as a country, according to Africa Union 2063 agenda, the Africa CDC 2040 agenda, is pegged on Africa biting the bullet and saying that we will make this investment for now, knowing that it will have some roll-on effect in the coming years. Because immediately, yes, we have to deal with infectious disease outbreaks, we have to deal with education as an issue, we have to deal with food as a security issue, but investment in the people by making sure that they have placements would be something that would go a long way. Because we do have a lot of jobless skilled persons within our space. And it could also be something that through IGAD and the representatives of government that are here could consider. There are countries that have a lot of people who are trained in biotechnology. Why not consider them as experts who would come and support your industries to be able to build their capacities? I speak as a Kenyan, and I know that there are a lot of people who are currently not in spaces where they could be. And if there is a country that has a thought process around setting up a manufacturing industry, why not utilize the untapped talent that already exists within the continent to ensure that this is something that could work? We may need, and this is the model that has been replicated by the global north. You have another country come set up shop where you are, train your people, and then they go back to where they're going. And that is something that can work in the long run. I think that is it for now. Thank you.
Let's clap for Dr. Robera. So leveraging on existing knowledge, I think we all agree there is a lot of knowledge on the continent. And you say maybe it's didactic knowledge, but we need to upskill in terms of hands-on practical experience so that they have the practical skills to be able to do the manufacturing activities. And of course, the issue of innovation from our academic and research institutions. How do we tap into that? So that brings me to, innovation brings me to WIPO. Prakash is joining us from Geneva. I would like to ask, I'd like you to speak to the role of intellectual property and tech transfer in supporting local medical manufacturing. I know intellectual property is not new, but it's not a very, it's not a subject that is discussed quite often, and yet it's very important in terms of the ecosystem. Growing the ecosystem for the long term, the mid-term manufacturing capacities on our continent. Over to you. Muted. I think you're muted. Could you unmute?
Greetings from WIPO, the World Intellectual Property Organization in Geneva. I am the head of global health at WIPO, and WIPO is a UN agency dedicated to leveraging intellectual property to drive innovation in all economic sectors, including health. So IP plays an important role in driving life sciences innovation and supporting medical manufacturing by providing the incentives to attract investment, mitigate the risk of failure, and support transfer of technologies and know-how, as well as local homegrown innovation, which is what we are talking about today. WIPO's Global Health Unit spent 1 year speaking to governments, vaccine manufacturers, medtech innovators, universities, and donors to understand how intellectual property can support local manufacturing efforts and identify the IP and tech transfer needs. We subsequently launched the IP for Medical Innovation and Manufacturing Center of Excellence earlier this year to support countries to develop the IP and innovation ecosystem required to support local medical manufacturing. And this is a very critical role, and I think Dr. Rivera also referred to it, is that if you are going to transition from importing health technologies to manufacturing locally, we need to have the IP and innovation ecosystem in place to do that. We need to have universities doing R&D. We need to look at also then How do we look at challenges of ownership, IP management, licensing, and tech transfer from the university to a government agency or a local manufacturer to really scale up? And in this regard, WIPO can support NPA countries to advance their medical manufacturing goals in the following ways. We are developing a guide that will explain the fundamental differences between vaccines, drugs, medical devices, and diagnostics, and different regulatory pathways and IP strategies applicable for each type of medical technology. As some of the earlier panelists have said, one of the critical lessons from COVID-19 is that in order to prepare for the next pandemic, it is important to diversify Africa's local manufacturing portfolio to cover vaccines, drugs, medical devices, and diagnostics. Not all countries can manufacture all of these different types of health products. Therefore, it is important to prioritize manufacturing goals based on country needs, capacities, and comparative advantage to avoid countries competing to capture the same market for the same product, as my colleague from Ethiopia mentioned earlier today. WIPO partnered with the UN Technology Bank and Medtronic last year to conduct a detailed study on the role of medical devices and diagnostics in addressing the rising burden of communicable diseases in least developing countries, majority of whom are in Africa today. The study examined the IP, regulatory, medical infrastructure, training, capacity building, and financing needs of LDCs, and included a detailed case study on Rwanda. The lessons learned from country experiences and policy recommendations can go a long way in shaping your medical manufacturing strategies along the lines discussed by earlier speakers. WIPO can support your countries by developing institutional IP policies to address IP and ownership challenges between medical universities, researchers, local innovators involved in the development of new medical technologies. Moving from institutions to also SMEs, which we learned about today. So we offer IP management clinics for medtech SMEs and startups, providing about 20 companies at a time with a 4-month one-on-one mentoring program to develop their IP portfolio and commercialization strategy. This Center of Excellence also offers online training courses on IP for medical manufacturing, covering important topics such as patents, trade secrets, copyright, design, licensing, tech transfer, freedom to operate, patent search and filing, IP commercialization and valuation, and also emerging trends in AI, health, and IP. This year, WIPO conducted 2 capacity building workshops for medical manufacturing stakeholders in NPA countries with the support of IGAD and the World Bank. The first online training provided 200 participants with guidance on the practical, legal, and dispute resolution aspects of IP, licensing, and tech transfer to strengthen vaccine manufacturing capacity in the region. This was followed by a 2-day regional training workshop in Kigali on intellectual property, tech transfer, and licensing for the health sector. We went over the 2 days into a deep dive discussion, as well as had simulation exercises to provide online and practical face-to-face training, capacity building, experience sharing to build the capacity of the local manufacturers through the workshop. And 30 participants from the 6 NPA countries representing national ministries of health, medical research institutes, IP offices, regulatory bodies, and local manufacturers benefited. During this session, Rwanda's health secretary emphasized the importance of leveraging IP systems to recognize, protect, and commercialize innovation in Africa. He called for the development of strong IP frameworks to promote local manufacturing and ensure that African-made health technologies gain visibility on the global stage. In order to support local manufacturing sustainably, we need to also promote the research, scientific literature, and development of university and knowledge coming out of Africa. Global studies show that at the moment, Africa is contributing only 2% of global R&D in scientific research and knowledge. The number probably is a lot higher. It needs to be documented. And we also need to develop the IP and innovation ecosystem to really nurture the knowledge, the intellectual capacity to support local innovation in these countries so that we have local homegrown innovations. So going forward, we have requested the NPA countries to develop a brief strategy to incorporate IP and technology transfer into their national medical manufacturing projects and policies. WIPO and IGAD will continue to provide technical assistance and training to advance country knowledge and capacity on these topics. I would like to end by offering a few suggestions to our partners in the room today who are in the process of implementing complex licensing and technology transfer agreements. It is very important as you develop your licensing and tech transfer agreements to identify the right match between provider and beneficiary. It is also important to negotiate on mutually agreed terms, giving due consideration to your must-haves, compromises, and deal breakers. It's also important to draft clear legal agreements, incorporating all key terms, including access provisions, scope of license, territory, sub-license, and royalties. It's also very important to clearly define the management of IP between parties and also have dispute resolution mechanisms to manage future conflicts. It is also important to clearly define the technology transfer process and know-how, because a lot of the technology transfer fails because this is a very important point where the know-how, some of it is tangible, some of it is intangible, but it needs to be very well documented. It needs to be clearly narrated from the innovator company to the local manufacturer so that they can successfully understand what is required, adapt it to their local context, and implement it successfully. And to do that also, we must assess the absorptive capacity and other needs of the beneficiary that will be receiving the knowledge. And lastly, document operational challenges, how they were overcome, and lessons learned from others in the room to benefit from. Thank you.
Let's clap again for Dr. Prakash. Thank you so much. A lot of information, especially focusing on how we need to prioritize manufacturing goals. And I think this is very key because all countries cannot go into vaccine manufacturing. And not all countries can go into manufacturing of all pharmaceuticals or biological products. So we really need to have a unified approach, looking at country needs and also comparative advantage. And I think countries really need to come together. And Dr. Bebe from Africa CDC, I will still bring this question to you. How do we move forward with a continental approach? And then, of course, emphasis on intellectual property policies, issues of commercialization strategies of intellectual property. Freedom to operate is very key for our local manufacturers. And then the issue of tech transfer licensing agreements. I'm seeing my legal person from my organization in the room. And so when I had that point on negotiation of these licensing agreements, the do's and the don'ts. And of course, the know-how, how to analyze the know-how for both tangible and intangible knowledge. So I think those are very key in terms of IP and tech transfer. This brings me to Dr. Janet from Africa Union Development Agency, AUD and EPAD. The journey has been long, and we developed the pharmaceutical manufacturing plan for Africa, the PMPA. A lot has happened. We came up with the list of 24 priority list of products, the 24 priority list of products. I would like you to give us update. What has been the progress like, and what are the next steps in terms of advancing the PMPA? Of course, having in mind that also Africa CDC have come up with the new strategies on how to advance vaccine, but also manufacturing of other health products. Over to you, Dr. Janet.
Thank you. Thank you, Chair, and good morning to our colleagues who are live in Lusaka and those online. Greetings from Johannesburg. I'm really sorry I could not be able to come and participate physically with you, but I will bring you greetings from my senior management who are aware that I am here to talk about the progress that has been made with regard to the pharmaceutical manufacturing plan for Africa strategy and the priority medical products, the 24 priority medical products list that we adopted or developed and endorsed this year, 2025. First of all, I would like to appreciate the efforts that have been undertaken by the various stakeholders in the room and online. I've been very excited hearing about what the Afreximbank is doing, what institutions of academia are doing, what the industry is doing, what our continental sister agency is doing, Africa CDC, what the private sector is doing. So really it is, for me, it's music to my ears, having been in this space for the last 18 years, working on the PMPA. I really believe that we are making progress, regardless of the definitely sometimes quite fragmented approaches and very kind of like multiple initiatives across the continent that need some sort of coordination that is intentional, so that we can be able really to benefit from the efforts that are being put in, the investments that are being put into this sector. Something to remind ourselves of is that in this industry, it's not about health only. It's also about other sectors, like, for example, energy. We know in this industry we need energy, and energy is not cheap. So it's not about the health. When we meet in this room discussing these things, we should look at the wider ecosystem that would create those enabling environment for us to be successful, to produce the medicines that we need, that we have prioritized for the continent, to also be viable within this ecosystem. So it's important to not only look at the pharmaceutical space as health imperative, but also as a broader ecosystem issue. So I'm coming from a space where I would like to be able at one point to assess the various pillars. And currently what we've decided to do at AUD and NEPAD is to do a State of Africa pharmaceutical manufacturing report, which will be an annual report that will gather information and data on what is happening along the various ecosystem pillars of the manufacturing plan, business plan for Africa, which is the key areas we're going to be analyzing. And I did present this in our last RAC. I said we would be, as AUD and NEPAD, championing this report to be able to see what the inputs of the various initiatives that are mushrooming across the continent. Where are we? We're going to analyze the manufacturer. We're going to map the manufacturers across the continent. What are they manufacturing? What volumes for which markets? What are their compliance as to the standards? What is their compliance according to the GMP standards that have been set? We will be analyzing in our report the progress of the AMRH, for example, leading up to AMA, the domestication of the model law on medical products regulation. We will be analyzing the issues around technology transfer and innovation ecosystems. When we analyze this, and I think many of you have already talked about them, we would be coming to you to collect the information in terms of how much technology transfer is being done, what still remains as a challenge, and then zoom into how can we really strategize in strengthening these ecosystems. We will also be tracking the workforce development and skills development that many of you have talked about, many initiatives that are coming up, building workforce around this ecosystem, building skills around this ecosystem. We will be coming to you to collect that information, putting it into a report and enabling us really to track progress and be able to make meaningful investments where we can see what is coming out of our investment. We'll also be tracking investment flows and financing mechanisms. I've heard of Exim Bank. I'm sure ADB has got also its own facilities for pharmaceutical manufacturing. We really need to see all these investments that have been put forward, all these facilities that have been forward to enable the manufacturing ecosystem to grow and to be viable and to be competitive within the global scheme of things. We want to see what are these initiatives actually achieving. So we will be also analyzing those kind of initiatives and putting it in a report. Then we will also analyze supply chain resilience and the pool procurement readiness that I think our colleagues from Africa CDC are also pushing for in terms of, shaping the markets in such a way that Africa can benefit from, can move from the current situation where we are occupying only 1% of the market to increasing to beyond that, and ensuring that we are deliberate about the efforts we are putting in and that the pool procurement mechanisms that we have put forward are actually delivering results. So we'll be coming to you to collect information on how far we are with those things. And then also on policy coherence. At the beginning of my conversation today, I did mention that it's not about just health. It's about finance. It's about trade. It's about industry. It's about education, science and technology. All these policies we are coming to check how really coherent are they and how are they speaking to building an ecosystem that will make Africa really a continent where we can manufacture the priority products. And remember, we did mention that not all countries must be producing the same products for the same market, but rather we should have an organized way of doing this. Incentives must be timed, incentives must be properly targeted and really specific to how our economies are. Because as I was hearing Ethiopia mention how they have created incentives for the Ethiopian pharmaceutical industry, it is clear that they are targeting what they have within the Ethiopian market. But think about IGAD, for example, think about the COMESA region and begin to see how we can target the bigger markets, how we can use the SEFTA, for example, to coordinate the way we frame our markets, the way we frame our incentives. And we are happy as African Union Development Agency, NEPAD, within the framework of the 24 priority medical products that we're really pushing for, to make sure that systems are built intentionally to enable us to improve the capacity of our manufacturers to produce these 24 products and deliver them to the various markets that are being created through your efforts as different stakeholders. We will do this with the support of our partners, definitely, the African Medicines Agency, the Africa CDC, the DFIs on the continent, plus our global partnerships that we are creating as we move forward. Lastly, I would like to welcome the IP, the person who spoke about IP. We're developing an IP accelerator, and I think we have already spoken to the colleagues in WIPO, whereby we will be, through the IP accelerator, reaching out to the pharmaceutical manufacturers associations within the continent to work with you to identify exactly who should benefit, who can benefit quickly from this accelerator, where we'll be training and raising awareness about the importance of intellectual property and how it relates to production of new medicines, production of absorption of new technologies, and investments around technology transfer. Understanding awareness of what is out there, how can they benefit from registering intellectual property, from what do they know about patents and all of that, especially for those who want to enter the production of new formulations and more complex formulations. So I'll stop it here for now and just really thank IGAD for always involving the AUD and NEPAD in your conversations, and look forward to an IGAD program that will really trigger improvement in the manufacturing of medical products across the continent. And within, to answer the question with regards to the new frameworks that Africa CDC is bringing, we're really happy to see that a lot is going on within the Africa CDC to focus their attention on manufacturing of medical products, but we do believe also that there is a lot more that the African Development Agency, NEPAD, can add, especially when it comes to the other elements that are beyond health. And that is why I keep focusing on how else can industry support, how can we improve access to energy? We talk about access to finance, but how about access to energy? It's not cheap. Maybe that's why we're not manufacturing competitively in the continent. We need to bring other players in the room, from industry, from trade, from those in charge of electricity, energy, and all of that. So, and water and all that. So I think today I'm convinced that the more momentum we're building around local production, the more likely we're going to get all the stakeholders in the room. And so for me, this is really music to my ears, and I really, really congratulate all of you for having brought this meeting together, and look forward to a successful outcome in the next 2 days. I'll be leaving the meeting and going to another one in 2 minutes. So thank you very much for giving me the opportunity to share what the Outer NEPAD is about. Thank you.
Thank you so much, Dr. Janet. A round of applause for Dr. Janet. So a lot of emphasis on looking at the ecosystem beyond the health sector. Of course, industry trade is very, very important. And recently, I attended a meeting in Kenya where all the permanent secretaries of the key departments of health, industry, investment, energy, they're all coming together to discuss the issue of local manufacturing. So it is an issue that is beyond the health sector. It cuts across other sectors, because the utilities and manufacturers know this very well. Energy and water, that two key utilities that you cannot manufacture medicines without. And of course, cost of those utilities is very, very key. So I'll just roll over to, and of course we look forward to the report, the State of Africa Pharmaceutical Manufacturing Report that AUD and NEPAD is going to produce. And I think this is going to, embed the issue of accountability mechanisms and to track progress on how the sector is moving forward. So let me come now to regulatory. Regulatory is at the center of local manufacturing. As you have all heard, this is one sector that is highly regulated for obvious reasons, that these are medicines and these are vaccines and these are medical devices. They are highly, highly regulated. So regulator is at the center of all this discussion. And as you may be aware, we now have the Africa Medicines Agency, fully operational. Not fully operational, but we have the DG in office, and we are all excited about those developments. However, before the Africa Medicines Agency has come into being, we had Africa Medicines Regulatory Harmonization Program under AUD and NEPAD, which has laid the foundation and has done a lot of work. And I think the DG recently has committed that she's going to create an office for SME to support local manufacturing. So I would like to request Dr. Nancy just to speak onto regulatory harmonization and how it's going to support local manufacturers. Over to you.
Good morning, everyone. Thank you, Dr. Karim. I also want to take this opportunity to thank the IGAD Secretariat for inviting AUD and NEPAD to this very important meeting. And as already indicated, I think I'm going to start with a background of what the African Medicines Regulatory Harmonization Initiative is all about. We recently just heard from Dr. Janet about the pharmaceutical manufacturing plan. So when this plan actually was, the decision by the African Union was made to develop the pharmaceutical manufacturing plan for Africa in 2005, there was then a need to create an enabling environment for regulatory harmonization in Africa, because if we have the manufacturers manufacturing the product and they are not getting to the market because of our fragmented regulatory ecosystem, then that was going to be a challenge. There was now the need to establish the African Medicines Regulatory Harmonization Initiative to actually provide a regulatory environment for Africa. And the vision for the African Union is that we have the 55 member states, and as Karim indicated earlier, they were all operating at the fragmented ecosystem with sometimes weak regulatory framework. So there was a need to actually unite and implement the AMRH initiative through the regional economic communities, where the 55 member states are divided into the 7 regional economic communities who are now implementing the regulatory harmonization initiative. Actually, we have COMESA and the North African Initiative, who are the new regions on board. All the other regions are actually implementing the regulatory harmonization initiative at different levels of maturity. And with the establishment of the regulatory harmonization initiative, we were able to actually recommend about 500 products that have been recommended through the regulatory harmonization initiative. They have received about 803 applications and more that have come through these regional blocks, and about 500 of these applications have actually been recommended for marketing authorization. So when we talk about how harmonization and convergence is accelerating the local manufacturing in Africa, we can look at the fact that this is a streamlined regulatory approach where we have countries in the regional blocks receiving one submission, having to review them in a group, which means one review, and then we have one response to the manufacturer, which then leads to a recommendation that is made to the manufacturer. So what does this mean? It means less cost to the manufacturer, and also we're reducing the time that it takes to recommend these products to the market. Actually, with the timelines, we have seen significant reduction, given that there's a target timeline of 210 days. If your application goes through the regional harmonization process or through the continental process, which is now the African Medicines Agency, from when the application is received at the regional body and when it is recommended, it takes 210 days. That's the recommended time. And when the applicant now sends the application to the country of interest, the target time for the country to actually grant marketing authorization is 90 days. So this is a significant benefit to the manufacturers and the local industry to reduce the timelines. Also, there is a key benefit where we have the market, because your product can be marketed in all the countries of interest after it's received a regional or a continental recommendation. And this is very key to the local manufacturers, because if you're a small manufacturer in one country and you have access to the entire Africa because your product has actually been reviewed at the continental level, which is now going to be the AMA, then you have access to the market. Also, we're looking at the issues of human resources. Through regulation, there's been a lot of expertise because it's working on resource pooling. And so the regional processes and the continental processes are very stringent. And because the aim of the African Medicines Regulatory Harmonization Initiative was to ensure safe, effective, and quality medicines to the patients in Africa. So through the stringent regulatory frameworks, we are sure that the products that get to the patients in Africa are of good quality. We have pooled resources through the regional blocks, because all the national regulatory authorities might not have all the capacity needed. So there is a need to actually pool the best from these countries, and they come in to review the applications that are being received. So recently, as Karim mentioned, the African Medicines Agency has been operationalized to pressure test the system. A continental listing was conducted through the AMRH program, and we have about 12 products that have been listed continentally. Out of the 12, we only have one manufacturer from Africa. So that's a call for concern because we also had other local manufacturers that applied through the continental processes, but they were not able to qualify, their products were not listed. So as Karim has indicated, the director of the African Medicines Agency is very keen to support the capacity of local manufacturers and has actually promised during the last scientific conference on medical products regulation in Mombasa last week that she will be setting up an office in AMA just to support local manufacturers. So indeed, we have the regulatory framework that is working, and as you know, these regulatory pathways are actually focusing on prioritized products. So it's not all the products that go through the regional systems or through the continental. There is a scope of products that actually goes to the system. So the manufacturers in the rooms and those who are not here, you're actually called upon to look at the scope of this product and see if your products actually qualify. Then it will be a very good opportunity for you to use the regional platforms or the AMA convergence platform for your product so that you can have access to the whole of Africa, all 55 countries at once. So you are spending less time, less review processes, less responses if there are queries. It's only one response that you have to respond to the query. So thank you very much for the opportunity and looking forward to working with all the manufacturers in the room. Thank you.
Let's put together a round of applause. So key takeaways, 500 products recommended through MRH programs, both at the regional economic communities, the RAC, and the continental listing. We have streamlined regulatory pathways at RECs, but also through the MRH program, now AMA, where we have one submission by the manufacturer, one review by the experts, the pool of experts, and one decision or recommendation, which is taken up by the countries. Turnaround time has been reduced to 10 days, 210 days full assessment. And after the recommendation, countries within 90 days, they're able to register or issue market authorization for these products. And then of course, capacity building of the regulators through the expert working groups and the technical working committees. And then continental listing, 12 products have been listed continentally. And I think many countries have already adopted this decision to issue market authorization for the 12 products. So a lot of progress, and we're all excited about the new agency on the continent, the Africa Medicines Agency. Thank you so much. So our final or last panelist is Dr. Abebe from Africa CDC. He's the coordinator of the initiative on local manufacturing of health products. Dr. Abebe, the main initiatives by Africa CDC to accelerate local manufacturing. There's a platform for Africa vaccine manufacturing, Africa Vaccine Manufacturing Accelerator Program, AVMA. There is harmonized health products, platform for harmonized health products manufacturing. There's Africa Pool Procurement Mechanism. So many initiatives by Africa CDC. The question is, how can our local manufacturers, especially the small and medium enterprises, benefit from these initiatives? Or how are they already benefiting from these initiatives? Over to you, Dr. Bebe.
Thank you very much, Karim. Good morning, colleagues. First of all, apologies for not joining you in person in Lusaka. And thank you for inviting us, Africa CDC, in this RAC meeting. And special thanks also goes to the World Bank that has been behind this initiative and also supporting Africa CDC in moving the agenda of manufacturing on the continent. So it's not easy to be the last speaker after we have been sitting for an hour and a half. So I will be very brief. So I think more or less you have heard from the previous panelists in terms of what Africa CDC has been doing in this space for the last, I would say, 5 years. So it started during the COVID-19 pandemic, and it started with a decision of the African Union heads of state and government to establish the Partnership for African Vaccine Manufacturing. So we set up the bold ambition and goal of manufacturing 60% of our vaccines by 2040, and we developed a continental strategy supporting vaccine manufacturing. So we wanted to take it end to end. So everyone here spoke about a specific aspect of manufacturing. So for us, there is no silver bullet for successful manufacturing ecosystem on the continent. So we need to address all of the enablers of manufacturing, and we need to do it end to end. That's why we have been working in the research and development. No one touched about research and development. Workforce development. We have been working on technology transfer. We have been working on supporting regulatory strengthening in partnership with our colleagues, MRH, and now AMA. Financing is another critical factor. And lastly is market. So we did 2 rounds of assessment of the vaccine manufacturing ecosystem over the last 2 years. And the result of the assessment is that manufacturers have done infrastructure development, some of them have done technology transfer, and some of them have done the workforce development. But the biggest success factor no one has addressed so far is market. No one knows exactly how the vaccines coming out of African manufacturers will be procured. That's why we decided to establish the African Pool Procurement Mechanism. So the African Pool Procurement Mechanism is like any other pool procurement mechanism, continental, like PAHO or the Global Fund or UNICEF, in terms of addressing challenge, but it has also unique features. The uniqueness of the African Pool Procurement Mechanism is that in addition to increasing access to health products by member states, we would like to support manufacturers, African manufacturers. So the whole idea is to pull demand from the fragmented 55 member states of the African Union and procure products for member states by prioritizing African manufacturers. So if you notice in the previous discussions, whether it's financing or technology transfer or workforce development, the biggest risk of success is fragmentation. So you fragment workforce development, you will not be successful. Fragment technology transfer, you don't do in silos. So fragmenting market means manufacturers won't have really sizable orders so that they cannot really reduce the cost of goods and the price of products. So our goal is to pull demand of the 1.5 billion people of the African Union and procure products targeting the African manufacturers. That's one of the success factors for India, for example. India is kind of one market, of course, a federal system, but one market of 1.4 billion people. So we would like to harmonize trade, harmonize procurement, harmonize regulation. So where are we now? So we started it almost 2 years ago with a decision of the African Union. We set up a team, and we have been engaging with member states, regional economic communities, other pool procurement mechanisms, the likes of the PAHO revolving fund. And now we have completed the design of the African pool procurement mechanism. So the African pool procurement mechanism, in terms of the design, it has several components. The quality assurance component, for example, that we have been working with MRH and now with AMA. The financing, we need to have a proper financing for the African pool procurement mechanism, both in terms of seed funding to set up the APPM and also capital funding. So we're looking at a capital fund of about $300 million when the APPM becomes mature, so that we will have financing to support the cash cycle, so that member states may not be necessarily paying upfront for the products that we will be procuring for them. Rather, they can pay later. We will use a capital fund to support the cash cycle. In terms of how we're starting the APPM, we have 3 phases: the startup phase of the APPM, the consolidation phase, and the maturation phase. At the beginning, we don't like kind of take off heavy and crash. Rather, we would like to take off light and cruise. So the idea is to go for a selected list of products for a selected member states of the African Union. That's the startup phase of the APPM. Luckily, the United Nations Economic Commission for Africa, UNECA, has been working on this space, trying to establish a pool procurement mechanism for the IGAD countries. And we made agreement with UNECA that we take over the UNECA continental pool procurement mechanism and integrate it as the startup phase of the African pool procurement mechanism. When the time comes, we'll expand the product portfolio and also the member states that will be procuring from the African pool procurement mechanism. So as we speak, we put out the first tender last month, and we're very much excited to procure products, SRM-NCH products for primarily IGAD countries, but also other non-IGAD countries. And then we will be also putting out other tenders as we go. And that way we will operationalize the African pool procurement mechanism. We have been working with member states and regional economic communities. With regional economic communities, we have a consensus that we have differentiated product portfolio. We don't want to be in the space of the RACs, PPMs, and national procurement agencies. Rather, we would like to focus on a selected product portfolio so that we complement each other rather than compete. So that's pretty much it in terms of where we are with African pool procurement mechanism. But for us, as I said at the beginning, we would like to take it end to end from research and development through workforce. By the way, workforce development, we established the regional capability and capacity network of African institutions to localize training. And now, as we speak, we selected the first batch of interns who have been placed to 3 manufacturers, vaccine manufacturers, for the coming 1 year, so that they will have practical skills. They will learn practical skills from these manufacturers, and they will go back to their countries and their manufacturing companies. And then we have also in-service trainings, short-term trainings, and so on and so on. But I call upon partners really to come together and synergize rather than fragmenting the ecosystem. We don't want everyone to give vaccinology course everywhere. So that's the call for partners. And we work closely with RACs, including IGAD, and we look forward to working together to operationalize the APPM. It's really a game changer in terms of supporting African manufacturers. Thank you very much. Over to you, my brother Karim.
Thank you so much, Dr. Bebe. Another round of applause. So as we come to the end of the panel, I think Dr. Bebe has brought out key issues on the implementation of the Africa Pool Procurement Mechanism, which is, from our view, it's going to be a key instrument in terms of market shaping and market aggregation. And of course, we encourage our local manufacturers to take up this huge opportunity and be able to supply through the APPM mechanism. And also, he has announced that the first tender has been published, and I think now it's up to our local manufacturers to grab that opportunity, as well as the regional capacity and capability networks for localized training. And the first batch of interns have already been selected to participate in hands-on training. Of course, also he emphasized the other issues of end-to-end approach in terms of capacity building, looking at all the enablers for support to local manufacturers. So this topic is very hot topic. We could talk the whole day if we had time, but because we have 1.5 hours to address, I think I request that we close it here, and I would like to sincerely thank our panelists, especially those joining online from the US, from Geneva, from Johannesburg, Addis Ababa, and everywhere else in the world. I think we really, really appreciate your commitment to join our panel. And also our panelists who are here physically, thank you so much for participating on the panel. Thank you, and hand it over to the chair.
Thank you very much. Have a good day.
Thank you so much, Dr. Karim, for that wonderful Thank you for the wonderful session, which was very insightful. We'll move quickly to the next session, which is digital-based buys to enhance preparedness and response in health emergencies. We'll have 3 presenters. From the World Bank, we have Matthew Thomas. From Rwanda, we have Clever Kayawosi. And EXA will be represented by Ayabare Timoth. So the 3 presenters will each have maximum 7 minutes to make their presentation, so that we leave about 6 minutes at the end of their presentations for plenary. So allow me to quickly invite Matthew Thomas to make his presentation, 7 minutes.
Thanks very much. Hi folks, I'm Matthew Hulse. I work with the World Bank, and I'm honored to be here today with so many distinguished representatives to talk and open this session on digital health. Right before I begin, I just want to make sure I've got my logistics right. Is there a clicker for the presentations, or how does that work? Okay, great, thanks. So I wanted to speak briefly. We've heard so much, and I had the honor of joining the Community of Practice event on digital health research and knowledge management that met earlier in this week. And we listened to many of the challenges. We also heard them from the distinguished high table yesterday on challenges around interoperability, digital capacity, fragmentation, and the role of how digital systems are necessary to deliver resilience and be able to rapidly respond to health emergencies. I'm pleased to be able to speak for about 7 minutes on this topic to inspire some of our thinking and also see how we can guide our investments to tackle some of these challenges that we've been facing. I know it's quite a unique opportunity, so I just again wanted to offer my distinguished thanks to invite the World Bank to lead and join in some of these panels. So let me begin by just saying that there are several health sector use cases that are driving digital transformation within our systems. Some you see on screen here, such as using digital tools for financial management or optimization of the supply chain, getting the right product at the right place at the right time, or for our digitally enabled health workforce who are expecting timely pay, continuous learning and skills from some of the tools and beyond. Let's go to the next slide, please. We also know that digital tools are driving quality and continuity of care, connecting patients across the care system. We're using them to monitor and measure climate events so that we can anticipate risk and adapt our health system's need. And a key topic that we're all around here today, to digitally strengthen public health surveillance and response, giving us faster signals so that we can have a smarter response. Let's move to the next slide, please. Thank you. So this is often what we think about in terms of when we think about a digitally enabled piece of a smart dashboard with lots of information coming in. On screen here was the Johns Hopkins coronavirus COVID-19 monitoring dashboard. But let's go to the next slide. This is often what it actually looks like in practice, though, in a lot of the health systems that we're working on in the world. This is a picture of the information management and case workflow from the Liberia Ministry of Health during the 2015-2016 West Africa Ebola outbreak. And on screen, there was data coming from all types of sources and signals. The emergency response labs, the dead body registries, the emergency operations center, contact tracing teams, Ebola treatment units, logbooks and spreadsheets, and all those blocks have arrows flowing of who's approving what piece and what came in a Microsoft Excel spreadsheet or a PDF report or a dashboard, who approve that notification went to the next level. And when we talk about adding digitalization to improve these systems, it's often both a human and technology process that we want to optimally design. The digital tools themselves are not necessarily going to address these challenges, but they might be able to support optimization or efficiency and getting us faster responses in what the real situations look like. Let's move to the next slide. Thank you. And apologies here. It wouldn't be a digital presentation without a few technical glitches, right? So we also know the reality of what's been happening on the ground, and that there's actually a proliferation of digital tools, sometimes often covering the same use case, whether it's border surveillance, supply chain management systems. They might also not necessarily be at national scale. Over 15 years ago in Uganda, we knew that there was actually a moratorium on additional mHealth tools because there were over 100 pilots happening in different areas of the country with different pieces with different interventions that they were addressing. Or we know that from only 2 years ago, our colleagues at the World Health Organization did a large survey of different platforms that were rolled out across Africa that have reached somewhat national scale, knowing that broad coverage and use is actually still really hard to achieve in terms of the number of facilities that can be covered, the amount of clients that can be served, but there's still so many systems that are deployed that we're investing in. Let's move to the next slide, please. Thank you. I just wanted to end this first part of my talk with the current state of digital transformation in the health sector. And that's to show that a lot of donor exits have exposed some vulnerability on those digital systems and tools that we are reliant on, risking some of the data pieces, continuity of services, disease surveillance that we're talking about. A lot of the legacy systems, and many of the countries in this room know that they've been dependent on some of the external resourcing and support. And we still don't have a substantial amount of on-budget support, even partial, to continue sort of their local finance or their sustainability. Since we're here talking about resilience, this is just a key point I really wanted to highlight. And we also heard and understand, we heard the need the other day around challenges with the local capacity, particularly around these topics of health information interoperability or the code bases and the software that sort of threaten their abilities to sustain. Let's go to the next slide, please. In the long run, though, and the opportunities we have in these programs and the leadership in this room, we see this movement away from trying to get out of the siloed systems and move towards a more integrated approach that's written into a lot of the projects and the leadership that we're championing. And I wanted to offer and end my talk with a few quick ways around how we can guide some of those investments to see that happen. Let's move to the next slide, please. Thank you. So on screen here is the global reference architecture for digital health. I know that our colleagues in Zambia, in partnership with WHO, are planning architectures around this. Our colleagues in Ethiopia are considering foundational registries. Countries in Rwanda, Sao Tome, almost everybody in the room, Kenya, has moved towards foundational registries and building services on top of registries and systems to deliver more functional applications and reduce some of those vertical silos. These are really strong approaches that a lot of the projects and support in this room is driving to adopt. Let's move to the next slide. In practice, it can look a little bit different. Some of the folks in this room might recognize some of the early or more modern architecture diagrams that are being done. My goal is to not walk through these, but to just show that in reality, it can be a bit unique or contextualized for each country, and the technical leadership in our ministries and the programs are helping drive this whole of health system approach, and something that we should get behind, even if our individual programmatic goals are around stronger response and emergency management and health system resilience. Next slide. The costing and financing are critical. We know that there might be a high return on investment, but it could be a long burn to get up there and start to see the costing models that show that this impact has a high ROI for the investments that we're making. It takes some time to do the change management, but it's something that we can get behind. Next slide. So let me end with my 4 recommendations. Next slide. The first is particularly around with health emergency response and resilience, really emphasizing the directionality of information exchange. Many of our digital programs, and we've seen that in here that we're investing, are looking at dashboards or sending information up reporting systems to bring them to a central level for command and control. And I cannot emphasize enough that the two-way signaling, both sending signals up and down or across, like cross-border or even between, in the One Health concepts, between ministries, providing our workforce with the ability to communicate, equally important. So this recommendation is just to not lose sight in the expectations of the RFPs, the terms of reference, the design documents, the training curriculums, that coordinating down is just as important as coordinating information up. Being able to distribute and disseminate those teams, whether they're the WhatsApp response groups or the digital tasking tools that are sending out signals. This is a key guidance on the systems that we're building that I wanted to offer. Number 2, please, next slide, is that the digital workforce capacity building has come up. We are doing a lot of capacity building in our work, from SLPDA to FETP programs to AMR trainings and infection prevention control, and we've heard the clear demand that digital capacity building should also be integrated or considered. Honestly, the introduction of digital tools did not necessarily remove the need for leadership or capacity over time. In many cases, it can sometimes increase it. We see more expectations for our informaticians, our analysts, the software engineering or visualization experts. And so the change management strategies to integrate that capacity with our clinical workforce or our rapid response teams becomes important. Next slide. On this topic of integration and interoperability, this will always hold us back. I often like to say that fragmentation is the chronic disease of digital health systems. If we do nothing, it will get worse over time, and then we're forced to take secondary and tertiary treatment plans to spend a bunch of funds to bring things together or do these big harmonization workshops. But just like chronic disease management, it's often preventative care that are some of the most effective interventions that are better than direct treatment to mitigate these pieces. So in the context of digital and information, building upon the systems that we have, using standards-based approaches where we've already got data protocols set, the platforms, wherever possible, the governance working groups, the technical working groups that are communicating across ministries, agreeing on the standard forms, leveraging the good governance and good policy and the technical working groups we have is some of the best investments that we can make on this. Next slide. Lastly, I'd wanted to really emphasize on data standards. Data standards in the context of health emergencies absolutely will decrease confusion among our responders. It helps facilitate this aggregation that we need. On screen are all kinds of technical standards that are being built into the systems. LOINC for laboratories, FHIR, we heard about this as a health interoperability standard, moving data between systems. Many countries are reporting against ICD 10 or 11 or the HL7 standard, putting these requirements into the digital systems that we're building and supporting, making sure that our digital leaders and our procurement officers know their relevance is very helpful. So let me end here on my last slide. Thank you. Which is just the 3 key takeaways that I wanted to share. And the first is that really it's a focus on data use versus collection or aggregation. The data use piece will drive that adoption and that impact. When people are hungry for the data around, I can get that from these systems, it will rapidly scale the use and uptake, the adoption of the digital tools that we know we're supporting, and we can see that make that difference. And the other is that sometimes our best buys are actually investing in the processes and not necessarily the solutions. Those standards bodies, those compliance events, the human-centered design processes of how are our tools used by our field pieces are really critical to iterate and make those systems work better for us. And lastly, to build on what we already have, always, as much as we can, before we go out and introduce new pieces that can introduce additional fragmentation. There's so many existing tools, the DHIS2 systems that are serving climate data, supply chain management, clinical tracking of NCD registries. We've got so many of those dashboards already, and let's continue to connect those and bring those together. I hope this was helpful and inspiring to some of the group around this talk. There's so many more stories to share on this panel and hour we have on digitalization. Thanks for letting me open it today on this, Chase, and it was a pleasure to be here. Thanks very much.
Thank you for that wonderful presentation. We'll quickly move on to Rwanda. Clever Kayabosi. 7 minutes.
Hi, my name is Gary Brecka. I'm a human biologist, a biohacker, a researcher, and an anti-aging and longevity expert, and I am so...
Good morning, ladies and gentlemen. I'll be taking you through the digital health in Rwanda, and we have the overall strategic framework, which of course the health sector falls under. Next slide, please. The day before yesterday, I lost my spectacles. That's why you'll be seeing me using the screen and the laptop. I apologize for that. So the first one is the vision of 2050. The Rwanda we want, prosperity and high quality of life of all Rwandans. With economic growth and prosperity and high quality and standard of life of Rwandans. There's also the national strategy for transformation, where all government services will be fully digitized and a single digital ID will be rolled out nationally to improve the quality and efficiency of public service delivery through trusted, secure, and resilient digital ecosystem. For now, almost all government services can be accessed digitally, including like a marriage certificate, birth certificate, and so on and so on. There's also a health sector strategic plan 5, which aims at set a comprehensive approach to applying knowledge and skills to advance health technology, like medicine, vaccine, procedure, and systems, but also to integrate cutting-edge research with innovation, health technology, supported by robust regulation and digitization. Next. In each ministry, there is a digital office, commonly known as CDO. The Chief Digital Office aims to utilize digital transformation initiative to enhancing service delivery, boosting efficiency, and fostering economic growth across all the sectors, but also that philosophy of sharing common services which are related to ICT. Next. This is a snapshot of key digital health initiatives that we do have. I will not comment on each and every initiative. I will be commenting on some of them. like the electronic medical records, where now 39% of health centers are covered and 100% of hospitals are covered. There's also the electronic tracker immunization system, integration of data within the DHIS2 platform. With this electronic immunization tracker, all immunization or vaccine data are digitized, where caregivers or other who needs may access the vaccination card digitally. We do not use a hard copy vaccination card. There's also the electronic logistic management information, where requisition of vaccine devices are requested through the system. There is also another one in the top corner, in the lower corner at my right, the community health information system, where a pool of 60,000 community health workers are equipped with a smartphone, accessing the system and populating data which can be centralized at a center, feed the hospital or district hospital up to the ministry. Next. These are major achievements under the HEPA project, which include digital point of entry screening tool we developed in assistance of EXA, which enables ultra-fast screening of travelers for public health threat. This tool was deployed at point of entries, including airports and borders, and it is being highly utilized as of now. Over 2 million travelers screened to date using this tool. And of course, it accelerated the detection. It enables quick routine surveillance, but also operational efficiency, where average traveler processing time dropped markedly, and frontline staff report fewer transaction errors. Next. Another one is the national system for mental health and NCD services, which we completed the phase 1 with EXA support. And we, once the phase 2, which is the deployment, the finalization and deployment, we expect using it for remote consultations, assessment, diagnosis, and care, to use the artificial intelligence in screening of mental disorders from community, but also using it for individual self-screening, to provide a digitized follow-up system to clients, like sending SMS reminders and calls, but also we expect it to improve the quality of supply chain by use of modern psychotropic medicine and alternatives. Of course, with what we achieved, we are not short of challenges or gaps and these include integration of data. All the data we collect need to be integrated, but also the systems need to be interoperable. Thank you very much.
Thank you so much, Karawosi. Allow me now to invite Ayebera Timoth to make the final presentation. 7 minutes.
Good morning, everyone. My name is Timothy Ayebare. I'm a senior systems engineer at EXA. And today, the presentation I'm going to be making is about digital best buys, the areas that we've observed within our region where we think if we make investment in those areas and we strengthen efforts in those areas, we'll be able to overcome a number of challenges. Now, this presentation builds on what Thomas, or rather Matthew, was actually presenting. And it's sort of a continued conversation on what he was trying to bring forward. And we've based this all the information we're going to be sharing here today as EXA has been actually based on what we've gathered from the countries, from the region, and the prevailing challenges and needs. So, first of all, what is the best buy and what have we based on to come with this? Like I've said, we've looked at what the region needs. We've interacted with countries, we've supported a number of countries, the communities of practice, information we've collected along the way, and so on. And we've focused on a small set, but a small set of proven digital solutions. There's quite a lot that we could get into, but we've chosen to focus on a small set where we are sure that if investment is made in these particular areas, we have a solid foundation to even further build on in the long run with other innovations. And these tools are specifically tailored to address the current prevailing gaps. And also this presentation will throw on an idea of how best we can adopt some of these solutions. So as we all know, our region faces a number of challenges. Next slide, please. Our region faces a number of challenges, and including outbreaks, actually, among all the challenges. And the frequency of outbreaks has actually increased. And this is not even debatable. It's something we all know, and it's part of the reason why we are here. And when information is slow, if you have low information management capacities in terms of surveillance and so on, it further frustrates the efforts in how to deal with some of these outbreaks and other emerging threats. And with this, we've come to the conclusion, and I believe all of you will agree with me, that effective digital tools are no longer an option. They are no longer to be treated as a project, but they are something we actually need. They're an integral part of our health systems. Next slide, please. So what makes a best buy? What are we calling a best buy? Exactly, I think that's now what I would want to talk about. So a best buy is, first of all, we are defining it as something that is already supported by existing national strategies, national policies, and so on. Something already at a national level, before we even get to the regional level, at a national level, innovations that are already supported, that are already regarded as effective and so on, and they've been proven to work. We have to be sure this has worked somewhere. There's evidence of these types of interventions actually producing positive results. And then two, the scalability of this particular intervention. Is it easy to scale and grow, and can we have progressive expansion of some of these innovations? And can we actually link them to existing systems such that we again now do not introduce solutions that are further fragmenting our digital health system ecosystem? And then we're also looking at the cost effectiveness. Are they affordable to run in the long run? Are they cost effective? If we make investments in these areas, do we expect a positive return on investment, and can we actually sustain that in terms of the financial impact? And another thing we are looking at is, are they useful across the region? I know this is a bit, it's a bit an interesting point, but we keep saying cross-border information sharing, outbreaks, no borders. This is where this comes in. Can we actually use them to support our neighbors as countries who can this technology be scaled at a regional level to, first of all, facilitate further and effective cross-border information exchange and so on? Next slide, please. So these are the 6 priority digital investment areas that we're calling the best buys that we are looking at. First of all, the first point we have is the early warning systems for outbreak alerts and action. This includes surveillance systems and so on. Service continuity trackers, an ability to know, to track and monitor service outages in real time, and laboratory information systems. I know on the slide it's QMS and SLIPTA, but that's not all of it. We're actually advocating for further investment in effective, robust laboratory information systems. And then we're looking at now the digital mental health and NCD screening and population support platforms, where that sort of solve the problem of ease of access. When it comes to mental health, we're looking at stigma and so on. But if you were to sort of boil down this point, what we are saying here is we are advocating for investment in platforms that help the population, the general population in our countries, actually access these services in a more effective manner and simpler. Also, regional capacity building. When we say regional, we're not leaving out the national aspect. We're also advocating for investment in actually primarily the national aspect of capacity building, but also at a regional level. Because the collaborative effort at a regional level will now help all of us learn from one another. And another point that we have is that digital cross-border screening. And let's not just look at screening, let's say digital cross-border tools in general that help us mitigate risks at our cross borders and points of entry and so on. Then, of course, national digital integration and data exchange frameworks and layers. And this involves both the programmatic aspects, but also the digital aspects. This is a very critical point. Almost all the countries that we're currently working with, this is one of their major challenges. We keep saying integration, interoperability. That investment is critical. Next slide, please. So our focus, when we say our focus is on people most at risk in crises, it doesn't mean that we are leaving out the rest of the population, but we're also advocating for tools that as much as they deal with the other populations, they also have a strong emphasis on populations that are most affected, most vulnerable, and so on. So it's not just for the populations that are vulnerable, the cross-border communities, the rural and hard-to-reach areas, and so on. But we are saying we need to develop these solutions and invest in these solutions to be more accommodative to this particular segment of our population. And we also would say we need to make sure most of these, especially the investments in essential services and running, let me see how to summarize. I want to get a way to clearly paint out the picture. But what we're trying to do is effective service monitoring and delivery. So it's not just for those populations, but for the rest of the populations, but with the context of those populations as well. And we also want to be able to track who's benefiting using extensive disaggregated data. We can have age, sex, pregnancy, but also again, with the other metrics, we're just adding this to make sure we are cognizant of the fact that there are populations that we might need to pay special attention to. Next slide, please. And the investments that we make in these areas, we should look at strengthening existing systems or having an approach that actually produces solutions that are interoperable and can be integrated into existing systems, such that we now avoid a scenario where we are creating more silos, more fragmented systems, and then and adding to actually the existing challenge that is at hand. So we look at what is existing and how can we support it and how can we better integrate with it. Also, how regionally we can now see how to integrate these systems at a regional level, or how we can share information at a regional level. Of course, each country retains autonomy over their own national systems, but at a regional level, we get a way to see how to support each other in terms of cross-border data sharing and so on. Next slide, please. So where are countries today? What's the current situation in the countries? So some countries at different starting points. We have countries that have already developed some of these tools. You find some countries have a strong leg in maybe digital lab information systems. Other countries have a strong leg in lab information systems, surveillance, AMR, and so on. So what we are basically saying is, for the countries that are strong in one area, we are not saying remove the investment, no, invest more in that area, but also invest in the other areas. And if you already have a solution, there's no need to rebuild it from ground up. Focus on strengthening that particular existing solution such that we scale it to a level where it becomes more effective to produce the results that we would want. And where tools are not yet in place, under the project, under other resources available, we can see how to now make sure we make investments that are going to give us the solutions that we need. But also, I think this is very critical to emphasize, the solutions that we're bringing on have to be able to also connect to existing systems. They shouldn't run in silos. But in all cases, we are looking at how we can better support both new interventions and existing interventions and how we can make sure they work together. So building national teams. This is now capacity building at a national level. First of all, we are advocating for investment in country ICT and health teams. I don't want to lose the word health. I know ICT is in capital, but we are talking about basically human resource capacity investments where we have sustainable capacities in our countries. We rely less on external factors, external consultants to run our systems. This is focused on digital health, but this, I think, can be borrowed across the spectrum. But specifically in digital health, we are looking at advocating for more investment in local capacity building, whereby we don't have to rely on third-party vendors and consultants and so on. And we need some of this training, the investment that we're going to make. This training, especially in the ICT sector, it has to be able to cover real-life scenarios, enterprise scenarios. This is a very critical gap. You find that most of the systems we are developing, and we've observed this across the region and the tools, they actually lack the enterprise sort of approach in terms of scalability, robust security, and so on. I also wanted to give you a snapshot. Next slide, please. Okay, thank you. So I also wanted to give you a snapshot. You remember in the best buys that we talked about something called a regional knowledge hub. So I expanded that just to tell you more about it. And by the end of this presentation, you will have a clear picture why. So of course, the other tools are also important, but in the interest of time, I'm going to highlight and so on. And we have a home for where we can make sure the lessons that protect vulnerable communities in one country can quickly also benefit others across the region. But to boil all this down into one point, there is so much we can really discuss here. Those are not just the functionalities or the benefits, but we are looking at, to boil it down, let's call it robust regional knowledge sharing and information exchange. So how is EXA supporting countries? In this particular case, we work with national teams end-to-end from design to development through the technical assistance model that is available under the project. If a country needs help in this, we are available. We work with the national teams, look at how to align some of the solutions we're going to be deploying and working with that country to make sure they align with existing policies. Next slide, please. So if we invest in this, the question is, what do we gain after we have invested in these areas? What would be the fruits of this investment? So we have faster detection, safer borders, better quality care. Even in crises, we are able to sort of support our efforts to have quality care even in the event of crises and so on. Smarter use of money, because if you have real-time data and indicators, you're able to have you're able to make informed decisions that are based on actual data, and also smart systems that last. And this comes in because now we've worked on the interoperability, we've worked on the integration aspects, we've worked on the capacity building, we've worked on the scalability, and so on. So call to action, what we are currently asking for is encouraging countries to expand or adopt some of these tools and make sure they are tailored to reach vulnerable communities and other hard-to-reach populations. And then promote systems, rather than deploying solutions that are in silos, also deploy some of these interventions in a way that they can easily be integrated and interoperable with each other, and also back the sustainability aspect. We are advocating for backing both capacity building at a national level, but also the efforts that we're currently having to have a regional sort of shared capacity building and information exchange. Thank you so much.
Thank you so much for the three presenters. At this point in time, before we break for tea at 11:30, I would open the floor for questions areas of clarification, kindly feel free to raise your hand and direct your questions to the panelists who discuss progress on accelerating health manufacturing in Africa, as well as the three presenters who talked about digital-based buys to enhance preparedness and response in health emergencies. Do we have any questions? Feel free to raise your hand. Or was it very, very clear? Yes, please. Can we have a mic, please? Oh, thank you.
Yeah, hello. Thank you. I don't know who exactly I'm addressing this question to, possibly Africa CDC. In the era of globalization, we know that like now, India is already ahead and possibly pharmaceuticals will be cheaper coming from outside Africa. How are we organized to make sure that our industry is protected to grow in the face? Because in an industrialized world, a globalized world, then products will come from everywhere. And I think that's the problem that many countries are facing when it comes to growing their industry. So how is Africa, how has Africa positioned itself to make sure that we protect the almost a very young industry so that it's able to grow in that kind of headwind? Thank you.
Thank you. Maybe we can have 2 more questions. Any other questions? So I think we had the manufacturer from Ethiopia. Where are you? Is he in the room? So the question is, how have we ensured that we protect the manufacturing industry in Africa against competition from those who are already established? Please feel free to respond.
Okay, thank you very much. My name is Stephen Juguna. I work at the Ministry of Health in Kenya. I lead the local manufacturing agenda in Kenya and also chair of the COP for local manufacturing at IGAD. On the question on how can we protect local manufacturers from imports, probably what I will do is, and I can see the manufacturer has come in, maybe I will just give the Kenyan perspective. Now, in Kenya, trade is free. You can trade, you can import, you can manufacture, depending on whether you're creating profits or not. But there are a number of things that the country has done to protect the local products. And for example, number 1 is in the Public Procurement and Asset Disposal Act. That is a law that, that governs procurement of products within the country. So what has happened is that our Public Procurement and Asset Disposal Act has actually encouraged local products by ensuring that in any tender that government puts out there, a local manufacturer will have a preference of 15%. So if, for example, an importer will import something at X amount of shillings, which most of the times is cheaper than what the local manufacturer is charging, the local manufacturer will enjoy a 15% preference, meaning that they can still consider a local manufacturer even if they are 15% more expensive than the imported product. That is a way of discouraging imports on especially products that are being manufactured within the country. Now, there are quite a number of other initiatives. For example, I know that Uganda, and probably Uganda will correct me if I'm wrong, I know that Uganda has actually even increased import duty for products that are being manufactured within Uganda. And I think it is 12%. I think Uganda has imposed a 12% duty on imported products that are being manufactured in Uganda. Again, that is a way of of discouraging imports for products that are produced within the country. The third thing that, is being done, for example, in Kenya, is that we are now having what we call the advocacy for locally manufactured products. So again, by ensuring that the people within the country understand what is being manufactured within the country and are able to appreciate, then the people will now again begin looking for the locally manufactured products and preferring them to what has been imported. So there are quite a number of things that government is doing, including government policies and even market shaping. For example, if you look at what we are doing as a country in Kenya, is that Kenya is manufacturing 220 products out of the 1,094 products within the Kenya Essential Medicines list. So what we are doing is that the largest procurer of products, which is called KEMSA, is we are ensuring that KEMSA will only procure from local manufacturers, these 220 that the country is doing. So quite a number of initiatives. I'm sure different countries have different ways of protecting the locally manufactured products. And I think it is up to the country to look at which ways work for them. But again, like I said, the manufacturer is here. Probably we could maybe hear from the manufacturer. Thank you.
Thank you so much. Do you have any addition? Anything different from what has been submitted?
Thank you. I think my brother articulated it really well, but that 15% is not enough. Take the bar higher. Ethiopia has put a 25% price preference. We still think that's not enough. We may go higher with value addition because there are so many logistical supply chain challenges that especially landlocked nations in Africa suffer from. But I think that's a great start. Many countries are including now price preference. I think the other thing is demand visibility, longer term contract. You cannot build and run a factory with a 6 months contractual visibility. I think it is time that public procurers look forward, put forward longer term contractual engagements with local manufacturers. I think a case in point is the example from Ethiopia. So for the first time, the government procurer, which is 75% of the total pharma market, has put forward a framework contractual engagement with local manufacturers that can go up to 7 years. This is a big risk taken by the government, but very promising step to be taken. So at least with visibility, with offtake, then you know how long you will survive. I think other than that, putting duty, taxes on imported goods is important, but I think we have to be prepared enough to even ban importation of certain molecules with objective assessment. If we're convinced that there is enough supply in the country, block it, ban it from importation into a specific country, just to throw those few points. Yeah.
Thank you so much. Do we have any more questions? Yes, there's a hand here. Any other hand? Or this will be the last one before we break for tea. So this is the last submission. Thank you so much.
Thank you. My name is Jeffrey from Malawi. I'm interested in an example of how the market is being segmented, where countries have to avoid competition by manufacturing the same commodities. Are we just discussing for now, looking at the future, or is there anything that is happening currently on the scene? Thank you.
It's a question or a response? Question?
Merci beaucoup, Madame la modératrice. pour m'avoir accordé la parole. Je voudrais me rassurer des dispositions qui sont en train d'être prises pour que l'industrie extérieure, l'industrie, pour ne pas les citer, de l'Inde, qui nous approvisionne suffisamment et beaucoup en médicaments. Et nous savons aussi que la qualité des médicaments que nous recevons en Afrique sont souvent douteuses. Il y a eu des études qui ont été faites chez nous en République démocratique du Congo qui ont démontré que plus de 60%, les études ont démontré que plus de 60% des médicaments que nous importons, nous consommons, ne sont pas de bonne qualité. Mais puisque nous savons les pays qui les fabriquent, nous savons où est-ce que nous les importons, quelles sont les dispositions qui sont prises dans le cadre de ce travail régional pour interagir avec ceux qui fabriquent ces médicaments et les persuader à nous envoyer ou à fabriquer des médicaments de bonne qualité. Parce que ça, je n'ai pas ressorti dans les speeches des différents panélistes. Merci beaucoup.
Thank you so much. Can we have responses from the panelists? So the first question, or the second question from Malawi.
Yes, so thank you for the question from Malawi on the issue of regional approach and preventing intra-region competition producing the same product. So Africa CDC has been convening a platform to bring manufacturers together, especially vaccine manufacturers, and having a discussion. They call it manufacturers marketplace. So they come to one platform and each manufacturer is able to share what antigens they're focusing on in a way of agreeing who can produce which antigens and having that kind of balance for the different regions of the continent. However, on pharmaceutical and biologics manufacturing, I think this discussion has not happened. We have not had an opportunity to bring manufacturers into one room where they can agree, for countries to come one room where they agree which country can produce which products. So I think that is the next step, and Africa CDC definitely should be able to take lead on this very important issue to avoid intra-regional competition. On the issue of substandard and falsified medicine, it's a big global concern that not only affects Africa, it's a global issue. One of the key things that our countries can do and our governments can do is to strengthen regulatory systems, national regulatory systems. And we start by having a very effective national regulatory authority, national medicines authority. Because one of the functions of the National Medicines Authority is import-export control. If the authority cannot effectively control import of medicines, then that's where we have a chance of substandard postal medicine coming to the country. So strengthening our regulatory authority to effectively control imports into the country. The second function is post-market surveillance. You have to strengthen post-market surveillance, where you continuously go to the market, collect samples of the medicines, and analyze the medicines to check whether they comply with the standard and specifications. And you can only also do that if you have a very certified national quality control lab. You need a laboratory that is equipped and has the capacity to be able to conduct these minimum tests to check the quality of the medicines. So those two, a quality control lab and the National Regulatory Authority, that is effectively functional, I think work together and generally the local industry association to address the issue of good manufacturing practice for our local manufacturers. Maybe Dr. Tadesse, you want to add?
It's easy to put the manufacturers on the spotlight because they speak freely, unlike politicians. Quickly, I think quality is important. At the end of the day, if our destination is access, it should be quality, access to quality medicine certifications. I think every manufacturer, if not committed for quality, I think it's better if we not push that on us. I think that's very critical. Africa and our population doesn't deserve an inferior quality product. That said, I think our regulators are growing, getting stronger, maturity level 3, 9 countries. We hope soon we'll have 10, 15 countries becoming maturity level 3 achieved or approved. But side by side, we have to be careful our quality intentions not to stifle and reverse the industrial gains that Africa is aspiring for and is achieving. I will come up with a bit later, but besides that, we have to strengthen our post-importation testing mechanisms. You look at, I can give you a very simple example. Amoxicillin was imported in Ethiopia for 1,000 capsules of 500 milligrams from China at the price of less than $10. That was about a year ago. The local manufacturers were not able to supply anything less than $20 or so. And we looked at the price of the APIs. 1 kilogram of API at that time would go for about $32. We forward induced what it means for a finished product. Actually, the local manufacturer, if they supply with the API price, they cannot even match the Chinese product. What does that tell you? So standard medicines are coming in Africa. You should start questioning, does that amoxicillin even have the APIs at the required concentration in that molecule? So I think regulators should institute without failure post-importation testing. We may, products could be registered, all the requirements are fulfilled, but when they are imported on consignment, you are not sure if they are really fulfilling the standards. So I think we need to strengthen that. On the last stretch, bioequivalence is important, especially for BCS class 3, class 4 product. But you know what it means? That we want every member state to take this seriously when we go back to offices, please. Maturity level 3 is making bioequivalence testing mandatory for private products. Much of the products manufactured locally are oral molecules. They could be class 2 and class 4. What does it mean? If you impose bioequivalence immediately on a young, struggling industry in Africa, $100,000 on average for a molecule for these studies, it will crush the industry. Let's face it, let's call it by its name. It will reverse the gains. The countries with maturity level 3, they are forced to do bioequivalence for class 2 and class 4. But there are scientifically verified methods, I'm finishing with this, vetted methods to ensure that quality is not compromised. You can do advanced or enhanced comparative resolution until the industry can sustain, the additional investment for bioequivalence. We're talking about this. Let's work together. Regulators, AMA, MRH, ABLA, NEPAD, country regulators, NRS, please open your ears to listen to the voice. If you put this demand of BE acutely, sharply on the local industries, they may not even serve. But at least what are other parallel ways, pragmatic mechanisms to ensure quality is not compromised, while we put a workable roadmap toward this self-sufficiency. How many BE centers are there on the continent at the moment? How many CROs can do bioanalysis at the moment? We know. So let's work together. The government speaks something, the regulator speaks something, the industry has no voice to be listened. There is science and there is a way to do things rightly. So I think this is an appeal to this forum, especially for people from the House of Government, to really take this seriously. Thank you.
Thank you so much for all the submissions. We'll now break off for tea, and we are expected to come back at 12 hours. The permanent secretaries are invited for the 1-hour closed session with World Bank, IGAD, and EXA, and the meeting will take place in the next building just behind the restaurant in room 1. And the rest of the participants will come back to the room and will continue with a session that we were not able to finish yesterday, the cross-border coordination, a collaboration preparedness. So that is all for this meeting, this morning session, sorry. So we break off for tea now and reconvene at 12 hours in...
So apologies, we have a brief announcement. We are planning for a field trip tomorrow, which is basically scheduled for Zamra and ZNPHI. ZNPHI is Zambia National Public Health Institute. So there are forms that are making rounds in the room. Please feel free to register your area of preference between the two. The vehicles will leave, the transport are already arranged. They'll be leaving at 7:45 a.m. tomorrow. And of course, we'll have two separate vehicles. And the field trip is scheduled for half a day. So the plan is to have lunch here. So meanwhile, feel free to register. And of course, we'll again remind you and collect the forms much later. Thank you so much.
So thank you so much. We are free to have our tea and then come back at 12 hours. And permanent secretaries will go to their meeting across the building. Thank you.
Just to announce that we will be having two parallel sessions, one with only the head of delegations and the BSs in the holding room yesterday. It's called meeting room 1, above the reception in the main building. The rest of the delegates, they are here for the cross-border session. That was not happened yesterday. So everybody will be here except the BS, and maybe if you want to take someone with him, is welcome.
Good afternoon. Good afternoon. We need an energizer. Do we need an energizer? So the next session is a carryover from yesterday. We were supposed to discuss cross-border coordination and collaboration in health emergency preparedness. And that is the discussion that we'll continue with. I would like to invite the moderator.
West Africa also, due to the reduced level of population and the control measures is not enough to protect the population. And later on in the year 2003, the outbreak was reported in the US. In Nigeria, the report was reported in the year 2017. And later on, the WHO established the surveillance for MPOX response, and they were getting reporting from countries. And by the year 2020,
Yeah, thank you very much, Dr. Hamid. We suppose what Professor Yap online. Let me technical check whether it's online or that presentation first, then we go to the panelists. So go on, Prof.
You can hear me?
Yes, we can hear you.
Thank you very much for the great opportunity to present today. Yesterday was a fantastic day, despite our session being moved today. It was really great to see all the great presentation that I had the pleasure to see from far. So now let me share my screen. Can you confirm that you are seeing my screen, my presentation, please?
Yes, we can see your screen.
Okay. So I will give you some of the lesson learned. I think I have 10 minutes for that, not more than that. I will try to be on time. On the lesson that we've learned from the incident management support team responding to the Ebola, to the Mpox outbreaks. So the first thing, what you are seeing that very nice vase that represents a vase that has been broken and that has been repaired using gold. And this kind of representation is coming from the Japanese kintsugi, which remind us that any challenge is an opportunity to get better, which what we call the post-traumatic growth. How can we get better after a challenge, after an outbreak, which is the case that I will show. But the most critical thing where I will start, and I think if there's one thing to remind from the IMST, from the response, is that we believe in that pyramid where the foundation of the pyramid is trust or confidence. It's only when we have trust that we can build the communication, the comprehension, and then have an efficient collaboration. Now, the way we have been working, and I will explain more about the IMST, but it's also coming from the inherited from the COVID-19, teaching us that we cannot have a one-size-fits-all approach. We need to have homegrown and solutions that are really contextualized and adequate to our environment. So for some of you who have been following Africa CDC, on Monday, Dr. Jan Kaseha highlight the new vision of Africa CDC, relying on Africa health security and sovereignty agenda. This is the new way forward. And as you can see, the second pillar, which is the one that is really critical for us today, is the one of the institutionalized continental preparedness response. And you will see all the different pillars that has been talked this morning on the local manufacturing, also the digital transformation, the predictable domestic innovative and blended health financing. And of course, the first one, the key one, is how can we reform and have a more inclusive global health architecture. Now, more than a year ago was declared the public health emergency of continental security because we realized that the Mpox has an unprecedented sustainable human-to-human transmission, a rapid geographic spread to African countries. At the time, if you remember, there was already that outbreak, global pandemic, which started in 2022 and were lifted as a fake in 2023, while the cases were continued to increase, especially in DRC. So because of those increase continuing, also this mutation that was found in the eastern part of DRC, this fake was declared on the 13th of August and the following day as a fake by the Director General, Dr. Tedros, as a public health emergency of international concern. So from there, we need to remind ourselves that Mpox is an issue of people, of patients who are suffering. It is painful. And even those who manage to make it, those who don't die, may end up with some sequelae, whether they are physical, whether they are psychological. It's important to have that in mind. Two, contextualize. Here is Pakajuma, a slum in DSC, which is at the heart of Kinshasa, and one of the places where the transmission was the highest because of the sexual network. And last but not the least, the logistic. Getting the sample in the community is extremely hard. It's important when we talk about our figure, let us have in mind the population, the environment, and also the logistical challenge. So what is the IMST? It's really the team led by Africa CDC and WHO with all those partners decided that we will be working as one team with one plan, one budget, and one M&E framework. Why? Because we want to reduce the overlap. We want to have one coordination and ensure that we have the most efficient way of addressing Mpox. So with those different what we call interaction review, asking countries, member states, asking partners what went well, what went less well, we were able to keep on improving the way we are working with those different plans. So this was the plan 1.0, the 2.0 that was really focusing on the intensification, the integration, and the legacy. Legacy, remember the ways that I've shown to you, highlighting that we really want that outbreak to strengthen the health system. And I think that was one of the key requests from the Minister of Health in DRC when we were handing over some lab equipment to the president of DRC. Now, quickly on the epidemic situation, we see it has been mentioning already in the remark, but we had 30 member states that have been affected by Mpox so far. We are glad to see that most of them has reduced. So now we remain with Liberia, Kenya, Guinea that are of concern, but we believe that the support that they are bringing and the coordination will help us to bend the curve, as we've seen in Sierra Leone, where the last case has been seen for the last 27 days, actually not 12 days, but also Uganda, you've mentioned, Burundi, some of those countries that have really shown a strong leadership on bending the curve. But it's not over. We still have to emphasize to strengthen the response in those countries, but also to move toward the integration, which we want to be one of the key legacy and lesson learned from the Mpox. So talking about the lesson learned, the key driver that we've really seen for successful response are 5. The first one is the leadership. A strong leadership at the ministerial level to ensure that the coordination is well implemented at the country level, the multidisciplinary rapid response teams, which we've seen deploy in most of the countries with epidemiologists, with leading the community healthcare workers, the IPC, and all those. But at the end of all that, most critical, the community. The community is really at the heart of the response. That's why the strengthening of the community-based surveillance and DRC has shown how, and Sierra Leone also have shown how we can use the DHS to tracker to be able to have real-time data allowing the proper management of the outbreak. The prompt isolation and case management also happened to be one of the key drivers. While at some point we all together were thinking that the home-based care was a critical way to move forward, as we've seen from COVID, we realized that no, for Mpox, it's not working well. That's why Sierra Leone has really shifted and changed and ensured that all the positive cases were isolated so that they are well taken care with the holistic case management, but also stopping the spread of the disease, which originally was the way Burundi was responding to these outbreaks. So now from Mpox, which is an effect, we had cholera, and then you can see the situation. We've never had such a bad situation of cholera for the last 25 years. We have multiplied by 3 the number of cases, and the same thing, the number of deaths. So that is the reason why our head of state have instructed Africa CDC and WHO to use that model of the IMST, used now to handle the cholera within the continent, so that is aligned with the cholera elimination by 2030. Now, going toward the end, and this is definitely another key lesson that we've learned, is that our institution, which we are relying, the NPHI, have managed to respond to most of those outbreaks. Mpox, cholera, Ebola, currently Marburg in Ethiopia. So we've seen that the maturity of our institution, and because of that maturity, we need to change the way we are responding to outbreak and to public health emergency in the continent, where the African organization leads. And then the multilateral health organization support. And we have also identified some key aspects where we really need to have that support. The co-development of an evidence-based norm and guidelines, which is critical, the facilitation of the technology transfer and regulatory capacity. Yesterday or this morning, you were talking about the local manufacturing. We still need that support, but also to invest on selectively in workforce capacity strengthening. That is key in epidemiology, genomic research, and so on. And last but not the least, to enable effective resource mobilization and development. So it's not ending the partnership, but just ensuring a more equitable partnership. That is one of the key lessons we've learned from this Mpox outbreak. I will stop there and I will be happy to join you in the panel. Thank you.
Yeah, thank you very much, Professor. And for close. Yes, thank you very much for that opening remark, opening presentation for this session. I think you have highlighted the key lesson learned from the incident management and the issues of challenges that emerged from the response, and the need to have a coordinated way of addressing the airports. As you correctly noted, 30 member states were affected by this outbreak. So there is a need for all of us to work together. And there's something that you also pointed out. There is no one size fits all approach. So we need to look at the context at which the disease has occurred. You also took us through the drivers of successful response. So with that, I want to welcome our panelists for today. And I'll take you through the first question in this panel. And given the ongoing effort to strengthen cross-border surveillance, improve detection, reporting, and overall management of Mpox cases, what approaches and mechanisms has your country already established with the neighboring country to jointly control the outbreak? For example, do you have a functional cross-border coordination platform, agreements, MOUs for sharing information and resources, or cross-border patient referral arrangement? Is there something like that? In addition, what key bottlenecks have you encountered, and how can this be addressed? Is your country already funding or planning to fund using the local resources that you have? So we want all of us to reflect on those in the following lines in terms of coordination and collaboration, surveillance and information sharing, allocation of funding for domestic resources to ensure the sustainability of the response, also key bottlenecks and lesson learned, which we want to share the rest of the countries. So those are the key issues I wanted panelists to reflect. And let me call upon Malawi to start, followed by DRC and Burundi in the last. Over to our panelists.
Thank you, the moderator, ladies and gentlemen. Really for mpox and any disease for that matter is not an effort for one country. So the topic is quite pertinent in terms of cross-border, how we can work together as a region. Yes, there are mechanisms in which we are coordinating and working together with our neighboring countries. We have physical meetings that we usually come together and work together. So in this case, we empowered the districts that border so that there is this constant communication and physical meetings. We really empowered the leadership of the districts so that they take ownership of the situation, and even when it comes to disease outbreak, prevention and control, in this particular case, talking about mpox. And of course, there are also virtual opportunities where people can have an opportunity to interact with each other virtually. There are WhatsApp forums where these neighboring districts, including people from the national level, share information quickly. And of course, other mechanisms that are there. Yeah, of course, we have joint cross-border surveillance meetings. Like for the case of Malawi, we are really talking about Malawi, Tanzania, Mozambique, and Zambia. That we are always we are coordinating and working together. There are also other instruments like using the Africa CDC framework for cross-border surveillance, using the XHC integrated disease surveillance and response framework. All these are instruments that are there for Malawi and its neighboring countries to work together. And of course, also using the Southern Africa TB Health Systems Strengthening Project that was funded by World Bank. We also have an MOU between Malawi, Zambia, Mozambique, and Lesotho, where data sharing is part of that MOU. So I guess all these are instruments that are there, as I said. But in terms of maybe when coming to the bottlenecks, it's really on data and information sharing. This has been talked for a long time. This is not to say that there haven't been some achievements. Of course, we are better today than we were yesterday. That's possibly the good side to it, but otherwise we are not still where we are supposed to be. I guess that's what I should say. There is still room for improvement for countries to share data. I know through Africa CDC we have the Regional Integrated Surveillance and Laboratory Network. That's being operationalized where countries can share data and information, but sometimes bureaucratic bottlenecks still exist, so much so that it's not data and information is never readily available. And of course, the SOPs are also not standardized. There are differences in terms of between countries. And also what is the bottlenecks are the nature of our borders. They are very porous. Like when between Malawi and Mozambique, communities they are one, you know, they have families on both sides of the border. So really people don't necessarily have to use what we have designated as borders. People cross from anywhere making life continue. So you really can't afford the match, but it is upon us, as I think the previous speaker just said, all these disease outbreaks really start and end at the community level. So I think the community also needs to come into that. And of course, there are issues of resource constraints. As I said, if you are talking about physical meetings, then resources are also come into play. Differences in terms of surveillance capabilities, when we are talking about countries, we are different levels in terms of our surveillance capabilities. And of course, sustainability, all these issues as we are talking about districts meeting is being usually supported by different partners in a project context. So when, like now the interest is on POX, then there will be partners that are funding that. But when this support is gone, then we also notice a slowdown in this. So in terms of possible solutions, of course, one of them is to establish an interoperable real-time data sharing platform. If we could have these, like for our case, DHIS2, if it could be interoperable and then we are able to share with our other countries, that would also help. Obviously, to engage in the communities so that they are part of the solution rather than part of the problem when it comes to cross-border issues. And of course, set up and jointly train cross-border issues so that we continue to talk to each other. And of course, to bring in sustainability aspects when it comes to that by domestic financing rather than to always wait for partners to help. This is not to say that we want to do away with partner support. No, I think it's just about coming together and making sure that even governments and ministries are taking ownership over the situation. Yeah, but I should also really, I think on the specific issue, just to mention on the specific issue of MPOX, while we are talking about cross-border issues, usually we view it in the context of neighboring countries, but for the case of Malawi, we have like people coming from up north. We don't border DRC, but we have people coming from DRC, coming into Malawi, and you even have people coming from even further up north. So, I mean, all these, and when these people are coming in, they are really not used the chartered entry points. So I think engaging the community also strengthen that area of intervention. Thank you, moderator and chair.
Thank you very much, Malawi, for that good reflection. Let's hear from DRC.
Merci. Yes, I will speak in French. Yes, you can put your helmets to understand better. Alors, pour la RDC, je voudrais que vous puissiez bien comprendre l'expérience de la RDC. Parce que quand on a déclaré le MPOX en 2024 comme une urgence de santé publique continentale par Africa CDC le 13 août, et le 14 août, l'OMS déclarait MPOX comme une urgence de santé publique de portée internationale. Nous, en RDC, on avait déjà l'épidémie depuis 2022. Parce que en RDC, le MPOX évoluait depuis plusieurs années en mode endémique. Parce que nous avions des provinces qui ont chaque année des cas de MPOX. Les provinces qui sont dans la partie de la savane équatoriale, surtout au niveau du centre du pays et de l'ouest, chaque année, ils ont des cas de MPOX. Donc c'est une maladie qui est endémique, qui est connue au niveau de la RDC. Alors qu'on a déclaré en 2024 comme une urgence de santé publique, il fallait qu'en RDC nous puissions aussi augmenter le niveau de surveillance et en faire aussi une urgence sanitaire nationale au niveau du pays. Et là, nous avons décidé, contrairement à ce qu'on a connu, parce qu'en RDC, on a encore la souvenance de la grosse épidémie de Ebola, 2018-2020, en RDC, où on a vu que cette épidémie, quand elle est arrivée, il y a eu un gros problème de coordination. On a eu, même au niveau du pays, des structures ad hoc qui ont été créées pour gérer cette grosse urgence. Alors pour le cas de Mpox, on a dit on ne va pas refaire les mêmes erreurs. C'est ainsi que dès qu'il y a eu ces déclarations, et au niveau continental et au niveau mondial, de l'urgence sanitaire, nous avons mis en place notre système de gestion de l'incident. Au niveau de l'Institut national de santé publique, à travers son centre des opérations d'urgence, le COUSP. Donc le système de gestion de l'incident a été mis en place avec la désignation très rapidement d'un incident manager et avec les responsables des différents piliers. Alors ceci a permis que nous puissions rapidement renforcer la coordination. Et avec ce système de gestion de l'incident mis en place, donc ça ne permettait plus aux partenaires et aux autres agences, chacun de venir faire ce qu'il voulait faire. Donc très rapidement, c'est un plan qui a été élaboré, un plan de réponse multisectoriel, parce que dans notre système de gestion de l'incident qui a été mis en place, on a eu très tôt déjà impliqué les autres secteurs, le secteur de pêche et élevage, le secteur de l'environnement, déjà les secrétaires généraux eux-mêmes des autres ministères ont été invités déjà à la première réunion de coordination pour qu'ils désignent déjà leurs experts donc, dans le système de gestion de l'incident, donc qui a été déjà multisectoriel, donc qui a permis déjà d'adresser cette question de multisectorialité dans la coordination. Et nous avons dû élaborer notre plan de réponse à l'épidémie et avoir un seul plan, un seul budget et une seule coordination, un seul mécanisme de suivi et évaluation. Donc ceci nous a permis déjà de pouvoir aligner tous les intervenants dans la réponse contre Mpox. Alors pour ce qui est aussi de la surveillance, parce que c'est une question qui est adressée, la surveillance transfrontalière, il faut savoir que dans la genèse, comme je l'ai dit, de Mpox, en RDC, nous avons jusqu'à ce moment plusieurs clades. Nous avons le clade 1A, et maintenant nous avons aussi le clade 1A, 1B, et le clade 2, qui circulent au même moment de manière concomitante. Nous étions plus familiers avec le 1A, qui est la forme zoonotique, qui se transmet de l'animal à l'homme, et qui a toutes ces manifestations cutanées que vous connaissez. Et ça, c'était facile, c'est facile à reconnaître. Donc, quand on surveille, on sait voir les signes, la symptomatologie de la maladie Mpox. On a les fièvres, on a des courbatures, on a les éruptions cutanées. Mais quand on a eu la deuxième forme, et qui est la forme épidémique, avec la transmission sexuelle de Mpox, alors cette transmission qui se fait par voie sexuelle, nous en RDC, et je pense que c'est aussi l'expérience des autres pays qui pourront nous le dire, c'est difficile de faire cette surveillance transfrontalière. Comment vous allez surveiller la transmission sexuelle d'une maladie entre les frontières? Je vous dis, c'est vraiment une réelle difficulté. Parce que la personne qui a la maladie de manière sexuelle, les lésions sont plus focalisées au niveau de la sphère génitale. Donc, et ça, c'est difficile de surveiller au niveau des frontières parce que les personnes qui ont déjà ce signe au niveau de la sphère génitale, quand ils se présentent au niveau des frontières, déjà vous ne verrez aucun signe si la personne elle-même ne vous dit pas qu'elle a des lésions au niveau génital. Donc ça, c'est une difficulté qu'on a eu à mettre en place, cette surveillance transfrontalière pour le cas de Mpox, parce que la plupart, surtout, c'est au niveau des frontières, c'est des voyageurs, c'est plus cette transmission sexuelle qui a été notée. Nous avons eu à avoir un cas, qu'on a eu à capter, 1 ou 2 cas, au niveau des frontières. On a eu un chauffeur qui venait de l'Afrique australe, qui est passé par, je pense, la Zambie et le sud de la RDC, Lubumbashi. Mais le signe évocateur pour lequel, au niveau des frontières, on a eu à capter ce cas, c'était la fièvre intense. Parce que le chauffeur du camion, il avait tellement une fièvre qu'il ne pouvait plus conduire. Donc, on a dû alors notifier. Et dans les investigations, et dans l'anamnèse, après, on a eu maintenant à comprendre, en faisant les examens, ça s'avérait que c'était un cas de Mpox. Donc, vous voyez la difficulté de mettre cette surveillance transfrontalière pour le Mpox. Mais alors que nous le faisons, c'est plus facile quand on a eu les autres maladies, le choléra, l'Ebola. Le choléra, nous avons des mécanismes de souvent transfrontaliers avec la Zambie. Pour Ebola, avec même l'Ouganda, nous avons ces mécanismes. Mais c'est beaucoup plus facile. C'est vrai qu'il n'y a pas encore des plateformes dédiées. On n'a pas encore des plateformes pour la surveillance transfrontalière. Mais les provinces voisines, entre la RDC, la Zambie, la RDC, Congo-Brazzaville, la RDC avec l'Ouganda, donc les provinces voisines, les structures, les responsables sanitaires, ils collaborent déjà, ils se connaissent. Donc à ce niveau, le partage d'informations est déjà beaucoup plus facile, malgré qu'il n'y a pas encore de plateforme déjà standardisée. Cela permet déjà au niveau des frontières de collaborer, d'échanger des informations entre les provinces et les zones voisines de part et d'autre. Ça, c'est ce qui se fait déjà, mais c'est vrai qu'il nous faut aller vers des standardisations avec des plateformes dédiées par rapport à cela. Alors, pour on a parlé aussi des allocations, des budgets. Alors, au niveau national, le gouvernement de la RDC avait décidé déjà, dès qu'on a annoncé cette urgence de santé publique de portée internationale, de contribuer à hauteur de 10 millions de dollars américains. Et à ce jour, je peux dire avec toutes les urgences et les priorités au niveau du pays, parce que n'oubliez pas que l'RDC fait face à plusieurs priorités en ce moment, avec la guerre à l'est du pays et d'autres priorités. Mais malgré cela, le gouvernement s'est déjà engagé à débourser à hauteur d'environ 6,5 millions sur les 10 millions qui étaient prévus comme contribution du gouvernement. Et aussi, nous avons aussi les contributions des partenaires qui appuient le gouvernement et le ministère de la Santé. Mais le bémol que j'aimerais faire ici, c'est peut-être, en RDC, on ne perçoit pas encore la contribution des organisations régionales, comme c'est le cas ici avec IGAD et EXA. Donc, c'est que nous devons aussi savoir quelle est la part de la contribution des organisations régionales au niveau de la RDC dans la réponse aux urgences. Comme on a maintenant en RDC, nous avons Mpox, nous avons Ebola, on a le choléra qui continue à être aussi une épidémie majeure en RDC. Mais je pense qu'il faut que nous puissions bien redéfinir la contribution des organisations régionales comme celles avec lesquelles qui organisent cette réunion pour capter ces contributions et les intégrer dans le plan, parce que, comme je l'ai dit, dans les mécanismes de coordination, nous avons un seul plan, un seul budget, un seul mécanisme de coordination, et on devrait retrouver dans notre plan, dans notre budget, quelles sont aussi les contributions des organisations régionales, ce qui n'est pas encore le cas de manière très visible pour ces organisations ici. Alors, les leçons apprises, aussi quelques défis, c'est que les défis avec le Impox, c'était comment déjà capter, diagnostiquer les cas, parce que toutes les provinces en RDC, nous avons 26 provinces, et on avait presque toutes les provinces étaient touchées. Et comment on devait renforcer la surveillance, être sûr que les capacités de diagnostic, de détection étaient disponibles au niveau de toutes les provinces. Ça, c'était le gros défi, parce que nous n'avions que 2 laboratoires qui pouvaient poser le diagnostic de Mpox. C'est un laboratoire au niveau national et un autre laboratoire au niveau de Goma, à l'est du pays. Donc, avec juste 2 laboratoires pour la détection, c'était difficile d'améliorer la surveillance de la maladie au niveau du pays. Donc, il nous fallait faire beaucoup d'efforts pour décentraliser le diagnostic. Il fallait vraiment que nous puissions décentraliser le diagnostic au niveau du pays. Et là, nous sommes passés de 2 laboratoires qui posaient le diagnostic en 2024 à environ une trentaine aujourd'hui de laboratoires qui sont capables de poser le diagnostic. Donc, c'est des gros efforts de décentralisation du diagnostic que nous avons dû faire et que nous comptons encore davantage renforcer, améliorer cette décentralisation, parce que pour renforcer, améliorer la surveillance, il faudra aussi que la détection puisse être aussi renforcée, et cette détection au niveau des endroits où émergent les épidémies, donc au niveau périphérique. Voilà, je pense qu'avoir fait le tour de la question. Merci.
Merci beaucoup, monsieur le facilitateur. Il nous a été posé la question de savoir comment on a mis en place les mécanismes de surveillance au niveau transfrontalier au Burundi. Bien sûr, après avoir mis en place différents comités de gestion de l'incident au niveau national, il fallait se déployer au niveau des frontières, parce que on était conscient que la maladie n'était pas née au niveau au Burundi, mais que c'était transmis à partir des pays voisins de la République démocratique du Congo. Alors pour cela, il fallait être vigilant au niveau des frontières. Alors pour y arriver, nous avons mis en place d'abord un système d'offre de services transfrontaliers robuste. Pour cela, il a fallu d'abord revoir l'état de fonctionnement des points d'entrée, des services de surveillance des maladies au niveau des points d'entrée. Ce qui a fait que, dans un premier état, nous avons réhabilité tous les points d'entrée. Pour cela, nous les avons équipés en matériel de screening, mais aussi en matière de transport des malades. Et puis, nous les avons équipés, nous les avons alloué du personnel. Le personnel que nous avons alloué à ces points d'entrée ont été soumis à une formation. Et la formation portait sur la prévention et le contrôle de l'infection, mais aussi sur les principes de détection de la maladie Mpox. Il a fallu alors mettre en place les procédures opérationnels standards qui ont fait que toutes les formations qui ont été menées au niveau des points d'entrée étaient conduites de façon standardisée
avec le même protocole. Et à côté de ça, on a mis en place des comités transfrontaliers. Les comités transfrontaliers avec appui des partenaires. Et je tiens aussi à signaler que grâce à l'appui des partenaires dont EXA, les comités transfrontaliers ont bénéficié des réunions de coordination. Là, je cite par exemple la réunion du comité transfrontalier entre le Burundi et la Tanzanie, et la réunion du comité transfrontalier entre le Burundi et la RDC. Tout ça, c'était pour une gestion conjointe de la maladie Mpox au niveau des frontières. Et à côté de ça, on a mis en place, on a décentralisé les capacités de diagnostic et de laboratoire à travers les hôpitaux de district qui sont au niveau environnant. Et d'ailleurs, je tiens à signaler que le Burundi avait pris expérience de l'épidémie de Covid-19 pour déployer les jeunes experts à travers le pays, où on a compté à peu près 100 appareils qui étaient tous paramétrés et fonctionnels pour aider dans le diagnostic de la maladie Mpox. Ça, vraiment, c'est déjà un atout pour le Burundi, vu qu'on n'avait pas besoin de faire recours au niveau central pour diagnostiquer la maladie Mpox. À côté de ça, il y avait quand même un défi à gérer, c'est que la frontière entre le Burundi et les pays voisins est une frontière poreuse où il y a d'autres points d'entrée qui ne sont pas officiels. Et pour cela, pour aller au-delà de ce défi, il a fallu mettre en place un système de surveillance communautaire où les agents de santé communautaire au niveau des frontières ont bénéficié des formations pour la surveillance communautaire. Et comme ça, ils pouvaient bien épingler tout passage à la frontière et pouvaient les orienter au niveau des centres de santé dédiés à cet effet. Et puis, pour le contrôle de la maladie, bien sûr, le pays avait mis en place un système de les services d'isolement dans toutes les formations sanitaires, parce que on avait compris que la maladie se transmet à une grande vitesse. Voilà. Donc, chaque fois qu'on suspecte la maladie, on pouvait transférer immédiatement la personne suspecte au niveau des centres. On pouvait d'abord mener un diagnostic rapide et le cas à confirmer était immédiatement transféré dans les centres d'isolement des différentes formations sanitaires à travers le pays, tout en commençant par les structures sanitaires qui sont sur la frontière. Et puis aussi, il faut signaler que le gouvernement n'était pas resté bras croisés, parce qu'il avait tiré expérience de l'épidémie Covid-19. Pour cela, il avait dans son budget annuel un budget alloué à la gestion des urgences en attendant l'apport des partenaires. C'est par là qu'il avait déjà déployé le personnel qu'il payait de lui-même, qu'il assurait le déplacement de tous ses patients sur le budget du gouvernement. Il avait aussi mis le matériel de screening, mais aussi les outils d'équipement, les équipements de protection individuelle. Tout ça, c'était le compte du gouvernement. Et puis les partenaires sont venus appuyer. Les partenaires dont je parle, c'est par exemple le COXA, plutôt l'EXA, qui a appuyé dans la mise en place, mais aussi dans la mise en fonction des comités transfrontaliers. Mais aussi, il a appuyé les activités de supervision, mais aussi les exercices de simulation pour les équipes d'intervention rapide. Il y a aussi l'OMS qui a apporté sa contribution dans la mise en place d'un thermoscan au niveau de l'aéroport, mais aussi dans l'acquisition des intrants de prise en charge. Je citerai aussi l'Africa CDC qui avait donné les outils de les intrants de prise en charge, mais aussi les outils de screening au niveau des frontières. Alors, de tout ce qui précède, il y a quand même des leçons que nous avons apprises de cet incident, de cette épidémie. C'est que l'engagement politique de haut niveau, là je cite au niveau, dans mon pays, où la primature avait pris les choses en main, où il dirigeait, le Premier ministre lui-même dirigeait les réunions de coordination pour la gestion de l'incident. Alors l'engagement de haut niveau politique, mais aussi la surveillance transfrontalière couplée à la surveillance communautaire, ainsi qu'un système d'évacuation des patients 24 heures sur 24 avec des outils de transport qui sont déployés au niveau des frontières, couplé aussi à la gratuité des soins des malades. Et là, je parle même la gratuité de la prise en charge alimentaire a permis d'atteindre les résultats satisfaisants où on a enregistré un taux de létalité de 0,02%. Un seul patient a pu succomber à la maladie, ce qui démontre vraiment l'efficacité d'une approche centrée sur le patient. Une autre leçon à apprendre, c'est que malgré que les épidémies se gèrent dans des stress, la décision basée sur des évidences est vraiment une chose incontournable. Parce qu'on a vu que dans un premier état, l'Institut national de santé publique a mené des recherches qui ont pu dégager que le type du virus et le mode de transmission, ce qui nous a permis d'orienter bien les stratégies de gestion de l'incident. Mais aussi, nous devons garder dans l'esprit que les appuis extérieurs peuvent arriver à n'importe quel moment, mais que dans nos budgets des gouvernements respectifs, nous devons garder un budget annuel dédié à la gestion des incidents. Et enfin, les équipes d'intervention rapide qui ont été mises en place depuis la gestion de différents incidents, là je parle l'épidémie d'Ebola en RDC avec les pays transfrontaliers, le Covid-19 et bien d'autres, y compris le Mpox, doivent toujours rester vigilants et aux aguets pour la gestion des épidémies futures dans un contexte où nous voyons l'émergence et la réémergence des épidémies qui étaient naguère oubliées. Voilà un peu de mots l'expérience que j'avais à vous partager. Merci.
Thank you, Dr. Mushi, and thank you to the panelists for that insightful contribution. I think speaking on behalf of Zambia, I'll be just informing you that Zambia is a country surrounded by 8 countries. And those 8 countries, we are talking about a stretch of 6,000 kilometers in terms of the border length. And to cover that border, Zambia has 14 designated POEs. Among them, of course, we are talking about the 4 international airports as some of the entry points. Of course, we have authorized entry points, which are 26 in number.
And obviously, when you look at the stretch that we have to cover based on the number of countries and the population mobility, I think in terms of infrastructure around the border still remains challenged. I must be quick to say that in terms of point of entry services in this country, we have an international health regulation which is anchored at MOH through the Assistant Director for Environmental Health, who serves as our international focal point. As a country, with support from EXA, the World Bank, that is Africa CDC Region Financing Project, Pandemic Fund, we've been building capacity in terms of establishing cross-border collaboration platforms with our neighboring countries. So far, we've collaborated and established across 6 countries, with an exception of Angola and Namibia, whose plans are being discussed. I must be quick to mention that during the establishment of these platforms, one of the key output is to establish, first of all, a memorandum of understanding. And one of the frameworks that we've been using, or many frameworks that we've been using, are that of the EXA framework, the COMESA frameworks, the SADC protocol for health, and now with the Africa CDC framework for cross-border collaboration as some of the guiding documents. So far, we've established the surveillance or data sharing platform with these 6 countries, but initially with Malawi, we started off by way of having meetings, but later on graduated into having WhatsApp groups where we would share information. But we've since advanced in the manner in which we collaborate into harmonizing some of the sharing platforms. For example, with the DRC, we've developed a harmonized data sharing platform where 2 countries had agreed. And so far, we've been sharing information under that platform. We have other approaches which are using the Africa CDC framework for cross-border collaboration with an event-based approach, which has been used for in pilot phase with the DRC. And that is a digital platform which we hope we can build and lessons from and replicate in other places in terms of digitalizing our processes. The other things that I may mention is that obviously as a country we've undergone a joint external evaluation, and within those evaluation we have demonstrated capacity in 2 of the 3 core capacities. An area where we had a gap is the issues of risk approach, and through support from the EXA, we have since developed capacity for conducting strategic risk assessments in cross-border. Of course, now we have a pool of national trainers. We have also a pool of international trainers with support from IGAD and EXA. So, following the trainings, we've since conducted strategic risk assessment, followed by development of joint multi-sectoral emergency plans with Tanzania. We've done so with the DRC. We've done so with Malawi as some of the initiatives that we've put in place. Coming back home, in terms of the challenges that we are having, at the moment the country is facing, of course, the mpox, which everyone has spoken about. And some of the lessons we've learned around mpox, the first cases which were reported in October came as a result of imported cases. And from that case, I think there are lessons that have been documented and published through a journal. So it just demonstrates that what we are talking about in terms of cross-border collaboration, preparedness, and joint response will remain key going forward. At the moment, I may be quick to mention that we have a cholera outbreak in this country. And that cholera outbreak started or is mostly affecting the northern part of the region. And that region is co-shared by Tanzania, Zambia, DRC, and Burundi through the Lake Tanganyika, which is a water mass. We have all these 4 countries reporting cholera. We've since collaborated well with Tanzania in terms of sharing information, but there are still gaps in terms of us responding jointly in terms of resource allocation and joint response. I think those are some of the things that we would ask that we elevate our capacities to in terms of response and with support from, of course, the partners. At the moment, we've floated some suggestions on how we can tackle cholera around the Lake Tanganyika, because most of these 4 countries that I mentioned have already a cholera control program in country. They have already identified their priority areas for multi-sectoral coordination, and some of the areas we are talking about are these areas around the lake populations which remain vulnerable. So this, we are of the view that most of the work has been done, but what is key is to have those strategic investment in terms of responding either through vaccine deployment, the issues of WASH around these common ecosystems which tend to contribute to insecurities in our region, as an example of cholera. So just to say that we are on course in bridging the gaps that were identified through the joint external evaluation of 2023. And that we have support, of course, in country from our government. We have support from the MPA project, and we also have some support from the pandemic fund and some of the resources we can leverage on. But of course, we will still request that through EXA, we continue foster this collaboration, especially with our countries like Angola, which we have not established, Namibia as another country which we have not established. So I'll end here just to say that thank you for the opportunity to share the Zambian experience and the having. Thank you.
Yeah, thank you very much, Zambia, for that presentation, and all the countries for your good reflection on the entire box situation, how we are responding, and what are the lessons that we have picked along. And I think you mentioned a number of key points. I took note of the ongoing collaboration between the countries, the cross-border collaboration that you have had among each other, the establishment of the cross-border committees that you have had, and the communication mechanisms that we have put in place, the WhatsApp group, and amendment to this, and also part of those WhatsApp groups, so I can testify the ongoing efforts to strengthen inter-country collaboration. So we have heard from the countries. Let me welcome the partners who also give their reflection based on the submission from the countries. To start with, let me start with Professor Yap. I don't know whether you are still online. We can get your reflection. Then we come to colleagues here.
Yes, thank you. Thank you so much. I hope you can hear me well. And thank you very much to the colleagues who have really shared the experience and the leadership. I think it's always important to congratulate. If we are where we are today, it's because of the strong leadership that we've seen for the countries. Also highlighting the key opportunities. I think it's a colleague, if I get it well, from Malawi that was highlighting the opportunities of using the continent, let's say, a common tool. Most of the countries, African countries, are using the DHS tool. And now the idea that we've actually implemented and experienced in DRC is how we can build that specific tracker that can help us to have all those data from Mpox. Now it has been used for cholera and successfully also for Ebola. Now the question is, how can we, across all our 55 countries, looking at the interoperability that has been mentioned. So to address that, there will be a cooperation workshop sometime in mid-December in Addis, where we'll bring the different member states and see what has been prepared and how we can get the input moving toward that continental tool. The other point, which is also supported by the bank, the World Bank, is to move forward with that memorandum of understanding. I think it has also been mentioned how we can strengthen the sharing of those data, the sharing of all those information. Those agreements are critical. Also allowing to move from one country to the other. I was few weeks in Namibia, and I saw the two cases of Mpox there, and I recall that lady who was really challenged because she was feeling that she's the one who has imported Mpox in the country because the partners who is from a neighboring countries has contracted the disease through another engagement with someone from another country. So you have three countries altogether moving the virus all around. So it's also important to highlight that those MOU are not only for policy, but really to ensure that our community are contributing to stopping the spread of this disease. That's what I can say for now. Thank you.
Yeah, thank you very much, Professor. Indeed, strengthening collaboration in data sharing is vital for the response in your way. Yes, I welcome also partner in yours.
Yeah, thank you very much. I'm Charles Njuguna, working for WHO Regional Office as the Regional Advisor. First of all, let me take this opportunity to acknowledge the member states that have been involved in this discussion on the progress they are making. For those of us who have been in this space for some time, like for me for the last 25 years, I want to recognize that our member states are making progress. When I used to work in Sierra Leone during Ebola outbreak and post-Ebola, we used to get Mpox cases, very sporadic, but it was mainly zoonotic transmission. And we had serious challenges with the laboratory confirmation. We had to send those samples from West Africa to DRC Congo, where there was capacity to confirm. But where are we today? You'll find that countries now, they have capacity to confirm Mpox. So this is good progress. And not just Mpox alone, including other diseases. I remember one country I was in 2012, we had to ship out of the country samples for cholera. Cholera. But now, cholera can be confirmed not just at national level, but even sub-national level. So we need to appreciate there is good progress that has been made. And now that we are discussing about cross-border issues, I want to make a statement. Population mobility is the engine of disease transmission. Population mobility is the engine of disease transmission. As long as people are moving, infectious diseases will continue spreading. We need to remember that. And therefore, in terms of coordination, we affirm that governments are on the driving seat. Us as partners, we come to support the government. And just echoing what I have heard in this discussion, there is a need to decentralize response. Let's take response to where the rubber meets the road. That is the way we can succeed, ensuring the sub-national level, they have capacity to respond to these emergencies. The other thing I want to emphasize from this discussion around surveillance and information sharing is about speed. Speed. anytime we are talking about emergencies, let us always remember speed is of essence. Chasing viruses that are ahead of us, months, weeks, it becomes difficult. I've been involved in a Ebola outbreak whereby you're trying to catch up with a virus which is 4 weeks ahead of you. It becomes very difficult. So speed here, we need to ensure that our systems are able to detect quickly and ensure that the turnaround time for laboratory confirmation is shortened. And therefore, in our decentralization approach, we need to ensure that laboratory capacity is also decentralized. Can we be able to have mobile labs that can easily be deployed to POE? That's what we need to do. And I saw that in Uganda last year when I was there. They were able to quickly mobilize and deploy a laboratory at the point of entry so that samples don't have to move from there very far to the national level. The other thing I want to emphasize is about the information sharing. We need to build trust. Please, we need to build trust and share information as member states. You know, there is this issue of trying to protect our tourism industry, looking at the economy vis-a-vis issues of public health importance. We need to have a balance, because if one country is affected and we don't share the information with the neighboring country, we disadvantage that neighboring country, because that neighboring country should be able to put readiness measures in place if they get the information in a good time. And lastly, it's about our investments. Every time we respond to these public health emergencies, let's ask ourselves, what amount of resource is going into resilient building, such that every emergency should not leave us at the same point where we were. If another emergency comes, our system should be higher than where we were. So we should not spend all the money in containing an emergency, and there's nothing that goes into building resilient health systems. So we should ensure we have that kind of health systems lens when we are dealing with emergencies, that we put finances, yes, to respond, but also something that will leave the systems in a better place. Let me stop there. Thank you.
Thank you very much, Dr. Lukuna from WHO Afro. I indeed totally agree with you. We used to have a project and a World Bank supporting pandemic surveillance in the countries. And one of the indicators was proportion of outbreaks on farm. And when we started, the baseline was like 20%. But now we are seeing that capacity has already been built, and most of these outbreaks are getting confirmed in the country. Let me welcome the last contribution from Dr. Elisa Bonis, the regional coordinator for IFRC, Health Security, Epidemic Preparedness and Response. She's online. Welcome, Dr. Elisa.
Thank you very much. And thank you to the country representatives and panelists from Africa CDC and WHO. Indeed, I think they've laid the foundations for health security, especially around cross-border surveillance. At IFRC, we also have been in the forefront supporting member states, working with WHO and Africa CDC, through our national societies. So indeed, as my fellow panelists have already highlighted, cross-border surveillance is like chasing, it's a moving target. Mobility is a reality that is with us now. And especially now with all the efficient modes of transportation, disease is very much can be aided in terms of their mobility from one country to the other. So as IFRC, we have been in our programming, especially around cross-border surveillance, working on the PREPARE program as well as other programs that have come before this one. We have endeavored to really strengthen the national societies so that there is capacity at the local level, especially right down to the localized structures, so that at the onset of any outbreak, at any point in time, there should be at least some interventions that people can begin to do at the local level. So I really like the fact that there has been funding that has come through, and now through the PREPARE program, we do have these committees, and that also support the communities at large. So our interventions have largely been training the communities themselves and also collecting feedback from the communities. Because as previous speakers have said, it is so important to contextualize our interventions. And even as we are looking at cross-border surveillance, it's not going to be one event approach, because clearly mpox is just one of the diseases that we are currently chasing, but there are many others that are sprouting, and there will be many others in the future. So from WHO, it is true that indeed we need to build resilient structures, and that resilience also needs to be filtered down to the communities and right down to the individuals. And so we find that when we are rolling out programs, everybody folds up and they leave once the outbreak has been declared over, but communities will remain in their respective locales. And so it is also critical that as we are trying to do health system strengthening, we begin to look at how we can then have that continuity in our communities. And so what does that translate to? It may actually mean that the governments and partners map out and strategize in terms of a continuous engagement with communities. Because the minute that we fold up and everyone is gone, you do not know which other area is going to be hit. So institutionalization should also filter right down to the communities. Trainings, we have been at the forefront again of training the individuals, the communities, with using simple case definitions. But again, I think we would need that to be institutionalized, especially with the pre-service trainings for the health care workers, so that they can in turn also support the local communities that they work in. So remembering that we do have an auxiliary role to government, and we are hoping that all the member states continue to support IFRC, because as we have realized, the domestic funding is definitely the way to go. We need to have both the domestic funding support the national societies to continue to engage with human resource capacity that is sufficient and that is qualified to be able to support the communities that we work in. So with this, I would like to thank you and hand back to the chair. Thank you.
Yeah, thank you very much, Dr. Eliza, from IFRC, for those who decided to refresh. reflection. We are also echoing the need for capacitating the communities, especially the community health workers who are the forefront in this response. The issue of also mobilizing domestic funding. Remember, our response will be much more efficient than waiting for the resources from outside. So, in the interest of time, I'm going to invite my co-facilitator to wrap up with the last question and the way forward. Coming Andreas from IGAT Secretariat. Over to you.
Thank you, Mr. Mushi. Thank you for our panelists for the basic reflection and responses. And I like it. Started from the beginning that the demand is huge, the needs are, and the gap is very big to bridge. We have seen that the countries are doing very well. The startup of the response to joint innovation, we have seen from the panelists that is probably how the dramatic improvement is happening. Still, there is a long way to go regarding infrastructure, the need for strengthening innovation, although we have seen very good examples of starting very good cooperation. Zambia is one of the examples of these successful endeavors. Involving communities is also one aspect. We keep saying community engagement, but now we need to have strong measures. The database is calling the countries to allocate resources, and this is one of the ways. But still there are other ways of strengthening the community role in this response, which is very critical. So with all gaps existing and the plans on the table and implementation challenges, I would like to hear from our panelists here in this room and online about what policy change and amendment and strategic arrangements, in addition to top priority recommendations, are you suggesting to improve the situation and how the country is achieving the goal of the national health security plans and improving the coordination and collaboration for a resilient health system? Please, we can continue the same way. Malawi, please, if you can give your intervention.
Thank you. On this one is, I think we really need to have that common understanding. As we said, somebody said yesterday or the other day that disease travel at the speed of our jetliners, which is really indeed true. So I guess if all countries in terms of the policy direction and practice, I think we need to take that responsibility so that screening is on both sides. Screening of travelers is on both sides, even from where the traveler is starting from. That country should have that responsibility to protect the neighbor by making sure that travelers are indeed screened before they travel to the other country. That is in cases where we have an ongoing outbreak. Obviously, I think this needs to be balanced with issues of trade and everything else. I think that's the horizon we have IHR 2005. And of course, we also need to conduct joint community engagement meetings with border communities. As I said, these are they are one community, they are one people, just divided by one imaginary line that possibly divided by one imaginary historical line, if I may actually add. Yeah, because I think yeah, we have lived as one people since time immemorial. So these people will continue to move on both sides or across both sides of this imaginary line that we have defined as a border. So yeah, we need to have all these joint meetings with the communities so that we are moving to with these communities. And as I said, we need to formalize these cross-border surveillance mandates. We really need to amend public health regulations to mandate timely sharing of information on suspected confirmed disease outbreaks. On this one, I think, as I said, we have these regional bodies, Africa, CDC, WHO among them, EXA community, championing, like the Africa CDC is regional integrated surveillance and laboratory network is one of them, but we really need to strongly operationalize it so that as countries we are indeed sharing the data and information. Yeah, so I think this is what I would reflect at the moment. Thank you.
Merci pour compléter sur ce que mon collègue du Malawi a si bien dit, et pour ne pas se répéter, c'est qu'effectivement il faudra que nous ayons des politiques en place par rapport à la surveillance transfrontalière, ne fût-ce que pour la région. Ça, c'est quelque chose que nous pourrons recommander et voir comment cela devrait se mettre en place et être beaucoup plus opérationnel. Donc, il faut voir comment une chose, c'est de mettre les politiques, mais une autre chose, c'est de les rendre vraiment opérationnels. Parce que des fois, on a des beaux textes qui sont élaborés, mais leur opérationnalisation, leur mise en pratique pose problème. Donc, nous devons aussi mettre l'accent sur mettre en place des politiques, voir comment ces politiques aussi sont rendues opérationnelles au niveau de la sous-région. Une autre chose que j'aimerais peut-être souligner, c'est aussi essayer de voir comment on peut renforcer ou intensifier les exercices de simulation transfrontaliers. Donc je pense que ça serait aussi des mécanismes qui pourraient aider les pays, surtout les zones, les régions transfrontalières, parce qu'on l'a dit, les populations sont très mobiles, elles se déplacent et les populations se déplacent avec les maladies. Donc je pense que ces genres d'exercices, en incluant vraiment, en les faisant au niveau des districts, qui implique le niveau des districts, pourrait aussi aider à ce que les équipes se connaissent mieux et puissent déjà connaître les homologues pour partager les informations, parce que autant plus facile que les districts collaborent déjà, ça permet déjà que les premières actions puissent être menées et de contenir la propagation de la maladie. Ça, c'est quelque chose sur lequel on pourrait aussi vraiment travailler. Voilà.
Ok, merci beaucoup. J'avais déjà évoqué l'engagement politique, qui est vraiment un élément indispensable dans la gestion des épidémies. Mais tout en nous focalisant au niveau des frontières, je voudrais revenir sur un point important qu'a évoqué notre frère panéliste de OMS régional, la capacitation, plutôt la responsabilisation du niveau infranational. Ça, vraiment, c'est une très bonne chose. Il faut comprendre que le niveau infranational est capable et faire de la surveillance une des missions du niveau infranational. Je voudrais revenir sur un point qui n'est pas une bonne expérience. C'est que chaque fois que les comités transfrontaliers veulent se réunir, ils ont toujours besoin d'un soutien du niveau central. Ils ont besoin d'une mobilisation de fonds au niveau central pour être utilisés au niveau des comités transfrontaliers. Mais si on pouvait responsabiliser les comités transfrontaliers et même les permettre d'utiliser les fonds disponibles, les réunions seraient fréquentes, mais aussi ils pouvaient prendre des décisions au niveau transfrontalier qui seraient exécutoires à ce niveau même et attendre les résultats au niveau national. Voilà. Donc, responsabiliser le niveau infranational et leur permettre de se réunir sans attendre la décision du niveau central, ça vraiment, ça donnerait des résultats pérennes. Je vous remercie.
Yeah, thank you. Indeed, it's a challenging question, but I think what is prevailing at the moment is that there are a lot of frameworks that are regional in nature that guide member states to share information or implement health interventions across borders. At the moment, I'm aware that at continental level now, the Africa CDC, through the strengthening cross-border surveillance and information sharing framework, I think they've gone ahead to develop a continental MOU through their legal department, and some of the member states have since been served with that MOU. But of course, I think what is key is that since most of the member states in Africa subscribe to Africa CDC vision, and I think this is one of the things that we just need to expedite. But at the same time, looking at the reality with the issues we are facing, we have to continue leveraging on some of the initiatives that we have already based on trust, such as the community of practice that we have, for example, in our Southern Africa region, where all the 10 member states are participating in that platform and really sharing information. But the core is definitely to quicken or hasten the processes of member states completing that task of signing or completing the legal document or the MOU through Africa CDC. Maybe that would help us a bit more. That would be my submission for now, but I think it's also dependent on leadership at all levels. At the moment, there are so many tools, but I think member states, they need to do a bit of soul searching and realize that we have a regional threat, and the information we are asking for is information meant to strengthen our regional health systems, and so that we can protect our populations better. That would end there. Yeah.
Thank you very much. What is a reflection from our partners? I would like to appreciate the clear vision of the interest in terms of focusing on strengthening collaboration, using the existing platforms, which is available like the one in South Africa region, like Zimbabwe. Existing policies, because the IGAD, the corporate policy, the regulatory Africa CDC, the surveillance framework, and others. Also, policy for prevention and building capacities. Of course, the local health system and the communities are making this the information sharing and reporting to the local level and localizing also decision related to detection and response. All of these are very critical in the situation if we would like to make change. Please, Charles, if you can reflect.
Yeah, thank you, moderator. I would want to make a few remarks. I think we are at a point whereby it is important to translate our policies into action. When you look at this space of public health emergencies, cross-border issues, we have frameworks that are guiding us. At WHO level, we have the global health emergency architecture that is based on 5 C's. 5 C's. 1, collaborative surveillance. That brings on board one health aspect also and ensures that also laboratory and genomics are involved. The second C is about community protection. We need to ensure that we are protecting our communities, and therefore our approaches to emergencies, cross-border issues, which are porous borders, community have to be at the center. So that piece of community protection is very critical. Number 3, we talk about scalable care, whereby we need to ensure that we are able to take care of the affected, but at the same time, we are able to ensure that there is continuity of essential health services, even during the time of emergencies. Number 4 is about access to countermeasures, which is very, very critical. Countermeasures, very critical. Look at Mpox. We want to vaccinate, but where are the vaccine? It takes time and all those things. So we should ensure that countermeasures in terms of vaccine therapeutics and diagnostics, we are making improvement in that front. And last, it is about emergency coordination, the 5 C's. That we have these frameworks in place at every level. And I think for me, what I want to emphasize here now is readiness. Readiness. Hello, are we together? When you look at this banner here, we have preparedness, we have response, we have resilience. But there is something that is between preparedness and response. That's what we call resilience. Readiness. And readiness is the bridge between preparedness and response. We can have so many systems in place, but if we don't make sure those systems are ready, we'll always be caught off guard. Let's learn lessons from COVID pandemic. European, American countries, highly sophisticated systems, prepared. But why did this virus humble those systems? It's about ensuring not just being prepared, but we are ready. Why do you have a $100 million referral hospital? But when we have an emergence of an infectious outbreak, they have no place to do triage. We have to bring a tent and put outside because they were not ready for that. So let's remember readiness is what helps us to go into effective response. Because what are our desired outcomes? There are 4. 1, we want to reduce morbidity and mortality. 2, we want to contain these emergencies within the shortest time possible. 3, we want to reduce the human resource deployment and finance in emergencies because they take a lot of money. We need to reduce that. And number 4, we want to reduce the socio-economic consequences that are due to public health emergencies. How can we do that? We must ensure that the systems are ready. How do we make them ready? Because we have put these systems in place. Let's test them from time to time. Are they working? Then when you do those testing, the simulation exercise from time to time, you are able to see where you did well, where you didn't do well. And then you try to improve in the aspects where you have gaps. I don't know how many of you have ever heard about the Kaizen model as I finish. The Kaizen model is used by Japanese. And that model is about continuous improvement. Japanese don't talk about major improvement at once. They talk about little by little. The Kaizen model, whereby you are improving bit by bit, ensuring that the system is becoming better and better. So like for Mpox, my colleagues, because it has been an emergency, public health emergency. But let's think about it. Now that it's an STI, sexually transmitted disease in many aspects. The reality is we will need to transition at one point from a health emergency program to issues of routine health systems, because we need to utilize the infrastructure that is there for HIV, AIDS, and all the STIs. We need to do that. But how much are we working with them? We need to leverage those systems. In Uganda, we had to bring on board the HIV program because we realized unless we use that infrastructure, we are going to miss many cases. So MPOX, let's think about also ensuring existing infrastructures, we leverage on them. Thank you very much.
Thank you very much. For the sake of time, I will give the floor to Prof. Yap to reflect.
I think Prof. Yap has put his reflections in the chat box as he has left the meeting.
So we give you the floor, Dr. Elizabeth, to be the last speaker for this. Please, Dr. Elizabeth, the floor is yours. Would you reflect on the responses that you were hearing from the countries?
Thank you very much. Indeed, we are fully all aware of what needs to be done. I think the next best thing is how. And as rightfully put, this issue of sharing data continues to be something that we all have to continuously put an effort to build the trust and make sure that the data is available. So in terms of the policies that are already in existence, the Africa continent has embraced that we are going to need and continue to use community health workers and community volunteers. So in this meeting, my call is that if member states could really ensure that this again is operationalized, because community health workers and volunteers are not free labor, but that they should be at least remunerated, as there has been calls. There is a framework for how we handle our community health workers and volunteers. Why? Because then we can then have the continuous process of preparedness, readiness, and the ability to quickly respond. So my call to action is that we go back, we continue to dialogue with our governments, we continue to make the noise around the community health workers, around the community structures, so that they are fully resourced to be a significant part of the continuous process of preparedness. Thank you.
Thank you very much, Dr. Elizabeth, for the response. I would read for you the message that Prof. Yap left for the second question. He is saying, once again, thank you to the organizers for this excellent meeting and coordination. Sorry that I have to leave now. Africa CDC remains fully committed to strengthening our member states as we advance African health security and sovereignty. We will continue supporting the continental digitalization of surveillance through DHIS2 and other tools, and move forward with MOUs on data sharing and other critical mechanisms needed to break borders and protect our continent together. This is the response from Prof. Yap. I would like just to wrap up saying that the countries are doing very well, and now we are understanding the importance of
that we cannot work in solos. We need to work together. We have the framework and policies in place that needs to be translated into actions, engagement of communities, allocation of local resources for improving the system, focusing also not only on preparedness and response, but also readiness, evaluation and re-evaluation to improve the response and ensure health system resilience. And I think the key messages to take home is to keep the discussion open and live and ongoing, continue the collaboration that we started, and throughout we will be improving, borrowing from the Japanese experience. We cannot make it all together very quickly, but gradually we can make change that can cumulatively will take us to the point we are aiming at. And we would like to thank the panelists for their offering their time and expertise and the good responses and the honest contribution, the openness, and that is how we can touch and pinpoint the areas of weaknesses in order to address them. Thanks also to the audience for listening, and I give the floor back to the chair to guide us, because I think this is the time for lunch break. Please.
Thank you so much for that wonderful presentation. We will now break off for lunch and reconvene at 2:40, 14:40. So give ourselves 40 minutes to have our lunch. Our lunch is being served where we had lunch from yesterday. Thank you so much. So 14:40. me to welcome Dr. Waku to our next presentation, which will talk about a key deliverable under the MPA.
Thank you so much, Madam Matilda. So my name is Waku Gufu, working with the IGAD Secretariat. I'll wish to request for us to bring order to the room. We can settle for this presentation. So our session for this afternoon is based on the learning agenda, essentially based on the different initiatives, activities, technical support, and many interventions that have been implemented over the last 1 year. We have drafted some initiatives on learning agenda to essentially enhance further learning in as far as this, the MPA program is concerned. So in this regard, allow me to welcome Dr. Evelyn Wesangula, who will be taking us through this presentation. Meanwhile, IT, please project the presentation. You can project the presentation on the learning agenda. Exactly. So thank you so much.
Good afternoon. That's not strong enough. Good afternoon. That's much better. Get us to the best endpoint. The next slide talks about the collaborations that we've had and what we've been able to do as of this month. Of course, looking at the regional institutions that are supporting the implementation of the MPA project, that's IGAD and EXA, financed through the World Bank, having an opportunity to sign memorandum of understanding with different countries. This being our third regional advisory committee, we should be able to look back and take stock after the previous 2 RACs that were held. And over and above the RACs, we've had 6 communities of practice being established, and these COPs have met and deliberated, and they've given feedback. The last 2 COPs met over the last week, and there was a lot of information that also came out of these communities of practice. The next slide looks at the achievements which each of the countries were able to share during the meetings with the project implementing units, and also in summary at the RAC yesterday and today. We have a lot of information that is really useful that has been gathered from the baseline assessments done in 8 countries. We are looking forward to completing this set of assessments in the new countries that have just onboarded. A lot of implementation at the country level. We have seen that, a lot of surveys, capacity assessments that have been conducted across different thematic areas. We've had a lot of training, as you saw reported by the regional institutions as well at country level. We've had country-specific technical assistance provided. We've had tools and documents developed over the last 2 years. We have had rich experiences learning from one another through exchange visits and also peer-to-peer support that has borne a lot of fruit, where we've had countries coming in to support their fellow colleagues in another country to implement and share what has worked for them in terms of best practices. And I already alluded to the meeting of the communities of practice. So where is all this information, if I may ask? Do we have a shared home where I can go and find the information that we have documented as achievements over the last 2 years or 1.5 years? And the beauty of the regionalism is that you can actually turn these isolated country efforts into a very strong and robust shared learning ecosystem, where the country contexts become an asset at a regional level and for everyone that is involved in them. Where through the conversations that we've had yesterday and today, I have realized we have actually created a very positive accountability and solidarity ecosystem. We are in agreement that yes, this has been a problem and we can be able to work together. So looking at what we have done, we also identified some gaps highlighted in the next slide. And we realized that yes, we are learning as we go through the different experiences that we have shared over the last couple of days and over the last 2 years. But we have realized that we actually do not have a strategic and governance framework that can explicitly guide our learning agenda. We are doing it, but we can do it better. What about the technical and analytical capacity to move data into policy, into action? As we engaged with the communities of practice, we also realized that this was a challenge. Knowledge management and learning platform, and my colleague Timothy in the morning talked about the possibility of a knowledge hub, a one-stop shop where we can go in and find a platform that can meet multiple needs. A strong M&E system that will help us to realize when we are making progress and when we need to change direction, even in terms of the way we are implementing our intervention. Translating the knowledge that we have. Also, I think that is one thing that we realize we have a challenge in. We have a lot of data, but how do we package the information? And of course, knowing that at the end of it all, without financing some of these processes deliberately, it becomes difficult to be able to achieve what we want to see. And definitely, if we have good governance and good strategy, coordination and partnerships will work better and we'll be able to avoid a lot of duplication. So that's why we want to discuss this learning agenda in the next slide and look at it as one of the features of this MPA project that will add a lot of value. After 5 years, what will we have to show that other people can learn from? We've heard from the different countries, some of the challenges have been high turnover. So what will we leave behind for the teams that are coming behind us? And what we want to emphasize is that this learning agenda is not new, but it's embedded into our implementation process. What we want to make sure is that we are deliberate about it, we are more structured about it so that we are also flexible to adapt to new information that the implementation process is going to bring, and also flexible to the changing contexts. And again, we'll be able to improve outcomes as we go, and our lessons can be more systematically captured as we have shared them out over the last couple of weeks. I think systematically capturing this helps us to be able to scale up innovations that work across multiple sectors. Then the other bit would be institutionalizing the knowledge that is coming out, and we provide a framework that is reliable for continuous learning. That will definitely improve our effectiveness. We will see more value in this and better partnerships. So what we also want to just put across, even after the discussions we've had with the communities of practice and the PIUs, is that The agenda is a living framework because it's part of the process, it's embedded in it. But what it provides us at this opportunity is to structure properly what we want to learn, why we want to learn, and how we want to go through this process. If you move to the next slide, we have a unique opportunity through this project. Having 11 countries is a big advantage because we have an opportunity for comparative learning. And this being embedded in a major investment and looking at the changing financial financing landscape in our countries, we have an opportunity that we really cannot pass. And like we say, this is not an add-on, but it's just looking at our implementation process and making sure that learning is actually embedded. And not looking at it from a country perspective, but also applying a regional lens. And we have had a lot of conversation yesterday and today about the silos, the vertical approaches that we are seeing in different countries alongside similar thematic areas. So this gives us an opportunity to break down the silos and work collaboratively. And of course, we will be able to strengthen our regional capacity in terms of knowledge that comes out and be able to use this knowledge to make better decisions. And the opportunity is that we are not looking at a three-month project. You have a multi-year project. So we have an opportunity for longitudinal learning and an opportunity to also build very strong institutional data and knowledge systems. We've had this conversation over and over from different countries and their submissions, and really build strong communities of practice that can live beyond the project period. And as we have worked through the communities of practice, we already realize the strong bonds that exist between countries, and I think we want to continue nurturing it in a more structured manner. We have innovations. Rwanda shared very good innovations in digital health. How do we test and scale this? If we have a structured approach, it becomes easier. And that makes it possible for us to institutionalize this knowledge right beyond the project period. And finally, it was not just about the country, it's about the region, and it's about sharing the lessons that we are learning beyond the region to even inform financing and other global conversations. The next slide brings us to the components very quickly, just looking at what would our priorities look like, who are the stakeholders that are not in our conversations on a day-to-day basis but would facilitate learning, where will we get this knowledge that we want to learn from, or we want to package or disseminate or translate into policy and ultimately action. What would our activities look like at a country level, at a regional level? Are there concrete aspects that we can put in place to make sure that our plan is well structured? How do we resource this? What would our milestones look like? And what would our governance and feedback loops look like at the end of the day? I hope that by the time we come for the next track, we will be reporting progress in terms of learning in a more structured way. And I think tracking the evidence that is being generated as we implement the project and how this is being used in making decisions, I think is one of the hallmarks of success. The next slide looks at some of the mechanisms that can help us address these gaps in a structured manner, such as the RAC that we are currently having, that can help to guide and endorse this agenda at the regional level, and also the leadership that is present support this at country level. We've talked about the COPs and their central role in peer-to-peer learning. We also have other mechanisms like having a hub that's going to support us, and also making sure that as we structure our agenda and identify our priorities, these are aligned to the priority project development objectives, and also building capacity in areas which we will identify as high demand, and looking at the role of the regional organizations and how to showcase country exemplars, because each of the countries represented here actually has a best practice that they can share with another. But how do we package this? And of course, that comes with the possibility of establishing centers of excellence in different countries based on what they do best. And of course, looking at the whole aspect of partnership to enhance knowledge and learning and not really duplicate the efforts. If we move to the next slide, we look at the generation of this knowledge, working towards joint protocols, having standard research design, considering multi-country studies across thematic areas that affect many of us or multiple countries. How do we assure that the data that's being collected is good quality and accurate, and ultimately ensuring that there's equity and inclusivity in all the work that we do? The next slide refers to packaging and disseminating this information. How do we standardize our knowledge products, our reports, the policy briefs that will come out of countries, the publications that we will see? Where do we archive the information? Are we going to have a digital hub that would want to see that is managed at the regional level? How do we disseminate? Because information that is packaged and not disseminated ultimately doesn't help. And how do we feedback and learn? How do we build the capacity? And how do we enable South-to-South learning, and finally incentivize the learning so that it doesn't become a burden, but we all are striving towards wanting to learn and contribute to the shared process. So definitely, if you move ahead, we will need to monitor this as we institutionalize. We will need to define the outputs that we want to track. We also would want to see how we can document evidence and how this is being acted on. Then there's a place of visibility and partnership. Who do we share the successes with? And sometimes it's not just the success, but there are times we fail, and the strongest lessons also come out of failure. So how do we make sure that this actually happens? And ultimately, the place of sustainability through better coordination of the whole learning process. The next slide refers to identifying some flagship areas that would impact on the project, also impact at country level outcomes, and also will be sustainable in the long run. And from the discussions we have had since yesterday and today, there's been a lot of conversation around collaborative surveillance. The communities of practice had also identified this as a possible area, and surveillance from a One Health perspective. Digital health has been big in all the conversations that we've had right through the year and even over the last 1.5 days. This morning, we had a lot of conversation around local manufacturing and how do we best go about this. And then there's a big conversation around reshaping human resources for health to support health emergency preparedness, response, and resilience. This is not limiting. It's open in terms of contribution, depending on what resonates best with the countries, but these have been identified as possible areas that can be addressed as flagship areas. And these flagship areas, for us to be able to effectively handle them, we need to go into a process where this will be, we understand that we co-own the process in terms of building the learning agenda. It is not left to the countries, it is not left to the regional organizations, but actually is a shared process. And before I move to this, I just want to emphasize that this is not new. Even the topics that have been suggested as possible to be taken forward as a flagship area, they're not new. This is what is reflected in our country plans, in our annual work plans, but we just want to flag them out so that we can be able to better document the learning journey as we implement interventions across these areas. The next slide touches on financing this and looking at it as a shared responsibility between both the countries and the regional organization. The place of ownership and co-creation becomes really, really important. How do we make sure that as we allocate resources to other areas of intervention, like we said, we deliberately plan for this as well. We also allocate resources to support knowledge generation and its dissemination and ultimate use. And we believe that the communities of practice that are already very active can serve as very strong champions to be able to draw in resources even beyond the project, as well as technical expertise. And that will be possible by leveraging the partners within and across the different countries. So the final slide presents us with some issues that we would want to reflect on this evening as we bring our RAC to a close. A lot of information has come in, but how we handle what is coming in through all these consultations is going to determine how the MPA evolves over time and ultimately how we close this chapter once all has been said and done. And I want to invite Dr. Wako just to take us through this last slide on the aspect that we can collectively reflect on, even as we share our reflections on the previous slides that I have presented. Thank you.
It's okay. Thank you so much, Dr. Evelyn, for that excellent presentation. I'm sure you've really given a very good explanation into the Learning Agenda Initiative. So as we flag the last slide, I would wish that the IT team please help us to flag the last slide. And then we can come back to round of plenary. I suggest we pick a few questions, get some your thoughts around this, and then we'll have reflection by the PS. So the country PSS will have reflections much later, and of course that piece will be chaired by the Honorable PS from Zambia. So meanwhile, these are some of the issues we are trying to basically wrap our minds around our heads so that we try to really, get ourselves understand the learning agenda. But I think one thing that Dr. Evelyn has really clearly emphasized is that learning agenda is not anything new. These are some of the activities, some of the interventions that we have been implementing. There are some of those, technical assistance that we've been implementing, supporting the countries, as well as the activities that are being implemented at the country level. So if you look at the best buys, of course, we are going to revisit those slides. Those are some of the issues that will be coming in. So, but the question here is, as we reflect, so how do we ensure that there's that buy-in and, of course, ownership at the country level? We have such an interesting 4 different kind of learning agendas that we have, the countries actually proposed during and endorsed during the pre-RAC, which just happened on Monday. So a lot of investments will go into this. How can we look back 5 years down the line, 6 years down the line, and then of course have some level of sustainability around this? How can we take it beyond this program? So, and that brings in the question of ownership by the government, and what is the role of the countries on this? And of course, then again, for the regional level, of course, we play the complementary support to ensure and supporting the countries through technical assistance, and of course, linking with also other continental or regional experts in, of course, around the globe. So, and the other aspect is embedding and financing of the learning agenda. So, and this is, most times, many things boil down to financial aspects. But of course, it's not always 100%. Sometimes you can have low-hanging fruits, that, and of course, through collaborative mechanisms, you can always have initiatives, being stretched to ownership, or through, of course, embedding in the national plans and all that, which of course, again, narrows down to domestic financing. But nonetheless, what is the role of the countries in financing these concepts? And of course, then, the aspect of monitoring the indicators, and of course, the aspect of dissemination and visibility. Just before we go into this, I suggest we pick a few maybe questions, and then we flag the slides on the flagship. We have 4 major flagship areas or areas of focus that have strongly come out from the pre-RAC and of course from the conversation with the countries. So perhaps we can still flag that before we come into this. Just back. So ahead, you can go back. Slightly back. Yes. So just to kind of refresh our minds on this, these are the 4 areas that have really strongly come out as points of learning, of course, that are already happening in the country, but and then basically that we have basically found it necessary to basically focus on them. Best buys and in collaborative surveillance through One Health approach, closing health gaps with focus on digital health, local manufacturing, of course, through with a focus on regional economies of scale, then reshaping human resource for health to support health emergency program. So what are your reflections around this? I'll be happy to get your suggestions, your thoughts around this, of course, before we again flip the project, the slide on financing. Feel free to raise your hand. Okay. Do I see? I know we are over close to 100 here, so I hope you are not missing any hand. Okay. So I guess this is okay. I can see at the back we have. You can move to a closer mic.
Thank you. Yes, Neil Squires from IAMFI here. I'm just interested to know whether the monitoring tools that are developed for this program will link to the monitoring processes that NPHIs are being encouraged to undertake by others. So, for example, Africa CDC has developed a monitoring tool for NPHI maturity, and some of the issues that have been listed here may well link to that maturity assessment. So rather than sort of duplicating tools or metrics that are already in the process of development, is it possible to align the tools that are being developed and the work that's being done with those existing frameworks so that we don't have to increase the workload and can rationalize the things that are being done? So it could be possible because a number of the elements of the maturity assessment tool are linked to the HEPA framework, including strengthening surveillance capability and collaborative surveillance. So I just think that would produce a useful synergy that would simplify the tasks for NPHIs.
Thank you so much. That's a very important question for sure. So, Dr. Evelyn, you're taking notes. Any question or reflection, comment? And also feel free to give any, comment. It doesn't necessarily have to be a question. Okay? So as you think through that, let's allow Dr. Evelyn to respond to that question, and then probably you can just maybe go to the next slide if there are no further questions.
Yeah, thank you for that question. And I think if you recall, one of the strong points I mentioned, or the gaps I mentioned, was in coordination and partnerships. And I think we recognize that as an important aspect to ensure that there's no duplication and there's alignment to existing or ongoing pieces of work. And that also came out very strongly during the pre-RAC meeting which we had with the project implementing units. So there's definitely going to be time to look at what is in existence so that we build on it and we don't necessarily overload countries with information or processes that are duplicative. Thank you.
You can just sit there, sure. Thank you so much, Dr. Evelyn. So, yeah, and thank you for that response. So I don't see any hand. Probably we can move to the next slide. But just to confirm, if there are any questions, feel free to raise your hand. And of course, you can interject at any point. So, so you can take us back to the finance. Yeah, and so you can see again, as we've said, so as we've correctly said, those four elements or the areas, focus is what has strongly come out as areas of interest across our, HEPA countries. So, but then the next question is about financing. And of course, the different entities have specific roles in how they can support the implementation of learning agenda. The regional entities provide complementary support through the funding basket they do have. Of course, through the technical assistance, providing training, expertise, and all that. And then you can project this. So, but then at the country level, how can we ensure that there's that sustainability through financing? So I wish to have your thoughts around this, and feel free to give whatever thoughts that you think, or even comments or questions. Okay. So, well, I know you are still probably having thoughts around this, but then I am sure at some point we are going to have reflection by our permanent secretaries for each of the country to address these issues. And I think essentially the major expectation here is we need to endorse, we need to give our submission on this. Are we in concurrence that these we accept and we concur with the proposed flagship areas for learning agenda? I think that's the main thing. And when it comes to implementation, of course, we can always have very explicit modalities into having this implementation. Of course, that will be co-shared, and of course co-implemented by all the entities, of course, and countries playing the front role in as far as implementation is concerned. So I don't know whether there are any further comments before we move to the next stage of getting statements, reflection from the permanent secretaries. And any point of emphasis? Okay. Any further clarification? So 1, 2, and 3. So I don't see, I think it looks like we have a good plan. And I think that is, and I think what you also need to understand is on Monday we had, countries, discussion with the countries, and these are the 4 areas that countries endorsed at the technical level in the meeting of the PIUs, the heads of the project implementation unit. So with that, I don't know, Evelyn, anything you want to emphasize? Yeah, thank you so much. So with this, I want to hand over to the Zambia team and probably Matilda to welcome the peers so that the peers can take us through points of reflection and endorsement of the flagship areas and of course essentially the learning agenda, so that then we can move to the next next step. I think that's where we are in as far as this is concerned. Thank you so much for your for this discussion and for this session. Please put your hands together for Dr. Evelyn.
Thank you so much for that wonderful presentation. It is now my honor and privilege to invite our Permanent Secretary for the Ministry of Health, Permanent Secretary Technical Services, to take up this role to solicit input, submissions from other Permanent Secretaries. PSA. Maybe we can beam the flagship item so that the permanent secretaries are guided.
Thank you very much, Dr. Simpungwe, and the moderator for this afternoon. Colleagues, we have a slide there that this community of practice have identified priority areas or topics for short, mid, and long-term implementation or consideration in our country efforts in order for us to say that our countries are health emergency prepared and we are able to respond and still remain resilient as we respond to a health emergency or a shock. We are still able to immunize our children. So we are coming from an era where COVID disturbed even the immunization coverage. So when we say resilience, many things keep going through my mind and I say, what kind of health systems are we targeting to create? Where is that document that we should be able to adopt and adapt and begin to score ourselves on a path which determines how you can be declared health emergency prepared, and you are able to respond and still remain resilient. So colleagues, I just mention one after another. So prepare yourselves, my PS colleagues, because I'll just go one after another so that we all can speak. Now, because I can't see this side, I'll stand in the middle a little bit. So I'll start with Saltome. If you have any contribution or any reaction to those 4 areas, if you want to add one, which you feel we have forgotten, please.
Tínhamos visto e tínhamos concordado, da nossa parte concordamos com aquilo que está ali escrito. Já tínhamos analisado aqui na última reunião também que tivemos. E tudo...
Thank you very much. Next is Rwanda.
Thank you, Chair. For us also, we agree with the proposal, and we are committed to implement all this proposal. And Rwanda is already in a good way, and I hope that for the next year meeting, we see a good achievement. Thank you.
Thank you very much. I thought that Rwanda could add a 5th point there, which talks about either capacity building or knowledge transferring. Food for thought, PSs. Next is it okay now? He's back. Mozambique. Reflections. We've got, okay, let me skip you for now. Let me skip you, settle down. The next is, that's Malawi. Yes, Malawi.
Thank you very much. Malawi is in agreement with the 4 areas that have been highlighted in the emergency response. We realize the strength that other countries already have in the particular areas. I mean, digital health, manufacturing. There are some specific countries we've learned that are already ahead, and we would like to learn from them. While we look at all this, an example of local manufacturing is when you're looking at economies of scale, is to look at the population being served. I think it's probably close to 400 million people that we are looking at when you look at these countries. So it's not small, it's quite a big population. The market is there. I think the issue is, defining who does what. I think that was the issue that we learned. In the emergency space, as we look at all those 4 areas, I think what has been highlighted is the uniqueness of the effect of these emergencies to gender, especially women and children. I think that was flagged out. The same toilet that can be used by a man may not be convenient for a lady in terms of an emergency. We discussed that when we were looking at other building blocks of emergency preparedness and response. So gender came out clearly, children came out clearly. The whole space of financing and sustainability, how do we take some of these issues into school curricula so that they're no longer becoming projects, but they become culture? and that we can maintain them with time. So there are aspects that we would want to bring them to review some of our curricula and or contribute to the curricular development. And one example, Chair, was when you're looking at digital health. So as we do preschool training, end-to-end tracking of medicines can be a simulation lab in a medical school. So we could do simulation labs, for example, in medical schools, so that people start learning right away, and it becomes culture more than workshops and still waiting for World Bank to support us. Thank you, Chair.
Thank you very much, Malawi, for getting something into this meeting, something that I always worry about. I am not sure whether you did observe when we were looking at the slide for achievements. And in those achievements, we see that almost all of them that we have achieved as countries are things that are around money in people's pockets. Are you following what I'm saying? So there is a disease on the continent, it looks like, a new one, that we have decided to start calling pediamitis. There is nothing that succeeds without pediems. So that is what we must try and run away from. Now, I like what Malawi has said. If we build systems from when you are still very young, unlike trying to build a system into an old system. I think somewhere it is said that don't put new wine in an old skin, or don't patch up an old cloth with a new one, because there could be issues of rejection. Next is Kenya.
Thank you, PS, thank you, Chair. I think also as Kenya, we do endorse the 4-point agenda of learning agenda. We were just thinking that maybe the issue of climate change didn't come out strongly. We believe maybe it's subsumed within One Health. But I think there's a lot to learn, and a lot of learning that would need to happen around how countries are tackling climate change and health within the context, of course, of the project. Otherwise, for our side, we in terms of how is going to move forward, I don't know many other countries, but we do have knowledge management units within the ministries of health. So our hope is that we will integrate all the learning agenda within the broader knowledge management portfolio of the Ministry of Health, and so we will collaborate between ourselves and knowledge management units in the Ministry of Health, and we will leverage on the resources that are in the project. In the project management, I think, aspect, we have resources for monitoring and evaluation and also knowledge management. We do believe that what would happen. And then I think lastly, the question of, I know we've talked about having a repository, regional repository. I know this is something that, we've had a discussion in other regional bodies. In anticipation, of course, that this learning agenda will be data-driven and evidence-based, it means we'll have to use a lot of data from countries. So I know sometimes data is a very sensitive issue. Countries are sometimes worried about data security. And when we share these platforms at a regional level, what are the safeguards that are there? On the other hand, of course, I'm happy that I think all of us belong either to IGAD or EXA or both. And we may have already agreements around data sharing already. If they are not there, maybe some MOUs might need to be strengthened so that countries that are willing and able to share this data. I say this actually with very careful consideration because in Kenya we have a very strict data protection act. So sometimes even if you share somebody's image in a website, somebody can actually sue you for it. So I think navigating the legal minefields around data sharing, knowledge sharing, I think will be something that we'll have to deal with. Otherwise, I think we offer, as Kenya, we offer ourselves. We do lead the COP on local manufacturing. So to the extent that we are able, we commit our availability to be used as a learning platform on knowledge management and many other things as well. Thank you, Chair.
Thank you very much, Kenya, for re-emphasizing the caution around data sharing. But creating data repositories and having dashboards would benefit all of us, and local manufacturing. Next, Ethiopia.
Thank you very much. Those collaborative surveillance and also in broader sense of One Health, including these outbreak investigation and the response and the preparedness, and One Health is a priority in my country, and also the digital health, manufacturing, and the workforce is a priority, and we have already included this one into the national plan and also into our national action plan for health security. This is not only the Minister of Health, but also in the key One Health sectors, and agriculture, animal health, and wildlife, and environment. So these are already a priority for a country, and we are also a center of excellence in many of those areas, including the workforce. So the very important issue as a developing country, strategic resource mobilization and the partnership is also very, very important and critical for obvious reason. And to my view, we need to include also, we have said a lot about this cross-border and the collaboration, cross-border collaboration. And also when you say One Health, it's not only a surveillance, should be in a broader sense. So cross-border collaboration and the holistic One Health initiative should come out as a strong recommendation of this meeting. And thank you very much.
Thank you, Ethiopia, for emphasizing, yes, indeed, on cross-border health and using the One Health approach. I think if you look at the four, you are strengthening the first one that is there. I still want us to continuously think about, when you look at these four, I hope that is not filtering in our minds to create trainings, documents, courses on how to train people on how to use digital tools, to create, packages on how to train people. Sometimes we need to buy things that strengthen the system itself. So in terms of border health, all of us have traveled, and we need the health section in all the borders, most of our borders, is probably the weakest if you look at border control. In our countries, the health section could be the weakest. And so we need to see how we strengthen that border health and then connect it to the surveillance systems of the country so that we are able to know how many came through our borders and recorded the fever and where they are going, what samples were taken, which lab did those samples go to, so that in case we find something, we're able to reach that particular individual. Next country. These 3 countries that are left, I haven't heard any of the previous ones talk about financing. It was also a reflection on one of the slides that was shown by the doc there. So maybe you could touch a little bit on financing and see what reflections we have. So DR Congo. Okay, Mozambique.
Obrigado. Bom, à semelhança dos que me antecederam, nós subscrevemos a proposta que foi apresentada. Nós acreditamos que elas estão descritas num modelo que permite tocar, abordar desafios que são, de certa forma, comuns nos vários países. E se nós tivermos estas questões na agenda, penso que poderemos ter questões comuns para discutir, mas também estaremos a contribuir para os objetivos, não é? Os objetivos de desenvolvimento do próprio projeto. Então, e por este motivo, nós concordamos. Adicionalmente, pensamos que devemos, eventualmente, no contexto da operacionalização, garantir que temos alguns indicadores específicos que nos vão ajudar a medir a nossa ação, olhando para o MPA, naturalmente olhando, por exemplo, para recursos humanos, que é um dos pontos que foi aqui levantado. Teremos que ver como vamos avaliar não só a quantidade, mas também a qualidade daquilo que estaremos a produzir. Aí temos que olhar para aspectos de sustentabilidade. Penso que a sustentabilidade deve estar, portanto, deve ser um aspecto a ter em conta em todos os momentos da nossa caminhada nesta fase. Penso que eram estes os nossos comentários neste momento. Obrigado.
Thank you, Mozambique. We quickly now go to DR Congo.
Merci. Merci beaucoup, monsieur le modérateur, pour m'avoir donné la parole. En fait, pour nous, la RDC, c'est plutôt un grand plaisir pour nous de prendre part à ces activités du comité consultatif régional dans les cadres de projets dans les cadres du projet préparation, réponse et résilience aux urgences sanitaires, de manière à pouvoir renforcer les systèmes de santé. Alors, nous avons suffisamment été aiguisés par rapport à la nécessité de renforcer les systèmes de santé. De manière à ce qu'on puisse être capable de bien gérer les événements, les incidents, les épidémies qui surviennent dans notre pays. La RDC a déjà
J'ai un système qui est en place avec un Institut national de santé publique et avec un centre d'opération d'urgence en santé publique qui nous permettent maintenant de pouvoir détecter en moindre temps l'épidémie quand elle survient et de pouvoir riposter. C'est comme ça que nous venons de contenir une épidémie à virus Ebola dans une seule zone de santé. Et dans moins de 10 jours, le ministre de la Santé publique va déclarer la fin de cette épidémie. Nous avons aussi beaucoup d'expérience en matière de production locale de médicaments et même de vaccins. Mais cependant, il faut dire que nous avons besoin d'un appui en termes de budget pour continuer à bien surveiller ces différents incidents au niveau de notre pays. Nous avons aussi besoin de pouvoir être appuyés pour organiser la surveillance à base communautaire, dont nous aurons besoin sûrement de l'appui de pays qui ont une expérience. Comme on a dit ici, il y a le Kenya, je pense, Éthiopie aussi. Nous aurons aussi besoin de poursuivre la numérisation, la numérisation de nos services, surtout les services qui sont impliqués dans la gestion des épidémies et autres catastrophes dans notre pays. Alors, nous sommes en train de vouloir également développer une base de données avec des personnels outillés en matière de préparation, riposte aux épidémies. Alors, il y a la grande question aussi en matière de coordination. Nous pensons qu'avec ce que nous avons appris ici, nous avons besoin des orientations et des directives claires pour mettre en place un comité national de pilotage dans le cadre de ce projet ici, de manière à ce que nous puissions aussi garantir la prédiction et l'anticipation. Nous sommes intéressés également à pouvoir avoir la maîtrise sur les maladies non transmissibles et la santé mentale en situation d'urgence. Et là aussi, il y a la nécessité de définir des stratégies, mais aussi de digitaliser les suivis des patients. Voilà, je pense qu'à ce stade, nous disons que nous avons beaucoup appris de ces assises et au retour au pays, nous allons faire en sorte que la plupart des recommandations issues de ces assises puissent être mises en application. Et nous souhaitons également que l'IGAD et AXA, de temps en temps, qui puissent aussi envoyer leurs experts pour nous accompagner sur le terrain en République démocratique du Congo. Merci beaucoup.
Thank you very much. PS from DR Congo, and I think he has raised important aspects, especially his last few remarks, where he's emphasized on integration and also capacity building or knowledge sharing. So those countries that are strong in certain areas, we could share how we got there with all of us, so that we can create those pool systems where we can tap that knowledge from. And digitization, local manufacturing, but also preparedness. What did DR Congo do this time around to make sure that the Ebola was confined in that one hospital from the time it broke out? So these are lessons that they can also share to all of us. We have seen something like this here in Zambia with our cholera, where we are ensuring that if we identify one case, we should not get beyond 12 in that region of the country. So there are many areas where we can learn from one another. And this time around, I want to say, Burundi, you should also say something, but just remember that Lake Tanganyika is in Zambia.
Okay, thank you very much, moderator, for that. To remember me that neighbor Lake Tanganyika, that's make Zambia a bordering country with Burundi, free water, and of course the fishes. Okay, thank you very much. So. In the interest of the linguistic sovereignty, let me come back to French. Alors, le Burundi, nous prenons acte de la synthèse des domaines clés et à haut impact et qui dégagent un impact durable et à long terme, que ce soit au niveau de l'approche collaborative de la surveillance selon l'approche One Health, que ce soit au niveau des actions à mener pour dégager le gap et résoudre le problème avec l'approche santé digitale, que ce soit la solidarité continentale dans le domaine de production locale des intrants pour une économie régionale. Cependant, je dois ajouter quelques éléments qui ont été relevés par le Burundi dans la gestion du projet. C'est que au niveau de notre pays, nous avons souligné un manque criant des ressources compétentes en matière de changement climatique et résilience dans la gestion des urgences sanitaires, mais aussi l'intégration genre dans le domaine de gestion des urgences sanitaires. Voilà les deux domaines où nous sollicitons une assistance technique pour bien remorquer les interventions de façon optimale. Voilà les deux points que je voudrais ajouter. Du reste, je vous remercie, je remercie cette initiative régionale qui nous a permis de participer dans dans cette réunion du comité consultatif. Merci.
Thank you very much, Burundi. And I'm sure everyone has enjoyed their presence. And so we are equally grateful that you could come and join us. Finally, the table that has only one gender, Botswana.
Wow. Thank you, Chair. Thank you for all the other comments that have been made. It is important as we are sitting here thinking about health emergency preparedness and response and pondering on the priorities that we have come up with, to remember about what you spoke to, Chair, resilience of our health systems. Just how much are they able to withstand all the shocks? Because we know one shock after another is going to come. Climate change is making that even more clearer to us, that it is going to happen over and over again. And so how is it that we're able to keep the business of giving health to people going on even when we have emergencies? In that light, when I look at the priorities that we have put across us, I see that we have looked at data as a very important part of that, and digitalization will lead us to have more data that we can use swiftly. Local manufacturing, I would like to say that in us thinking about local manufacturing, in the learnings that we are going to do, let's be thinking about collaboration, harmonization, especially harmonization when it comes to regulation, our regulatory principles, because we have to regulate this manufacturing business that we are going into. In addition to that, how we orient our health systems, because in emergency preparedness and response, most of the diseases will start in the communities. As we are thinking about healthcare workers, we should be thinking about what has other countries done to ensure that there's enough public health workforce. We found out, I don't know about other countries' experiences, but we quickly found out during COVID in Botswana that we don't have enough public health workforce. We just have healthcare workers that we then quickly had to somehow make to be able to do public health work at the time of an emergency. So with all those, I do support the priorities that we have set forth today. And I believe as the project goes forward, we achieve some, or we find other ways, or we find some that would have to add to make sure that in the end, this is a project that takes us from one place and brings us somewhere, and we end up with a continent, if you may, that is resilient to all the shocks. I thank you.
Thank you very much. I am not going to say what I wanted to say. EXA, Health Community, IGAD, and the World Bank. This was country reflections, right? So you've heard what the countries have said, and Zambia, where is she? She's gone. Zambia, your reflections. Me, I'm the chair.
Thank you, Chair. Thank you, Chair, for this opportunity. As Zambia, I think we had a very good interaction period with other countries, and it was encouraging to learn that really we have a lot of things to learn from other countries. In particular, we took note of the AI tool that enable health workers conduct diagnosis in mental health, and we feel that is one of the practices that we can learn from as a country. And then we also found the discussion under manufacturing very, very encouraging, how some countries have taken up steps to support local manufacturing through ensuring that a percentage of commodities that are procured outside the countries, which are also available in country, are ring-fenced so that the local manufacturers also benefit. And I also found it interesting that there are also discussions to the effect that maybe increasing the import taxes for commodities that are locally available can also provide a comparative advantage to local manufacturers. So I think there are good lessons that we were able to implement in Zambia, and also what is encouraging that whatever we discuss PS, there's a country that is ahead of others. So we don't need to reinvent the wheel. We'll continue engaging with other countries. For manufacturing, we had good practices from Egypt, from Kenya, from Uganda, so we can learn from those. I submit.
Thank you very much. That completes the reflections from the countries. And at this time, maybe I need some structural adjustment. So what should I do now, moderator? Okay. At this point in time, I want to just say that we should always, as we implement this health emergency preparedness, response, and resilience multi-phase approach program, we should ask ourselves, what is that one or two key indicator that we need to track in order for us to say we are now prepared for any health emergency, or we have a good response, and as we respond, we won't break down. So I ask these simple questions because we need to think about things like this as we prepare our country plans and as we use the money that is being made available to us. And then, of course, we supervise our colleagues. A lot of times when you look at the plans, it's like there's a set template of business as usual. So there isn't much of thought process that goes in when you have opportunities like this. So this opportunity that is being created for us, we have to look at it and say, I'm being requested to actually create a system that I can predict that in this area of the country there could be this outbreak. Why? Because of what you are seeing on your dashboard. So if you've got a community, you've mapped out your country and you know where your communities are living, you know what kind of wash systems they have. Do they have running water? Do they have wells more than they have, piped water? Do they have more pit latrines versus flush toilets? So, and how many people are using these amenities? So you are able to predict that in this particular locality, I can have a disease outbreak, and interventions can be made so that we avert some of the things that might come as a result of us continuing as business as usual. So for me, this is what I think we must be doing. Let's use this opportunity to map up our countries in terms of where are the services, how are the people distributed around these services, what amenities are available for our people to use in wherever they are, so that we begin to link the determinants of health to disease outbreaks, and we can be able to predict better and design our responses better according to what our country data is showing. So that for me is very fundamental in these 4 areas that we have put there. Because of talking too much, I have forgotten the name, Dr. Waku. Dr. Waku. Dr. Waku is now coming to do, this will be the last presentation, I believe. So the stage now, the floor is yours, Dr. Waku. Please give us.
Thank you so much, PS. For sure, this is the last presentation. We'll try to wrap it up as soon as possible. IT support here. So, So you can project the slides on recommendation. So Bob, you can check the IT. Bob, you can check on, send to you this results, slides on recommendation. So basically we've just put together some points for us as takeaways from this, from the 3rd RAC, just basically so that we can track going forward some of the recommendations and of course takeaways that we have been putting together for the last, actually, from pre-RAC. I'm not sure whether you have located, Bob. Yeah, excellent. So yeah, thank you so much. So I'll quickly take you through these recommendations. I'll try to be as brief as possible so that we don't really have to spend a lot of time on some of the basics. So, so essentially we kind of categorize some of these recommendations based on some thematic areas. So the first one is basically focused on the coordination and implementation of the health emergency program. Some of the key issues that came out were essentially issues on fiscal and procurement processes. Apparently, there are a number of delays that are occasioned either by internal physical process, especially at the country level, and also procurement process. Then need to fast track establishment of the PIU. We found that a number of countries have not established PIUs, that is Project Implementation Unit. So, and then it becomes very difficult to really have that seamless and of course enhanced coordination of the project implementation without establishing PIU. And I think that will be a good lesson, especially for Mozambique and of course Botswana that are just joining this project. Need to fast track implementation requirements, of course, so that this does not lead to delays in initiating the project. And again, this is a good lesson to Botswana and Mozambique, then there's need for joint planning between the countries and the regional entities. So apparently we've, as you realize, there's a lot of complementarity between the regional programs as well as the country level programs. So we need to see how we can have synchronized or essentially joint planning. And it's good enough. This is one of the subjects that was discussed during the closed door meeting. And of course, this need to have a planning cycle, and of course, ensure that this is calendarized. So enhancing advocacy for strong government ownership and long-term sustainability plans for this, for MPA project. There's continued, importance to ensure that there's integration of health emergency programs in the national plans. For example, the National Action for Public Health Security, I think this is coming out strongly again, and of course need to enhance, scale up advocacy for domestic financing, especially post, MPA program. So, and I think this discussion can always start, you don't necessarily have to wait for 2030 to initiate this conversation. Addressing cross-cutting issues, and one major cross-cutting issue that really runs through the entire program is the aspect of mainstreaming gender responsive interventions in the health emergency program. Next slide. On the National Public Health Institute, so we had discussions, this was one of our first plenary discussion, very successful conversation yesterday, which was so much focused on the policy dialogue, policy issues. So I think key 4 major issues came out, of course, among other raft of issues, and one, of course, includes strengthening multi-sectoral public health governance for NPHIs. And of course, ensuring that this is institutionalized in terms of coordination, and of course, in terms of linking with the ministries of health. Need to empower NPHIs and MOH with clear mandates, so that there's that very clear mandate between the ministries of health and of course, NPHIs, reinforcing primary health care PHC as priority for population health protection. They need to build resilient future health ready NPHIs with capacity that extends beyond emergency response. Next slide. So from here, you realize that we've gone through, thematic by thematic areas. So on workforce development, there's strong realization that we need to prioritize workforce strengthening and development. So some of the key issues that came out was FLTP. I think through and across all the countries, there's need to strengthen and establish FLTP, the 3 tiers, ensuring that for some of the countries which do have probably 1 or 2 tiers, there's need to ensure that we have the 3 tiers being supported and of course being strengthened within the countries. Establishing regional training hubs. The 2 key areas that came out was the FEM training. So some countries are already working on the initiative to have eFEM and also having FEM as a training hub for the region. So and then of course issues around lab systems as a hub within some of the countries, and of course issues around development of and implementation of regional pre-service curriculum guide for IPC and AMR. Next. On lab and surveillance systems, we just try to kind of categorize and really summarize this aspect. There are so many issues and specific recommendations that came out. But nonetheless, one of the key issues, of course, is on the collaborative surveillance. I think literally all the countries really emphasized on this as a recommendation. And of course, again, as you know, this has to be through a One Health approach. And of course, need to strengthen implementation of IHR instruments. Again, on lab, we have issues to support SLIMTA and accreditation pathways for lab, establishing and strengthening AMR surveillance systems. And of course, on the climate and health nexus, I think we repeatedly, what we realized during this year's RAC, there's a lot of emphasis on climate and health nexus. And I think the issues around integration of climate and health data has always really come out so strong. And of course, there are several initiatives at different, within the countries to see how, basically to address integration. Next slide. On local manufacturing, we picked 3 major key overarching issues. And of course, this includes strengthening governance, financing, and access to finance, of course, and enabling business environment. Of course, there are quite a number of issues around there which have been proposed, and good enough, these are key points that came out during the plenary panel discussion today. And this, of course, includes, access of some of these issues around governance and finance through government, development finance institutions, industries, development partners, of course, should jointly improve the governance and, of course, bankability of local manufacturers. One of the key things that I think has always been coming out on local manufacturing is the aspect of incentive. How government can incentivize and motivate local manufacturing through providing tax waivers and of course, developing industrial parks. We have countries that have initiatives around industrial park, which is a good initiative and, of course, motivation, and, of course, having issues around licensing and, of course, affordable utilities. Need to accelerate regional regulatory harmonization and capacity building. So through AMA, that is African Medicine Agency, the regional economic communities, as well as MRH programs and national regulatory authorities, there's need to expedite the development of harmonized regulatory pathways and enhancing NRS, and of course, advancing strategic partnership, technology adoption, and of course, skills development. Next. On cross-border collaboration, this is one of the panel discussion we've had today, which ran through the afternoon, early afternoon hours. And of course, these are some of the key, overarching issues that came out. And of course, this includes integrating, strengthening integration of cross-border surveillance and information sharing. And of course, in partnership with different initiatives or leveraging on different initiatives that are happening through the continent. Enhancing point of entry readiness through decentralized laboratory and multi-sectoral capacity. Then of course, institutionalizing community-based surveillance and cross-border community engagement, as well as building sustainable cross-border preparedness systems. Next. On the digital health, we majorly try to pack most of the recommendations into three major areas, and you realize that there's a lot of cross-cutting issues between digital health and surveillance system, and you realize that digital health is an enabler for surveillance system. So these issues include supporting a regional knowledge exchange platform, which are basically focused on digital workforce. Building should be integrated or considered in the existing or ongoing training programs. Sustainable investment in digital health systems and ensuring interoperability of the system. Then adopting and strengthening digital labs and surveillance, as well as focusing on digitalization of NCD and mental health tools. Next. So on the learning agenda, we try to basically pull some of those comments that were coming from our peers during the reflection, and we've tried to lump them within, essentially they fit within these four major overarching areas. So this, of course, includes, this need to institutionalize knowledge and learning through focus on these flagship areas, which includes best buys in collaborative surveillance through a One Health perspective. So some of the key issues that came out, of course, within the same context include climate change and health, cross-border collaboration, integration of gender in health emergencies. Then, of course, issues around closing health access gaps with focus on digital health, local manufacturing, with a focus on regional economies of scale, reshaping human resource for health to support health emergency preparedness and response program, then ensuring sustainability of a learning agenda. Well, I know that's one of the points for discussion through that we've had, a reflection of the PSS. And I think going forward from the discussion, what is coming out is that I think we need to further refine the modalities and mechanisms of financing the learning agenda. And of course, I think what is coming out clearly is that, of course, countries have, a huge role to play to ensure that the learning agenda is implemented. And of course, we need to probably focus now going forward on how the countries can come in to contribute on the learning agenda. And of course, for the regional entities, regional entities have responsibilities and roles to support the learning agenda again. So, and I think this probably can form some of the next steps going forward as we look forward into refining our thoughts around the learning agenda. So I think that is it. Next. Yeah, thank you so much. These are the takeaways from the third RAC. And unless there are any additions or any comments whatsoever, then I think that is it. And I submit. Thank you. Thank you so much.
Thank you so much, Dr. Waku. Do we have any more reflections? Any reflections? No reflections? Allow me to invite anyone with announcements. Any announcements before we go into the closing session?
So we have two announcements for tomorrow. So there are two activities scheduled for tomorrow. So one is the training on the workshop on health diplomacy, which is scheduled to take place at Legacy Hotel. The pickup will be at 7 a.m. And I think that is it. So the vehicles will be available here at Radisson to take you to Legacy Hotel where the workshop is taking place. The second event for tomorrow is field trip. So we have two field trips basically which have been scheduled and basically planned. One is to Zamra. The second one is to ZNPHI. So the vehicles, the pickup point will be Radisson Blue. The vehicles will be available to pick you up at 7:45. The event is for half a day. And registration is ongoing. Please make sure you register so that you can be considered for the pickup and of course for the logistics that follows the same. Thank you so much, and back to the chair. And probably just before the chair, we have, yeah, yes. So on every table, we have this QR code. I'm not sure whether you have it with the PSS. So, but I think the rest of the table. So this QR code, please scan it. This will take you to basically provide your contacts so that we can have your contacts for this third RAC. So ensure you fill that up. And then before we close, we have evaluation that will be coming up, which will be projected before we go, I think probably during the closing session. Thank you, and back to you.
Thank you so much. Allow me to invite Mr. Piri to take us through the last part of our program.
Good afternoon. Good afternoon. All right, thank you so much. We have come to the point, and I'm going to invite the following to come to the front and take up their seats. So we're going to start with IGAD. IGAD, please, you can come and take your seat. HC, World Bank, and our Permanent Secretary for the Republic of Zambia. Then Africa CDC. So yeah, we take. Thank you very much. With your permission, we are going to look at the screen. So we're supposed to have an evaluation. And so what you do is that you just look at it. We'll come back to it after the closing session. Okay, so that's the QR code. You can actually scan so that you give us that feedback. Ladies and gentlemen, the third Regional Advisory Committee RAC meeting is coming to a close, and at this juncture, I'm going to invite the people in front to give us their remarks to mark the end of the session. And to start with, allow me to invite IGAD to come and give us their remarks. And take note, just immediately after we have this closing session with the statements, we're going to go straight into a press conference. We're going to allow the media to ask the questions to the people seated on the high table. Thank you very much.
Thank you very much, our Master of Ceremony, for this closing session. Excellencies, our honorable permanent secretaries that are here in this house, the representatives, distinguished delegates, ladies and gentlemen, a very good afternoon, and I think let me first say congratulations to us this far for making us come to the close of the third Regional Advisory Committee meeting. And indeed, it gives me great and deep encouragement that one of the most important key reason for this regional initiative is the need for us to work together, to move together because of the shared vision and challenge that we find ourselves confronting. And of course, over the past 2-3 days, we have been here. We had the pre-RAC technical discussions. We had the main RAC discussions. And looking at the progress that has been shared over the last 2 days, it really affirms the commitment we all have to this initiative, which renews our collective resolve to safeguard the health and the resilience of our region. Of course, this has been possible with everyone's contribution. Particularly, I would like to really recognize our member states, our participating countries in this initiative. Your strategic leadership, your political commitment remain at the heart of the regional preparedness and resilience of this program. And of course, to the technical intergovernmental bodies, EXA, I think you are quite an important value partner in this initiative. And I'd like to really extend our deepest appreciation to you for being extremely collaborative, and your technical leadership and unwavering collaboration remains very critical for us. I also would like to recognize the World Bank. Indeed, the financing comes very timely to this initiative, and we truly, truly appreciate that wisdom that linked the resources to such an important cause that we have here. We truly appreciate all the partners, the Africa CDC, and all the strategic partnerships we have that has made this such a progressive initiative. Excellencies, I know this is something we've always had people say, disease is not, doesn't have a passport, doesn't need a visa to cross any border. And that means even the nature of our programming, our strategies needs to be responsive to the nature of how disease move across borders. That means we need to build systems that equally are not limited by the borders we have, and systems that can respond rapidly, and systems that can be easily coordinated through such a platform. And of course, we have seen from the discussions, the plenary, fantastic plenary sessions we had here, it was clearly we could see the call for us to reinforce and ensure that we don't have fragmented systems when it comes to our health systems. We need to open up and ensure joint planning linked to strong data to inform decisions. Even looking at the areas for learning, I'm happy that the question of data remains important in the areas that we need to look at to inform our programming. And one thing that I really want to appreciate is the fact that we are integrating learning within the implementation of this initiative. That means there are questions we want to find answers along the way as we move on. And where we have questions that we encounter in implementation through such kind of learning, we're able to find solutions for that. So it provides an operational kind of study embedded within the program, and I find that quite an innovative thing to do. The recommendations that were summarized, I think, are quite clear, and I really want to salute all the experts that put together, summarize all the discussions we've had over the last 2 days to come up with precise and concise recommendations that will form the basis or the outcome of our third RAC meeting. But let me say this. It's quite important that these recommendations truly mean something when it comes to following up after we leave here. I want to call upon all of us to really, really take these resolute recommendations we've made with the determination, commitment that is needed for us to move this initiative forward so that we can see its full realization of the purpose of its existence. I noted an interesting remark that was made by one of our permanent secretaries earlier. And I think it was of importance that even when we talk about health, emergency preparedness and response, there was the aspect of resilience that was put in there. I think that is very, very critical. Because one thing that is clear is that we are at a time where shocks have continued to increase in frequency and in terms of severity. When you look at our climate-related data, you look at our data from our surveillance systems, we are seeing frequency in the shocks that disrupt both economic activities and our health systems as well. So what does that mean in our programming? That means all programmers must infuse in an aspect of resilience building as an integral part of the solutions we undertake through our normal programming. And I want to really salute this initiative for including the aspect of resilience. And I think the question that the permanent secretary asked here on this floor is, how do we know that our systems are resilient? That means it can only be answered when we encounter a shock. And when a shock happens, that question becomes a reality. To what extent were you prepared? To what extent did you respond? Were you even aware that this shock was coming in terms of your preparedness, in terms of the early warning, and in terms of the surveillance? I think these are quite fundamental issues here. So with those, I think I want to again really extend our profound appreciation on behalf of IGAD and on behalf of His Excellency, our Executive Secretary. We really want to extend profound appreciation once again to Zambia for being a wonderful host. We really want to salute you and to all the member states that have been here, our partners. We look forward to further engagement in future, and we want to wish everybody the best of luck as we disperse from here. And may God bless you, and asante sana.
Thank you very much. IGAD stands for what? Ladies and gentlemen, IGAD stands for what? I wanted to hear those who say IGAD and others who say IGAD. The owner has said IGAD. Thank you very much, Executive Secretary, for those remarks. I proceed to have Africa CDC to give the remarks.
Thank you. The Director of Programs, Sir, the Ministry of Health Zambia Permanent Secretary Technical Services, Dr. Kennedy Lishimpi, the Government of Zambia officials, our officials from the member states, permanent secretaries, directors present, our esteemed representative from partner organization, the Director General, AXA Health Community, Dr. Ntuli Kapologwe. Ladies and gentlemen, all protocols observed. Good afternoon. Good afternoon. As we conclude this significant third regional advisory committee meeting of the AXA, on behalf of Africa CDC, I wish to express my sincere appreciation to the AXA Health community, member states, and our esteemed partners who have enriched discussions with technical depth, practical insights, and renewed commitment to a stronger health security architecture for our region. Throughout our engagement, one message has come through clearly. The health security of Africa will be shaped by the systems we build, the coordination we strengthen, and the solidarity we maintain across borders and sectors. Ladies and gentlemen, we have focused on the most pressing priorities for our region's health security, and together reaffirmed our shared commitment to building resilient and coordinated public health systems. First, we examined the urgent need to strengthen public health stewardship and capacities across our member states, recognizing that an integrated approach is not optional, it is essential. By aligning national strategies with regional platforms and with the Africa CDC's new public health order, we ensure that preparedness and response are not fragmented efforts, but cohesive, coordinated, and sustainable. Second, reflections on the lessons learned from the Mpox outbreaks, particularly the importance of the cross-border coordination. Ladies and gentlemen, while we celebrated progress in information sharing and joint investigations, as well as harmonized public health measures, we also acknowledged the gaps that persist. These experiences reaffirm that threats do not respect borders, and our responses must not either hasten the response that we do in our countries. We should strengthen cross-border platforms with central future preparedness as pathogens move freely, but resources, information, and decisions often do not. Our region's experience showed that shared risk require shared solutions. This underlines the value of regional solidarity and the need to formalize and strengthen cross-border public health platforms, ensuring that no country faces outbreaks alone. In addition, ladies and gentlemen, data sharing across countries remains one of our powerful tools.
to reinforce the principle of no country can achieve health security in isolation. Also, one of the most forward-looking discussions centered on Africa's ambition to expand local manufacturing on vaccines, diagnostics, and pharmaceuticals. We celebrated the progress made across our continent, from new manufacturing hubs to strengthened regulatory systems and growing political commitment. Accelerating health manufacturing offers Africa's greater autonomy, resilience, and the ability to respond rapidly to emergencies. Henceforth, across all these discussions, we clearly saw how our works aligns together with partners as well as the Agenda 2063, the Africa we want. Strong public health institutions, skilled workforce, increased local manufacturing, robust emergency preparedness, and deepened partnerships. We are not only talking about the new public health order, but we are actively supposed to implement this. Last but not least, my colleagues, we recognize the contribution of the One Team, One Plan, One Budget Continental IMST for mpox and even cholera outbreaks, a model that has strengthened coordination, streamlined resources, and improved response efficiency across the continent. It stands as a practical demonstration of what unified action can achieve. As I conclude, my dear colleagues, 3 priorities stand out as our collective way forward: to sustain and strengthen political commitment, to be building resilient and well-governed health systems, to invest in integrated public health capacities, from manufacturing and harnessing workforce development, even the community health workforce, to surveillance and emergency operations, to deepening regional solidarity and cross-border cooperation, ensuring that no member state faces public health emergencies alone. Let us take recommendations into implementation, into action. I will repeat, let us take recommendations into implementation and to action. Colleagues and partners, on behalf of Africa CDC, we thank you for your leadership, your expertise, and your unwavering dedication. Together, we are building a safer, stronger, and a more resilient Africa. I wish you safe travels, and I thank you. Good afternoon.
Recommendation, implementation, action. That's the voice of the Africa CDC. Now we proceed to get EXA HC Director General. Thank you, sir.
Zikomo. Dr. Kennedy Rishimpi, Permanent Secretary, Minister of Health, Zambia, on the technical services, and all PSCs here present, Dr. Ramesh from the World Bank, my sister from the Africa CDC, Dr. Anthony from IGAD, representative from all the organizations who are here today, partners, ladies and gentlemen, good evening. As we are coming to close of this very important Regional Advisory Committee, allow me to begin by thanking the Government of Republic of Zambia and the people of Zambia for the reception that have accorded to us since our arrival here in Lusaka. Secondly, I would like to extend our sincere thanks to IGAD, our co-host, with whom we worked very close to making sure that this activity becomes a success. I also like to register our sincere thanks to the World Bank, who have been able to support us financially and technically. And then to all of you, this gathering would have been made possible without your presence. I know people are quite very busy nowadays, with different commitments, but still you manage to set aside your time and be part of this very important platform where countries meet to discuss issues around health security and also come up with common resolutions to be implemented in the next 12 months. We, East, Central, and Southern Africa, we take this Regional Advisory Committee very seriously. And whatever was discussed here, from implementation of various components of our public health emergency preparedness, response, and resilience program, to the digital health, to the health and climate change, as well as local manufacturing capacity. We take all these components very seriously. And let's be assured that what we are going to do together with our colleagues from IGAD is to draw the action plan, which is going to be joint one. And that one is going to be a compass for us to be able to implement in the next 12 months. I therefore like also to take this opportunity to welcome on board our colleagues from the Republic of Botswana, as well as the Republic of Mozambique, with whom we shall start implementing this program from now to the next 5 years. Then I would like also to take this opportunity to actually commend again the colleagues from the World Bank with the flexibility, with the devotion they have shown towards this program. And we would also like to reaffirm our commitment to them that we will work hand in hand with IGAD, with other regional organizations and sub-regional organizations, in ensuring that these programs becomes a success. And I also would like to say that we as EXA, we would like to say and to provide our serious commitment to some other upcoming projects that, whether it's World Bank or any partner who is here today, who is going to be willing to work with us. On that note, I would like once again to thank the government of Zambia, IGAD, the World Bank, Africa CDC for the partnership and the collaboration that we are enduring as we move forward in making Africa a better place and safer place to live. I thank you.
Thank you very much, Director General, Eastern, Central, and Southern Africa Health Community. And happy 1 week old in Lusaka. Yes, thank you very much. So just an announcement, someone has lost eyeglass and laptop charger. That's an HP laptop charger. Please, if you see one, you can hand over to me. Now, we get to the World Bank, and I'm going to invite the country manager to come and address us. Thank you.
A very good afternoon to everybody. I'm going to start with an expression that I actually learned right here in Africa, which I find both efficient and effective. I stand here before you with all protocols duly and respectfully observed. I see a lot of drooping shoulders around me, including perhaps my own. And in order to make sure that you're not just listening to yet another speech from the podium, I'm going to invite you to join me in an activity. I believe that each of you has received, and I hope I'm right, a post-it note, which will be right there in front of you. And I would urge all of you to participate in this. If you could just take a moment or two to write down just one thing that you're going to initiate and which you're going to commit to, which you have learned based on what you have heard during the last 3 days of the RAC. It could be a new idea, it could be a new action or a to-do, it could be a new way of doing an old task, or it could be a determination to reach out to someone you have met during the last 3 days. So if you could kindly just put that down on that post-it note, and somebody will collect it from you. This is not just a bland exercise. It is something that I believe will lead to something tangible. So I'm just going to pause for a moment or two to allow you to put down your thoughts on those post-it notes. You can either identify yourselves on that post-it note, or you can just leave it anonymous. I don't think it matters. It's very encouraging to see all the heads of delegation joining in this, so thank you very much. Okay, so I hope you've had an opportunity to reflect and put down your thoughts, and it's just one thought that we want from each of you. I think the speakers before me have said most of what I would have wanted to say, and in that sense they've made my life easier. I'm going to be very brief. I think it is fair to say that we stand at the threshold of a huge opportunity within Eastern and Southern Africa and within the framework of the MPA on HEPRR to transform the health of our people. However, I think in order to seize this opportunity, I think we need to embrace, and I believe we have, through the commitment that I have seen over the last 2 or so years of the implementation of this project, even as new partners have joined us, to 5 pillars to guide our progress. The first one is collaboration, working jointly to strengthen health systems and health security, both the systems and processes, and to share solutions. The second one is coordination, to align efforts, policies, and resources across borders. The third is capacity building, to develop skills, infrastructure, and knowledge collectively. The fourth is communication, and this entails communication both within our countries, across the various levels of governance, across ministries, from government to communities and other stakeholders, but also externally, so that we are able to make the gains of this program more visible. The fifth one is actually connectivity. By sharing information, technology, so that we can create a regional network that can protect every citizen. And I honestly believe that if we can embrace these 5 pillars, we will see huge gains accrue to all of our people. And as you leave us to go back to your respective countries, I would like to keep I would like you to keep these 5 C's in mind as we move forward collectively. That said, I would like to echo the sentiment that was voiced by several before me. I would like to thank the government of Zambia and the people of Zambia for hosting us so graciously and for the excellent organization of this event over the last 3 days. I would like to thank all the development partners who have been gathered, who are gathered here and who have been working tirelessly with us through this process. I think it is this partnership which is going to shape the future of this effort and determine whether or not we succeed or fail. I would particularly like to take this opportunity to thank the PSS, the senior leadership of the Ministries of Health, who have spent the last 2 days with us, as well as the country delegations who have worked in the day prior in the pre-RAC. You have taken the time to reflect on a variety of things, to come to an agreement on the way forward, and I think that this is to our mutual benefit. I think we have made very important progress at this RAC. And I think we have all learned a lot in this process. I certainly have. And I look forward to a reinvigorated and an effective implementation of this program in the next few years of this. And I want to hark back to the message that I conveyed in the opening, that although we started off as a 7-year program, for many of us, we only have about 4 years left. And I think it is important for us to work even harder to make sure that we are able in this time to achieve the results that we have set out for ourselves. So with that, I wish everybody who has joined us here a safe trip back to your respective countries and look forward to a continued engagement on this important agenda. Thank you.
Okay, so I delayed a bit because I had to collect the papers on your behalf. You know, when World Bank asks you to write, don't forget to put the amount. Thank you so much. That's the lead specialist and acting manager, Health, Nutrition and Population Global Practice at the World Bank from Washington, D.C. Is that okay? Thank you so much. And at this juncture, ladies and gentlemen, traditionally, I'm going to invite the Director of Public Health, Ministry of Health of the Republic of Zambia, to invite the Permanent Secretary representing the government of the Republic of Zambia to close.
Thank you so much, PS. It's my honor and privilege to invite you to deliver the closing remarks. Thank you, sir.
So, Andrew, I see you have not collected from people this side. So before I close, collect. Okay, thank you very much. And distinguished ladies and gentlemen, dear participants, I want to recognize the permanent secretaries and the representatives of the permanent secretaries from our member states that are here. I do not take it for granted that you really found time to come, because our offices are extremely super busy. The representative of IGAD, Dr. Anthony Awira, Director General for Exa Health Community, Dr. Tuli Kapologwe, Dr. Ramesh Govindaraj from the World Bank, and my dear sister from the Africa CDC. May I simply say, ladies and gentlemen, members of the press, as we conclude this third Regional Advisory Committee meeting, I wish to express my sincere gratitude to all participants for your active engagement and valuable contributions. Your commitment to strengthening health systems and regional collaboration has been evident throughout our deliberations. On behalf of the government of the Republic of Zambia, I extend our deepest appreciation to IGAD, EXA, and the World Bank for choosing Zambia as the host for this important gathering this time around. It has been an honor for Zambia to host such an important event, convening under the Health Emergency Preparedness, Response and Resilience Program, a program that remains central to safeguarding the health and stability of our region. We are honored to have provided a platform for dialogue that will shape the future of health security and resilience in our region. Over the past 2 days, we have shared experiences, identified priorities, and agreed on actionable steps to enhance preparedness and response to public health threats. The presentations from countries and technical partners showcased meaningful strides, whether in strengthening public health emergency operation centers, improving surveillance and digital health systems, advancing the One Health integration, or enhancing laboratory capabilities and regulatory maturity. These achievements demonstrate the continued relevance and impact of the Health Emergency Preparedness, Response and Resilience Multi-Phase Approach Program and the determination of the country teams. These outcomes reflect our shared vision of a healthier, more resilient region. As Zambia, we reaffirm our commitment to implementing the recommendations urged upon and to work closely with IGAD, EXA Health Community, the World Bank, and all of you participating countries and partners to ensure that these decisions translate into tangible improvements for our communities. Excellencies, distinguished guests, delegates, ladies and gentlemen, let us leave this meeting with renewed determination to turn our discussions into concrete actions and future improvements on this platform. Together, through solidarity and partnership, we can overcome the challenges before us and build a stronger, healthier system for all of us to live as one united people. Thank you once again for your dedication and collaboration. I wish you safe travels and continued success in your endeavors in each of your countries. Ladies and gentlemen, on behalf of the Ministry of Health and the government of Zambia, I would like to declare this meeting officially closed. Thank you very much.
Thank you very much. That's the Republic of Zambia speaking in closing this important Third Regional Advisory Committee, RAC meeting here in Lusaka, Zambia. And for the vote of thanks, you know, thanks in our local language is zikomo. So instead of having someone to give us a vote of thanks, I want all of you to stand up and say zikomo. Yes, all of us together to mark the end of the Third Regional Advisory Committee meeting here in Lusaka. So all of us in unison, everyone seated, please we are giving a vote of thanks with this one word, Zikomo. Please remember that very well. Zikomo. Washington, I'll give you my number after this. Thank you very much, ladies and gentlemen. But before you go, I'm going to ask that a simple exercise is just shown to us how we are going to evaluate just for 3 minutes. And I'm going to ask Bob to come and take us through, even as I...
Maybe, thank you so much, moderator. As Bob, I think the evaluation has already been done. But just to confirm from Bob, meanwhile, the permanent secretaries, in case you have not been facilitated, please just remain behind just to confirm your logistical preparation. Anything, Bob, on evaluation? Okay. Thank you so much. I think we are done, and the high table, you are free. Sorry for holding you back. You are free to climb down. Yeah, down. Thank you.
Thank you so much. As we finalize, ladies and gentlemen, I want to ask that if you want to access the resources, you'll go to the website, racmeeting.forum, go to the resources section. I will ask you go to the resources section and choose between the gallery and the presentations. I will ask that you click on the presentations. When you click on the presentations, you'll find there both for the pre-RAC and the RAC. Otherwise, thank you very much.
Sorry, ladies and gentlemen, before we go, whilst we are upstanding, I will invite all of us to sing the Zambian national anthem. PA, please help us. We remain standing as we sing the Zambian national anthem. Then thereafter, immediately after the national anthem, the high table, you step forward so that we just have that interaction with the press. So we are on standby for the Zambian national anthem. So before we go to the national anthem, shall we pray? We thank you, Lord, for this RAC. Thank you for all that we have said in this place and promised ourselves. We pray that God, as we come to the end, you go before all of us. Thank you for hearing us. In Jesus' name we pray. Amen. So, national anthem, please. the tea, but high table, please, you have to remain behind just for a short interaction with the press. Thank you. So colleagues from the press, please, you can come forward. Colleagues from the press, please, you can come forward. Media, please, we have to. Colleagues from the press, you have to move forward because of the interaction.